Good morning. I'm a clinical pathologist. I know that a lot of you here for the POLA course are going for the anatomic boards, is that correct? So you usually tell people what their animals died of. We tell them what they're going to die from in the future. So I thought today we would cover things at sort of a leisurely pace. My intention is to go through red cells, white cells, clinical chemistry of liver, and we'll do some hemostasis, and we'll take some time and work some cases, because I know on the ClinPath portion of the anatomic exam they always give you these cases, and you're in a quandary. How do I handle these things? And I'll try to work you through some of those today. So we'll start out this morning with red cells. And everything has to have a fancy name, you know, if you're writing a book. So instead of just saying red cells, they call that the erythron, white cells, the leucon, platelets and megakaryocytes, the thrombons. So that you got to get into the lingo. Most of my comments will be related to mammalian species, but I'll interject some things on some other animal species as we go along. I've been very fortunate in my career because I work with anything that walks, crawls, or flies except my friends. Occasionally I work on them on the side. So I'll throw in some things about fish and reptiles and so forth as we proceed. But as far as mammalian hematopoiesis goes, this process begins in the embryo, in the yolk sac of the embryo, and there's some very primitive stem cells that will circulate and begin to populate various tissues. They're going to populate lymphoid tissues and other organs. By the time fetal development is fairly well advanced, the major hematopoietic organ actually is the liver. Shortly thereafter, the spleen. Notice that the medullary cavities of the bone in the bones don't begin to form until later in gestation, so they take over relatively late in hematopoietic activity. And as far as the bone marrow goes, most of the hematopoietic cells are there producing red cells, white cells, and megakaryocytes that make platelets. The exception are the lymphocytes. The bone marrow is considered the bursal equivalent for B cell production, initial B cell production, but most of the lymphocytes are produced in the peripheral lymphoid tissues, and I'll address that in a little more detail later this morning. By the time of birth, the marrow of almost all the bones in the body is involved in active hematopoiesis. The lymphoid tissues are producing the lymphocytes. Sites of hematopoiesis may vary with the animal species. In mammals, most of the hematopoietic cells, again, are going to be produced in the bone marrow. The exception being very young animals, newborn, you may find residual extramedullary hematopoiesis in liver and in spleen. In mammals, all of the blood cell production in the marrow is extrasinusoidal in the parenchyma. If we consider birds, birds are animals of a different sort. They have bone marrow where most of the hematopoietic cells are formed. The granulocytes are produced in the bone marrow parenchyma, granulocytes only. The sinusoidal spaces are where the erythrocytes are produced, and also the thrombocytes, which are the avian equivalent of mammalian platelets. And I might say that although we use terms like thrombocytosis in mammals, platelets are just particles of shed cytoplasm from megakaryocytes in mammals. But in birds, you have a true thrombocyte. Cyte equals cell. A cell has a nucleus. So in birds, the thrombocytes are nucleated. Lymphoid cells in birds are produced. The primary organs, as you know, are the thymus, and for T cells, bursa of Fabricius for B cells, and there are peripheral lymphoid aggregates in birds. A lot of lymphoid production in areas like spleen, but birds do not have lymph nodes. in fish have no bone marrow, so their blood cell production is primarily in the anterior kidney, and also blood cells are produced in the spleen. I thought I would show a histologic section. I do histopathology as well as clinical pathology, and give you a close-up view of a fish anterior kidney. This is a renal tubule, and these are forming hematopoietic cells. All right, back to mammals then. In the adult, most of the blood cell production is going to be in the axial skeleton. So think ribs, sternibra, vertebra, pelvis. Also in the proximal long bones. And the lymphoid cells are going to be produced in the lymphoid tissues. Now the current concept that you need to keep in mind as far as mammalian lymphoid production is that the primary organs are the thymus for T cells, the bone marrow for B cell, initial B cell production. The bone marrow again being the bursal equivalent. Once the initial cell production or lymphoid production of T and B cells are produced in those sites, then those cells will seed the secondary lymphoid organs. So you have things like lymph nodes, spleen, tonsils, gut-associated lymphoid tissue, bronchial-associated lymphoid tissue involved in both T and B cell production. What about extramedullary hematopoiesis or blood cell production outside of the bone marrow in mammals? You'll see this occasionally in neonates, and there it will involve residual activity in liver and or spleen. You can also see extramedullary hematopoiesis when you have excessive blood cell demand and the bone marrow is unable to keep pace. Then there is a resumption of blood cell production in liver and spleen. You get the same situation with unregulated hematopoietic cell production, but this is neoplasia such as leukemia, so it can be widespread. All right, as blood cells develop, they all originate from a pluripotential stem cell. This has the ability to become any one of the blood cell components. And in addition to the ability to ultimately produce red cells, white cells, and platelets, mast cells fit into this scheme too. The pluripotential stem cells will usually become committed early on to one line of cell development. They form differentiated stem cells that then give rise to the individual cell type or types. Blood cell development is regulated by glycoproteins. The major one for erythrocytes, of course, is erythropoietin. Colony-stimulating factors and interleukins, various lymphokines, stem cell factors are associated with leukocyte production and thrombopoietin for platelets. And blood cell production is under negative feedback. So if the numbers or mass of cells is correct, production slows. If the mass is decreased or numbers are decreased, production increases. Stem cells in mammals can be found in both the blood and in the bone marrow. So they're circulating in the blood or in the bone marrow. And following a major marrow insult where you damage hematopoietic cells, you can actually affect repopulation of the marrow within 7 to 14 days. And you can do that with stem cell transfer from bone marrow harvest or peripheral blood transfusion. An important thing to remember is that stem cell numbers decline with age. So if you have a tremendous, say, toxic marrow insult, an older animal would be slower to recover or possibly less likely to recover than a young, actively growing animal. And a lot of our knowledge on the concepts of hematopoiesis has come about through bone marrow culture on the benchtop, where bone marrow cells are harvested, they're placed in agarose with fetal calf serum and various stimulants. We grow the colonies and identify the cell types to see what they become. So what this has done for us has helped us to understand immune-mediated diseases, how toxic insults to the bone marrow occur and resolve, differentiation of cells in leukemia, and to get some basic information that has helped clinically with bone marrow transplantation in humans and other animals. Also, studies of hematopoietic cell development in vitro has led to the testing and shown some of the potential clinical use of products like recombinant erythropoietin and recombinant colony stimulating factors prior to going to clinical trials. This is just a general overview of hematopoiesis. This would be your pluripotential stem cell up top. Early on, the choice is, in my job description, do I want to become a producer of lymphocytes, or do I want to be more versatile and go for everything else? So the lymphoid cells break off early in development, then they have their committed stem cells that will produce the T's and the B's. The NK or natural killer cells are still controversy raging. Are they truly macrophage origin, or are they lymphoid origin? It depends on who you talk to. You can get people in both camps. The other lineage that makes everything else is called a colony-forming unit spleen, or CFUS, in the older literature. The newer literature, they usually go to colony-forming unit GEMM, granulocyte, erythrocyte, macrophage, and megakaryocyte. What you can see, though, is that in the current schemes, a lot more cells are represented. So there's a colony-forming unit for megakaryocyte. Megakaryocytes, they will in turn make platelets. Burst-forming units and colony-forming units of erythroid activity that will ultimately give rise to mature erythrocytes. Then we have granulocytic series, the granulocytes being the basophils, eosinophils, and neutrophils. The basophil has a colony-forming unit, baso, that's been worked with considerably since this diagram was produced. There's a colony-forming unit for eosinophils, and the one that I like the best is the colony-forming unit GM or NM. GM means granulocyte macrophage or granulocyte monocyte. NM, a little more specific, neutrophil monocyte. Sort of a cross-dresser or switch hitter, if you please. It depends on the stimulus to the committed stem cell, and this one can either produce a predominance of neutrophils or it can go the other route and give rise to monocytes that serve as a replacement pool for tissue macrophages. In some instances in leukemia, and I'll talk about this later, this stem cell goes awry and it starts producing both cell lines, both neutrophils and monocytes. That would be called a myelomonocytic leukemia. Another very interesting facet of bone marrow cell culture work in identifying stem cells was the involvement of mast cells, that the original precursor can actually be recovered from bone marrow cell isolates. And currently this is called a CFU-MAST, M-A-S-T for mast cells. Back in the older days being 8 to 10 years ago, they used to call this a P-cell precursor that gave rise to mast cells. And since we have plenty of time, I'll tell you a neat story about that. When people first started harvesting bone marrow cells and growing them up in culture, they could pulse them with erythropoietin and make red cell colonies. They could pulse them with colony stimulating factors and make granulocytes. And another thing that they would do with these marrow cultures is subject them to antibodies, anti-neutrophil antibodies, anti-eosinophil antibodies, anti-erythrocyte antibodies, kill everything they could and grow up the cultures and see what was left. So what they could do is use every type of antibody they had in their armamentarium, treat the marrow cultures, and then do a process called panning. Sort of reminds me of panning for gold. Some of the lymphocytes will stick to plates when you pan. Pour off what's left, grow it up, and the thing that persisted, the P-cell precursor, grew mast cells. Okay? Now mast cells are produced from colony-forming unit mast cell. Stem cell factor is important in mast cell growth and production. All right, a little bit about hemoglobin synthesis. Hemoglobin synthesis is controlled by delta aminolevulinic acid synthetase. That's the rate-limiting enzyme, delta ALA synthetase. Heme formation is unidirectional and irreversible. Once you start it, it goes to completion and you generally can't back it up. If you have enzyme inhibition or deficiency, a nice example of enzyme inhibition might be lead poisoning, what you're left with is porphyrin accumulation. And what porphyrin is a multi-sided ring. And if you pop an iron atom into that porphyrin ring, you get heme. Okay? So if you interfere with heme synthesis, you can be left with the porphyrin ring. The porphyrin ring, if it's excreted in large quantities and in some hereditary diseases, will result in pink teeth and bones and pink discoloration of urine, sort of the madness of King George, if you remember the movie, and all the court physicians are peering over the chamber pot, you know, looking at the color of his excreta before he goes crazy, that kind of thing. All right, the heme synthesis is also matched to the globin chain synthesis, and the globin chains are specified according to their amino acid content. And with alteration in the globin chain, substitution of amino acids, you can result in a hemoglobinopathy where the hemoglobin fails to function properly in oxygen transport. The globin chain abnormalities with the amino acid deletions or substitutions are referred to as thalassemias, and they've been well described in humans, but to my knowledge, not many examples in animals. All right, erythrocyte metabolism. I'll leave it to you to memorize all these biochemical cycles and these inane details that people sometimes ask you about. But let me give you an overview of erythrocyte metabolism. There are four sort of pathways that I deem to be relatively important. The first one is the Embden-Meyerhof pathway, and what this does is reduce methemoglobin. Methemoglobin has the iron atom in the oxidized or 3+ state, ferric state. And the Embden-Meyerhof pathway helps to keep that methemoglobin, which has 3+ or ferric iron, to oxyhemoglobin, which has 2+ or ferrous iron. And the way I remember ferrous and ferric, ferrous, two of us, both of us, 2+. The next pathway is the hexose monophosphate pathway, and this is important in neutralizing oxidants that would otherwise oxidize hemoglobin that could produce methemoglobin or Heinz bodies. The third pathway is called the methemoglobin reductase pathway, and again, it's important in maintaining oxyhemoglobin. So these first three pathways are important to protect the red cells against oxidative damage. And we'll talk about that in more detail as we proceed through the program. Okay? Notice that whenever you have a very important or life-sustaining function, there are multiple levels of regulation and backup systems. I'm a pilot. It's like flying an airplane. There's a backup system for everything. You don't want to have one ignition system and have it go and then wonder about whether or not you can play glider pilot safely to the ground. So dual ignition in airplanes. They had it long before they put it in commercial automobiles. Okay, the last pathway is called the Lubring-Rappaport pathway. And what this does is produce a small molecule called 2,3-diphosphoglycerate that can be inserted into the hemoglobin tetramer and allow it to unload its oxygen more easily to the tissues. But this 2,3-DPG only benefits certain species, dogs being one, and I'll talk about that a little bit later when we get into anemias. Okay, during erythropoiesis that's occurring in the bone marrow of the adult mammalian animal, a critical hemoglobin concentration stops red cell mitosis, stops the mitosis of the precursors. And as the red cells develop, the nucleus is going to be extruded. As red cells develop, they're going to go from big nucleated cells to smaller anucleated erythrocytes. Hemoglobin is going to be produced. It gives the cells their red-orange color with right stain. And the RNA, which gives reticulocytes their bluish color on right stain, is going to be removed because it's no longer necessary in protein production. The basic thing to remember is that 8 to 32 red cells are produced in 3 to 5 doubling divisions. So in your Duncan and Prossie textbook, you can see a nice diagram of these doubling divisions. 3 to 5 will give you 8 to 32 red cells. The time from the onset of mitosis until reticulocyte release from the marrow is approximately 5 days, and it really takes about a week or 7 days to get a maximum reticulocyte response. We'll cover that a little bit later. Can anybody tell me which domestic animal does not release reticulocytes into the blood? Horse, right. That would be one of the pieces of information they'll probably ask you. If they ask you that on the boards, that's a give me, but it's a core piece of knowledge. All right, how can we increase red cell production if it becomes necessary? The best way is to increase stem cell input. If we can recruit cells from the resting phase of the cell cycle into the active phase of the cell cycle and then commit them to make red cells, that's the best way. The more stem cells you put into action, the more erythrocytes you're going to get. Now, there are a couple of other methods of promoting erythropoiesis, but they only have temporary benefit. One is we can skip cell divisions. Remember previously I told you that 3 to 5 doubling divisions. If we only go 3 doubling divisions, we'll get the red cells out faster, but we produce fewer of them, so it's really a temporary benefit. The other thing that can be done is we can shorten the maturation time of the reticulocyte and release them from the bone marrow more quickly. But usually when we do this, there is temporary benefit there because their lifespan is not quite as long. This is a little listing of some of the various species and their red cell lifespans. And what I'd like for you to look at is ruminants and horses have a relatively long red cell lifespan of about 160 days, whereas the lowly chicken down here, 20 to 35 days for the red cell lifespan of a bird. And this will convey a little bit of information. One, in ruminants, when you look at a stained blood smear of a healthy ruminant, you're hard-pressed to find a reticulocyte or polychromatophilic erythrocyte. The reason for that is the red cell lifespan is long, so they're not turning over as quickly. If you look at a chicken or a psittacine bird, you'll notice about 4 to 5% polychromasia in health, and the reason for that is there's a constant cell turnover. Another thing to remember is because chicken or avian red cells are nucleated, they have a lot more oxidative stress. They have mitochondria in the cells, a lot more oxidative stress, and that may shorten their life as well. So anemia tends to develop quicker in those species that have a short red cell lifespan. Say you develop a lymphocytic leukemia in a chicken, lymphoid leukemia in a chicken involving the bone marrow, versus the same thing in a cow. Which one's going to become anemic fastest? It's going to be the chicken because of the shorter lifespan. Okay? All right, what happens to red cells when they become aged? They are usually removed from the body. These red cells will undergo membrane alterations. They can have enzyme changes, particularly in those systems that protect the cells from damage, forms of damage including oxidative damage. So these aged erythrocytes are removed. The primary method of removal is phagocytosis by splenic macrophages. That's generalization. That's not for all species, but most of them. And this is the major route. And what happens as these erythrocytes are phagocytosed and digested, the iron is recycled for other bodily processes. The globin chains are broken down to amino acids that return to the amino acid pool, and then that porphyrin ring or tetrapyrrole ring is split open and excreted as bilirubin or one of those products, bilirubin or biliverdin in birds. A minor route to get rid of old erythrocytes is intravascular hemolysis, where the cells just finally reach their end stage and break down in the blood vascular system, and then the products are reclaimed and recycled again. But in health, intravascular hemolysis is a minor route. Phagocytosis by splenic macrophage is the major route. But these things may be reversed in disease, as we'll see today. And again, the iron is recycled. The globin chains are broken down to amino acids, which are recycled. The tetrapyrrole ring or porphyrin ring is broken open as bilirubin and excreted. All right, what laboratory tests can we do to evaluate the erythron or evaluate our red cells? The classical one is called the packed cell volume, where we take anticoagulated blood, put it in a small tube, centrifuge it, and pack the cells down. This is sometimes called a microhematocrit technique. Another synonym for packed cell volume is hematocrit, and you hear about that frequently. But on a lot of the newer hematology analyzers, what they'll do is size the red cells, count the red cells, plug that into the red cell index formulas, and compute the hematocrit. So they don't pack anything down. They don't pack the red cells down and measure them. They just do a mathematical computation that may or may not be accurate. So the microhematocrit centrifuge, we were actually packing the cells down to get an idea of red cell mass. The automated analyzers usually compute it mathematically. Hemoglobin is usually measured by a spectrophotometric technique called the cyan methemoglobin method. And basically what you do is you lyse the red cells, put in a mild cyanide solution, and then take a spectrophotometric reading. That usually is accurate in animals unless you're working with cats that have a lot of Heinz bodies. If that's the case, you need to centrifuge the sample to remove the Heinz bodies, otherwise they will interfere with light transmission through the specimen. Same thing in birds, reptiles, and amphibians. If you're doing a hemoglobin in those, remember their red cells are nucleated, so you need to centrifuge the samples to get an accurate hemoglobin. Another method of evaluating the erythron is the red cell count. This is usually done by automated hematology analyzers in mammals, because the hand counting with the hemocytometer is just too inaccurate to really give you meaningful results. However, we still use hemocytometers somewhat for birds, reptiles, and amphibians. You can do some of their red cell counts on automated analyzers, but some people hand count them. The leukocyte counts, though, on fish, amphibians, reptiles, and birds are still basically done by hand counting with hemocytometer. All right, the red cell indices are primarily used to classify anemias. And the three common indices that you will see, the first index is the mean corpuscular volume, that's measured in femtoliters, and that gives you an idea of how big or small the erythrocytes are. MCV, we'll look at some of this later on this morning. The next index is called the mean corpuscular hemoglobin, which is the average hemoglobin concentration per cell listed in picograms of hemoglobin. Another similar index is called the mean corpuscular hemoglobin concentration, and this is expressed in percent. It's the percentage of hemoglobin within the red cells. And you might scratch your head and say, well, why do they give you two different indexes for this? And the reason being different camps, different popularity. But when you're interpreting data, put a little star by MCHC. If these two values disagree, base your interpretation on the mean corpuscular hemoglobin concentration. I think I've got an example to show you of that this morning. And the reason for that is the hemoglobin concentration, the mean corpuscular hemoglobin concentration does not require a red cell count for its mathematical calculation. And the red cell count has the highest degree of error in it. Okay, this MCHC, to do that, all you need to know is the hemoglobin concentration from the cyan-methemoglobin method and packed cell volume. Now, some laboratories will put out another piece of data that's called an RDW, or red cell distribution width. Has anybody seen that? They're getting away from that now. And what this is, the larger this RDW number, the greater the degree of anisocytosis, which is variation in red cell size, anisocytosis. All right, going back in a little more detail, the PCV or hematocrit is a fairly accurate technique, only 1% error. And again, the automated cell counters will size the erythrocytes, count the erythrocytes, and then do a mathematical computation called the hematocrit. Okay, this can be a problem in cats. The reason that it can be a problem in cats is if you have a sick cat that's anemic and has platelet turnover where the platelets are larger than you would expect, you get red cell platelet overlap and the machine can't distinguish them. Here's a little piece of trivia that they may ask you on the boards. Which domestic animal has the largest mean platelet volume? Cat. Kitty cat. And the mean platelet volume usually increases if you have a turnover in platelets. Big platelets are sometimes called macroplatelets or shift platelets, and they'll have a large MPV or mean platelet volume. But cats have the largest mean platelet volume, and that can increase in certain disease states. All right, and the packed cell volume or hematocrit, when we have that value and look at it, our judgment is that value within the reference interval, or is it too low, which would be anemia, or is it too high, which is polycythemia? And I'll talk to you about distinguishing those later. All right, mean corpuscular volume, or MCV. This is the average size of red cells. And what are our three choices here when we're evaluating red cells? The cells can be larger than expected, which is macrocytic. They can be normally sized, which would place them within the reference interval, or they can be smaller than you would expect, which would be microcytic. All right, let's figure out which things might result in macrocytosis or big red cells. First off, reticulocytes. Reticulocytes are anucleate young erythrocytes. They're usually fairly large. They have a lot of membrane volume. They look diffusely blue-gray on right stain. So reticulocytes can be responsible for an elevation in the mean corpuscular volume or macrocytosis. Other conditions that you may run into, there's a congenital macrocytosis in miniature poodles, B12 deficiency in giant schnauzers. This is an inability to absorb B12. You can actually inject these affected dogs with B12 parenteral injection and have the macrocytosis resolve. Feline leukemia virus infection in cats is sometimes associated with macrocytosis. And occasionally, in certain blood samples, you may have red cells that are agglutinated or stuck together with antibody in certain immune-mediated diseases. And the machine is pretty dumb, sitting on the bench top, and it just sits back and says, boy, that sure was a big red cell that went through there, and it may be a half dozen agglutinated erythrocytes. What about microcytosis, or red cells that are smaller than normal? Usually when I run into this, it's due to iron lack or iron deficiency anemia. Can anybody tell me what other observation you may make on a blood smear from an animal with iron deficiency anemia? Hypochromic, increased central pallor from lack of iron. So microcytic hypochromic anemia, classic for iron lack, iron deficiency. Another time that you will see subtle microcytosis occur will be in portosystemic shunts. The mechanism for that is not entirely known, but portosystemic shunts will be associated with microcytosis. Asian breeds of dogs may have subtle microcytosis. These will be things like Akitas, Chow Chows, Shar-Peis, and I think the Japanese Shiba too. Occasionally you will see the mean corpuscular volume indicate microcytosis in extreme spherocytosis, but this is rare. I've only seen it a few times. In human beings with hereditary spherocytosis, you'll see a microcytic index, but to see this in animals in diagnostic settings is sort of unusual. The mean corpuscular hemoglobin concentration. Okay, this is the index that's figured based on hemoglobin concentration and packed cell volume. And because of that, this is the most accurate red cell index. It's more accurate than figuring out the mean corpuscular volume or mean corpuscular hemoglobin, the MCH. If the MCH, mean corpuscular hemoglobin, and MCHC differ, base your interpretation on the MCHC. So what are our possibilities for MCHC? It can be within the reference interval, which is usually consistent with health. It can be decreased. If it's decreased, I would be thinking, these cells are hypochromic. Maybe this is an iron lack or iron deficiency anemia. If the MCHC is above the reference interval or increased, think hemolysis. So if it's ever indicating hyperchromic, think hemolysis, lysis of red cells. All right, decreased MCHC, hypochromic. You'll see this in iron lack, iron deficiency anemia. You'll also see it in intensely regenerative anemias. And the reason for this is that the reticulocytes are young anucleate erythrocytes and they haven't developed their full complement of hemoglobin yet. Okay, so they don't have their maximum concentration of hemoglobin, so they are hypochromic. So whenever I see a decreased MCHC, look down at red cell morphology and see if the cells are hypochromic microcytic, that'll be iron, or if there's a lot of polychromasia, that'll be reticulocytosis. Red cell distribution width, again, it's a degree of anisocytosis. The greater the number, the more variation in red cell size. Anisocytosis by itself just means a variation in red cell size. It doesn't tell you if the cells are smaller than normal, normally sized, or bigger than normal. So we don't know if they're macrocytic, microcytic, or what's going on until we look at other information, specifically red cell morphology. The look of the cells on the smear is very, very helpful in distinguishing which of these possibilities is resulting in the anisocytosis. Poikilocytes are misshapen red cells. That's an umbrella term that you can apply to any misshapen, unusual, funky-looking red cell. You can call it a poikilocyte. All right, let's go into polycythemia a little bit. Polycythemia, if you will recall, is an elevation in the hematocrit or packed cell volume. And I'm going to show you how to deal with this if they give you a case of polycythemia. There are two reasons for polycythemia, for your increased packed cell volume. It can be due to a relative increase in the red cell mass. I say relative meaning we can either lose water from the plasma, so the blood is more concentrated, if you will, or we can get extreme splenic contraction and shove red cells into the circulation. Splenic blood has a PCV of about 80%. So animal gets excited, the spleen contracts, those red cells are shoved into the circulation, the packed cell volume may increase. So we can have a relative polycythemia, or we can have an absolute polycythemia. An absolute polycythemia is a true increase in red cell mass. So the basic things that you need to do to work through cases of polycythemia, first you need to know the hydration status of the patient, because if they lose water, the same number of erythrocytes are in less fluid volume, so the packed cell volume elevates. The second thing that you really need to know is whether or not the animal was excited during or before venipuncture. Okay? An easy way to see this would be to get a horse excited, take a horse or a cat when they're calm, draw a sample, do a PCV, get them real excited, draw another sample and compare them, and you usually will see an increase in packed cell volume, possibly a mild polycythemia. So excitement, we need to know information about that. The next thing that we need to work through a polycythemia case is we need to know about the oxygen tension. Because if the animal is hypoxic, what the appropriate response is to produce more red cells to carry more oxygen, right? Because the body's sensing oxygen decrease or deprivation. So we'd want to check and determine whether or not we had hypoxia. If we do a PaO2 and the arterial oxygen tension is normal, then I think of other problems that could be due to erythropoietin, things like polycythemia vera. PaO2 is within the reference interval. Polycythemia, neoplastic production of anucleate red cells, increase in red cell mass, and there's no feedback regulation to control red cell production. So what the body tries to do is decrease the erythropoietin concentration or stimulus to shut off red cell production. It can't. So in these animals, if we assay erythropoietin concentration, it's decreased usually. Certain renal cysts and neoplasms will have inappropriate production of erythropoietin. So it gives an added stimulus to the marrow to make red cells and a resultant increase in red cell production and packed cell volume. With certain hormonal diseases, it varies according to the disease. The erythropoietin concentration can be high within the reference interval or decreased. I think I've included an algorithm in your notes somewhere toward the end maybe of the red cell section on diagnosing polycythemia, which may be helpful to you. Okay, with polycythemia, you ought to have an increased hematocrit, hemoglobin, and red cell count. And the next thing you want to do is determine the hydration status of the patient. If the patient is clinically dehydrated, you oftentimes will see an increased total protein associated with water loss. This would be a relative polycythemia, something that you would see with, say, water deprivation, vomiting, diarrhea. On the other end, if the hydration status is normal, the next thing I want to know is whether or not this animal was excited. If excitement is present, we may have a relative polycythemia strictly from splenic contraction. And in my experience, I see this most often in horses and cats. If we have no evidence of dehydration or excitement, the next thing that I want to do is check the oxygen status of the blood, the PaO2. And if it is decreased, we have hypoxia, and this is called an appropriate absolute polycythemia. Appropriate meaning because of hypoxia, you want to increase red cell mass to transport more oxygen. So the bone marrow is signaled to produce more red cells. So you'll get an increase in red cell mass, but it's what you want. It's an adaptation to the process. You'll see this a lot of time in people that live at high altitudes. If you could do PCVs on the basic population in Denver versus PCVs on the flat sea level area of Athens, Georgia, the people in Denver have a higher packed cell volume, greater red cell mass. All right, if the PaO2 is within the reference interval 80 to 95 millimeters of mercury, then I want to do erythropoietin concentrations, and if it's decreased, that could be due to neoplastic conditions, specifically polycythemia vera. If the erythropoietin is increased, then we have an inappropriate absolute polycythemia. It's inappropriate because this increased erythropoietin stimulus is not needed. And this you'll see in renal tumors, cysts, certain other types of neoplasia. And then the hormonal things are just a case unto themselves. All right, case number one. Let's see what we've got here. This is a 5-month-old pug. On physical examination, it's got a heart murmur, mild cyanosis. Clinically, the hydration status is okay. There's no evidence of dehydration. Contrary to most pugs, this one for our exercise today is sort of lethargic, not bouncing around, panting, snorting, and the clinician suspected hypoxemia. The information that we have is an hematocrit of 61%. The reference intervals for the data are on the right-hand side. So the hematocrit is elevated. What's the condition? Polycythemia. What's the next thing we want to do? Determine whether or not we have normal hydration status. And the history says clinically normal hydration. And why is the plasma protein important here? And notice it's within the reference interval. Because if we had dehydration, we'd have increased concentration of plasma protein. So this further tells us that probably our hydration is okay. What's the next step? PaO2 on blood gas, 72 millimeters of mercury. So what have we got here? It's below the reference interval, so hypoxia. We have hypoxia. So this would be an appropriate absolute polycythemia. The reason here is that we had a decreased PaO2. This animal had a patent ductus arteriosus, which will shunt the blood, bypass, some of the blood is bypassing oxygenation in the lungs. So ligation of the patent ductus arteriosus, oxygenation improved following surgery, and the polycythemia resolved. Okay, Dr. Chris, this is yours. I'll pick on you because I employed you as a student. Now you've moved on to bigger and better things in pathology. Your case here is a German Shepherd dog, male, 7 years old. Red mucous membranes, ataxia, polydipsia, hydration status is normal, and it's not excited. Okay, there's your data. What do you think of an hematocrit of 81%? Polycythemia, correct. And what information, if any, do we glean from the plasma protein concentration? Hydration status appears to be okay because the plasma protein concentration is within the reference interval. And we also had a clinical assessment of hydration status which was within the reference interval. All right, the next thing we want to do is a blood gas. What do you think about your PaO2? Within the reference interval. So do we have hypoxia causing this condition? No, we don't. What's the next thing you want to look at? Erythropoietin, and that's usually expressed in milliunits per mil. What do you think in the patient? Below the reference interval. It's so low we couldn't even get a reading on it. Okay, so decreased erythropoietin. And what does this tell you about, say, feedback in trying to regulate blood cell production? Well, the negative feedback system is trying to work because the erythropoietin is decreased, but is it effectively working with an hematocrit of 81? No, it's not. We did a bone marrow on this individual, and what we found were hypercellular particles involved in erythroid production. So the diagnosis on the bone marrow was erythroid hyperplasia. Okay, here's your diagnosis in the case. We had decreased erythropoietin. So this was an absolute inappropriate polycythemia. The feedback mechanism wasn't controlling red cell production because of the neoplastic process. This is called polycythemia vera. Anybody heard the old term? Have you read the old literature where they used to call this polycythemia rubra vera? You remember that? You hear that term? You know why the rubra was dropped? It was redundant, right, because polycythemia is an increase in red cells, so an increase in red cells, they dropped the rubra. This patient was managed initially by periodic phlebotomy, and that held things within check. Then we tried chemotherapy, little response, and finally the owners got tired of driving back to the veterinary school for us to play vampires, and the animal was euthanized. On the lower right is a right-stained microscopic field of view from the bone marrow of this particular individual. The larger cells with a thin rim of blue cytoplasm, the little Golgi zone, these are early red cell precursors, prorubrocytes, and then as the erythrocytes age, the cells get smaller. These are rubrocytes. The chromatin is more condensed. Eventually it becomes a metarubrocyte with an ink dot nucleus that is extruded to leave you with a polychromatophilic erythrocyte, a bigger cell with a lot of membranes, sort of blue-gray coloration to it, and as it matures it becomes a biconcave erythrocyte, mild central pallor in dogs, rim of hemoglobin. Case number 3, 10-year-old male poodle, normal hydration, not excited.
Dr. Latimer?
Yes?
Why was that dog ataxic?
Because a lot of times in polycythemia, when you have a PCV of 81, you get sludging of blood flow and ischemia.
So even though the oxygen content is pretty normal?
Right, you have sludging of blood flow, and tissue oxygenation may not be what the blood is reflecting. Okay, case number 3. Elevated hematocrit polycythemia. The protein is within the reference interval, so that would tend to shy away from dehydration. That's providing the animal was not hypoproteinemic before it became dehydrated. PaO2 at 89 is within the reference interval, and notice the erythropoietin concentration here, well above the upper limits of the reference interval. So what we're getting in this individual is an increased production of erythropoietin, stimulating the bone marrow to produce erythrocytes. All right, on further diagnostic workup, this individual had a kidney mass on both ultrasound and radiographic examination. A unilateral nephrectomy was performed, and histopathology provided a diagnosis of renal carcinoma. And following the unilateral nephrectomy, the polycythemia resolved. And that was also associated with a decrease in erythropoietin concentration back to the reference interval. When we talk about anemias, there are 2 types of anemia again. As we mentioned for polycythemia, there's absolute anemia and relative anemia. Absolute anemia is a decrease in red cells, and this is very commonly encountered clinically. We can see it in physiologic anemia in juvenile animals, particularly those that switch from a fetal to an adult hemoglobin type. And this is the type of anemia that we're faced with in various and sundry diseases. Relative anemia, on the other hand, is rare. And this is a type of anemia that's due to an expanded plasma volume. And you don't see this very frequently except in the case of excessive fluid therapy. However, sometimes during pregnancy or in laboratory work on neonates, you will see this. Clinical signs associated with anemia are variable. Hypoxemia is a major one. Blood viscosity is usually decreased, and we may have some signs due to red cell loss or lysis. Of course, if we have loss with trauma, we can usually see blood or evidence of bleeding. Parasites, gastrointestinal ulcers are other common causes. Abnormal hemostasis can also be associated with bleeding into body cavities, into muscle mass, things of that nature, but clotting abnormalities are less frequently encountered in the general mainstream of practice. Red cell lysis can be associated with Heinz body formation or any oxidative damage to erythrocytes. Specific lysis in immune-mediated diseases is usually more of a problem in large animals like horses, where immune-mediated hemolytic anemia will cause red cell lysis as opposed to agglutination. Certain hemoparasites such as Babesia may result in marked red cell lysis. And another time that you will see this, particularly in a clinical setting, is due to hypotonicity. And with my experience, it's been mainly in large animals where they have these big plastic carboys and they mix the IV fluids up in the carboy and sterilize them, and they forget to put the electrolyte powder in and they're infusing distilled water. That's a bad sort of thing. During the anemic process, one method of adaptation that some species can use to help cope with decreased red cell mass is the production of 2,3-diphosphoglycerate, 2,3-DPG. This is a small molecule that's inserted into the hemoglobin tetramer, and it allows the hemoglobin to discharge or release its oxygen more readily to the tissues. But this adaptation mechanism is only effective or works to a great extent in certain species such as dogs, horses, and pigs. Cats and other animals don't derive much benefit from this. As far as when to transfuse the patient, that's usually based on clinical judgment. Generally, when the PCV falls below 12 to 15%, consider transfusion. The ultimate decision will be on a case-by-case basis depending on the clinical signs of the patient. All right, I thought I would give you a little bit of an approach to anemias that you can use as you prepare for the boards. The first thing, if you suspect anemia, is you want to verify that it is present, and this can be done most simply by the PCV packed cell volume alone. Red cell count is also helpful. The second thing that we do is classify the anemia according to red cell size and hemoglobin content. Okay, so for red cell size, what we want to know is whether the cells are bigger than normal or smaller than normal. So is the anemia macrocytic, normocytic, or microcytic? Classification according to hemoglobin content, what we usually want to know is whether the hemoglobin content of the red cells is within the reference interval, which is normochromic, or whether it is decreased, which is hypochromic. And again, if the iron content, average iron content of red cells is decreased or hypochromic, the next thing that I immediately want to determine is whether this is due to polychromasia, a lot of reticulocytes that don't have their full complement of hemoglobin, that would be associated with regeneration, or whether it's strictly due to a lack or deficiency of iron. And there I would be looking for hypochromic microcytic erythrocytes. Now, before we leave this, I mentioned that the body doesn't overproduce hemoglobin. It doesn't make too much hemoglobin. If the concentration of hemoglobin gets too high, you can get crystallization. So whenever I see evidence of hyperchromia, think hemolysis. Think red cell lysis. All right, a little bit about determining regenerative versus non-regenerative status of the anemia. Things that will suggest regeneration on the blood smear include polychromasia, which is a diffuse blue-gray coloring of erythrocytes. In certain animals, basophilic stippling is a sign of regeneration. This is true in domestic ruminants, And for you lab animal folks, gerbils. Gerbils. This should be associated, regeneration should be associated with an increased reticulocyte percentage. And what we have to do if the patient is a dog or a cat is correct the reticulocyte percentage. We can do that mathematically with a little bit of data, but it doesn't work real well in other species. Off the top of my head, for a dog, you normally expect to see about 1% polychromatophilic erythrocytes or reticulocytes in health. To do the corrected reticulocyte percentage, you take the patient PCV divided by 45 times the reticulocyte percent that you observe, and you get a number. And if that number is 1 or greater, it's regenerative. If your patient is a cat, it would be the patient PCV over 35 times the observed reticulocyte percentage, and if the number you get is 0.4 or greater, it's considered regenerative. So to rely just strictly on the reticulocyte percentage may not truly indicate whether the anemia is effectively regenerative. If it's a dog or a cat, you can do a corrected reticulocyte percent. But the best indicator of regeneration is the absolute reticulocyte count. And the way this is mathematically derived is as follows. You take the observed reticulocyte percentage times the number of red cells in millions, and then multiply those and get a number, and usually it's in the thousands. So if your absolute reticulocyte percentage is greater than 80,000 per microliter in a dog, 60,000 per microliter in a cat, your anemia is regenerative. Also, if you have blood that's stained with new methylene blue, the ribosomes are aggregated into a reticular network, so we look for reticulocytes. A reticulocyte and a polychromatophilic erythrocyte are two different names for the same stage of red cell development, depending upon which stain you used. Got it? If it's right stain, we call it polychromatophilic erythrocyte or polychromasia. New methylene blue stain, we call it reticulocytes. Now, for those of you in a lab animal setting that work with cats, it's important to know that there are two types of reticulocytes in cats based on their morphology. They are called punctate reticulocytes and aggregate reticulocyte. Punctate reticulocytes have little spots in them, little dots, and they can hang around for days to weeks and give you no real information on what is happening as far as resolution of the anemia at the current time. The other type of reticulocyte has a larger aggregated masses in them, and they are called aggregate reticulocytes, and they're the ones that you enumerate in cats to determine if your anemia is regenerative or non-regenerative. So if they ask you a question about reticulocytes in cats, you count the aggregates, forget the punctates. If we have non-regenerative anemia, we lack all of these findings, or most of them, of regeneration, or our reticulocyte percentages are not indicating effective regeneration. And again, to remind you, horses do not release reticulocytes. Okay, so every horse is going to present as a quote-unquote non-regenerative anemia. I have a few algorithms in your notes to help you as you prepare for boards on how to handle anemias. So the first thing that you want to do is to verify the presence of anemia, and you should see a decreased hematocrit, hemoglobin, and red cell count. The next thing that you want to do is look for indicators of regeneration, which would include polychromasia or reticulocytosis, basophilic stippling in gerbils and ruminants. And if it is present, you have a regenerative anemia. And then you can follow it through. If you have hemorrhage and enough time has elapsed to shift water to expand the plasma volume again, the total protein may be decreased in acute hemorrhage, sometimes in chronic hemorrhage. If there is no evidence of hemorrhage, but you have a normal to increased total protein concentration, you may have excessive red cell destruction. So what we'll be looking for are abnormalities in the morphology of the red cells reported on the CBC, things that the technicians have seen on the stained blood smear to get to the cause of the hemolytic anemia. Okay. So we can look at the MCHC, and if the MCHC is increased, think hemolysis, right? Intravascular hemolysis, things that will do this. Antibodies associated with immune-mediated hemolytic anemia, where you get complement fixation to the membrane attack complex. It punches a hole in the cell, the hemoglobin leaks out. Oxidative damage with Heinz body formation. You'll get to see pictures of Heinz bodies in a little bit. The Heinz body projects from the cell membrane, and these cells are sensitive to intravascular lysis if that Heinz body brushes against the vascular wall. Eccentrocytes, also a sign of oxidative damage. I'll show you a picture of that. Certain parasites such as Babesia or bacteria such as Leptospira species can be associated with intravascular hemolysis. And also you can have fragmentation or wearing blender syndrome, I call it, where you get tearing of red cells, either on fibrin strands from DIC or turbulent blood flow. If the MCHC is decreased and you don't have any evidence of hemoglobinemia, hemoglobinuria, you may or may not have icterus. This usually leads me to think extravascular hemolysis. So look for things like spherocytes on the blood smear, red cell agglutination, hemoparasites. Good examples might be anaplasma, eperythrozoan, hemobartonella, misshapen erythrocytes as well. And I might point out that these algorithms are sort of the ones that I use clinically. They work for me. You may have to modify them for your personal use. All right, what if the anemia is non-regenerative? The next thing that we want to do is look at the red cell indices, mean corpuscular volume, mean corpuscular hemoglobin concentration, and mean corpuscular hemoglobin, and see if there are any alteration in the indices. If if the anemia is normocytic and normochromic and it's non-regenerative, I think of things like selective erythroid depression, might be an anemia with chronic disease or disorders, anemia of renal disease, pure red cell aplasia, some endocrinopathies, or if we also have a leukopenia, thrombocytopenia in addition to the non-regenerative anemia, that would be pancytopenia or aplastic anemia, and we'll consider various toxic insults, certain infectious agents. We'll get into that in a little while. All right, what if the indices are abnormal? The major ones that you see are either microcytic and hypochromic, and things to consider here would be iron lack, iron deficiency, pyridoxine deficiency, copper deficiency, portosystemic shunts, Asian breeds of dogs. The Asian breeds of dogs and the portosystemic shunts, though, would be a decrease in mean corpuscular volume only. They are not hypochromic. Okay, they're microcytic but not hypochromic. All right, what about things that are macrocytic and normochromic? Cobalt deficiency in ruminants, B12 folic acid deficiency, and then you can see it in neoplastic conditions like erythroleukemias, erythemic myelosis, certain viral infections. An example would be feline leukemia virus infection in cats, macrocytosis of poodles. In the macrocytosis of poodles, the major thing that will really catch your eye is the increased MCV. Another algorithm that I put in for you is for dealing with equine anemias, because every instance of anemia in a horse looks non-regenerative. Remember, they don't release reticulocytes into the circulation. So I usually check the total protein. If it is decreased, look for evidence of clinical hemorrhage. If you have evidence of clinical hemorrhage present, then the mechanism here is blood loss. If we don't have evidence of overt hemorrhage, it might be occult hemorrhage. So what you'd want to do is check fecal occult blood, do parasite checks. If parasites are present, we have inapparent or occult hemorrhage. Deworming will usually take care of that. If the blood is absent or we really can't detect it on this occult test, then a little scientific neglect, do sequential PCVs and total protein, and if recovery is affected, the anemia will resolve. Otherwise, you're going to have to look a little bit closer to try to determine the mechanism of the anemia. Sometimes you can have occult hemorrhage at some unknown site associated with hemangiosarcoma. It's low grade, persistent. It'll drive you nuts trying to find it. Usually when I get down to the bottom here at this part, I put a star there and say consult a veterinary clinical pathologist, because it's going to take more than one brain to get to the bottom of it. Okay, what if we have a normal to increased total protein? Look for evidence of red plasma, which would be hemoglobinemia, red-brown urine. Red-brown urine could be hemoglobinuria, hematuria, or myoglobinuria. Three possibilities you'd have to consider. Call waiting. Okay, and if we have signs of hemoglobinemia, hemoglobinuria, if it's present, intravascular hemolysis, so again, things oxidative damage, parasites, immune-mediated diseases will pretty much take care of that. What if we have the situation where we have normal to increased total protein, but we can't find any icterus, hemoglobinuria, hemoglobinemia? We just do sequential PCVs. If we get an increase in the PCV, evidently the disease is resolving. If we have no change or the PCV continues to decrease, then we'll want to do a bone marrow aspiration biopsy. And make sure you have good facilities when you do this in a horse. Where I prefer to take the specimen is from the sternibra, so you're crouched under the horse. Be careful that you're not kicked, that the thing doesn't fall on you. Usually getting a bone marrow from a horse is not a big deal. You can use a spinal needle to puncture the sternibra. The only real contraindication is cardiac laceration if you pass between the sternibra. But you can usually feel the needle twitch and you can withdraw it, and that's all right. You can get by with it. All right, what about red cell morphologic changes? Things that are reported on the hematology sheet, on your data sheet, or things that you can see on the blood smear are important. As we mentioned, signs of regeneration include polychromasia, which are large blue-gray erythrocytes, reticulocytes, which have the aggregated network in them of ribosomes following new methylene blue staining. Basophilic stippling indicates regeneration in ruminants and gerbils, but the question is, would they have basophilic stippling in lead poisoning too? Of course they would. In monogastric animals, if we get a lot of basophilic stippling, we usually will put lead poisoning at the top of the list. Not so with gerbils and ruminants. Iron lack or iron deficiency, think hypochromic microcytic cells. Small cells, increased central pallor. With red cell fragmentation due to disseminated intravascular coagulation or turbulent blood flow, schistocytes which have points or any misshapen erythrocyte called a poikilocyte. You'll see pictures of those momentarily. Immune-mediated changes can include spherocytes. These are red cells that have had membrane removed. They no longer are biconcave discs. Now they're small and globoid. a variety of parasites, eperythrozoan, Hemabartonella, Babesia, cytozoan, Tyleria, lots of things, Plasmodium, on and on and on. Evidence of oxidative injury. Look for eccentrocytes, which have the hemoglobin in one side of the cell, Heinz bodies, which give the cells a light bulb appearance, or red cell ghosts. These are red cell membranes with attached Heinz bodies. The hemoglobin has leaked out. Lead toxicosis, basophilic stippling. There are some viral inclusions that you'll occasionally see in red cells. Canine distemper, paramyxovirus, it will produce magenta inclusions. Okay, evidence of regeneration. On the right stained blood smear, polychromatophilic erythrocytes are large cells. They have lots of membrane that folds. They look diffusely blue-gray. So what you're going to see if you have a tremendous regenerative response in an animal, look for macrocytic hypochromic anemia. Macrocytic hypochromic. Big cells, they don't have their full complement of hemoglobin. On new methylene blue staining, on the right, notice that we have aggregates of RNA, ribosomes. These are called aggregate reticulocytes in cats. This is a cat blood smear stained with new methylene blue. The other retics that have the little spots in them are called punctate reticulocytes. So again, when you do a reticulocyte count on a cat, ignore the punctates, count the aggregates. In ruminants and gerbils, in regeneration, look for basophilic stippling. On right stained blood smears, you'll have sort of blue-gray spots in the red cells. You will see this with lead poisoning too. Iron lack or iron deficiency anemia. Look for increased central pallor. The cells don't have as much hemoglobin, so larger central pallor. If I had to say what is a relatively normal red cell in this field, it would be this cell right here. These are transfused cells in this individual. All right, the rest of the cells are markedly hypochromic, and compared to the normal erythrocyte, many of them are smaller. They're microcytic. Okay, I think of a microcyte mentally as a tiny miniature red cell with a lot of central pallor. Also, in iron lack or iron deficiency anemia, poikilocytosis, abnormally shaped erythrocytes, are a common feature. Iron lack, iron deficiency. Fragmentation of erythrocytes associated with things like disseminated intravascular coagulation or turbulent blood flow. With DIC, I sort of think of this as the old wire-type cheese slicers, if you've ever used one of those. You get these fibrin strands forming in the microvasculature, the red cells flop across them, and they're cut up. They're carved up. And some of them, the membrane cuts will spontaneously reseal, and the cells will be abnormally shaped. Schistocytes usually have 2 points on them like this. This one has a lot more. If it's really unusually shaped and you can't put a specific name on it, just call them a poikilocyte. Immune-mediated change. The big thing to look for here are spherocytes. They are small, round, red cells that lack discernible central pallor. And what has happened is the membrane has been coated with autoantibody. As that circulates through the spleen, the macrophages have FC receptors. Complement may be on the surface of the red cells. The macrophages have complement receptors. They grab hold of the red cell, and from there, the struggle can end in a few scenarios. One is the macrophage could entirely phagocytose the cell. That would be extravascular hemolysis. Another thing that happens is that the red cell may tear, so it would be essentially intravascular hemolysis. Third thing that may happen is some of the membrane may be removed. What's left will spontaneously reseal and the cell pops away as a spherocyte. Okay? Infrequently, you can see spherocytosis accompany oxidative damage where you get Heinz body formation. When the Heinz bodies are pitted, spherocytes can be left. So you see that in some cases of red maple toxicosis in horses. I've seen it in zinc toxicosis in dogs, but it's unusual. Parasites, tons of them. Epirythrozoan, Hemabartonella will look like little circles, rings, chains, or rods on the red cells. And they may detach, and you can sometimes see them in the background. This is Epirythrozoan on this slide. This is Hemabartonella on this slide. And the parasite is epicellular. It lives in a pit on the surface of the membrane. All right, another parasite that can look like Hemabartonella, say Hemabartonella in cats, would be cytozoan or Tyleria, and they'll be ring-shaped but with a little stone on it. They look like signet rings. They are intracellular. Okay, this is cytozoan felis. Back years ago, about a decade or so ago in Georgia, whenever I saw a cat with cytozoonosis, it would come from the pine forests out around Brunswick, Georgia. And invariably, I would see it in histosection because the disease was terrible. Cytozoan felis plus house cat equals dead cat. But now it seems as though the parasite is adapting to the host somewhat. These cats are surviving longer, and I've had several cases now from the metro Atlanta area, so it's on the move. Another parasite, hemoparasite, is anaplasmosis, and this one is Anaplasma marginale. It's at the margin of the red cell. Look for purple dots. Now you may say, this looks like a Howell Jolly body. Howell Jolly body is a remnant of DNA. How can you tell the two apart? Usually the Howell Jolly bodies are a little bit larger and one per cell. Anaplasma, the organisms are smaller and you may have multiple organisms per cell. But on these animals that have anaplasma, if they're treated with imidacarb, the parasite seems to swell and will resemble a Howell Jolly body even more closely. More parasites. Piriform organisms characterize Babesia, and many of the Babesia species like Babesia equi and cabali are little nicer piroplasms. In dogs, Babesia canis may be a little more variable and not quite as teardrop shape. Avian parasites, for you fans out there, there are a number of them. The one that I like reminds me of Monday Night Football on NFL, leukocytozoan. And here the cell is enlarged, it's football shaped with points on the end. And these things can be seen easily at 10x. So leukocytozoan. Another parasite that you will see in red cells is called Hemaproteus. And the way I think about this, I guess I'm sort of a food pathologist. Think Polish sausage. Looks like a Polish sausage wrapped around the nucleus. And another parasite that you will see in avian blood will be Plasmodium, and these are multiple rings, each ring with a pigment granule. The rings usually aren't as large as Hemaproteus. This is another one that has Plasmodium and it's got Hemaproteus in it too. It's got a dual infection. Other unusual parasites, hemoparasites that you may see in birds include atoxoplasma. This is a blood smear from a canary. It was used in a research study. Atoxoplasma sirenii, and what these organisms look like are round to oval structures, light blue structures in the cytoplasm. They have some fine metachromatic granulation, and frequently they'll push into the nucleus, causing it to indent. A last parasite that's very unusual that I haven't seen that frequently in birds. Looks like a little dot or spot, and this is called Egyptianella. It sort of reminds you of Hemobartonella in a cat. Now, I'll be quick to point out that if you're in a laboratory animal setting and you're working with reptiles, particularly things like alligators and sea turtles, loggerhead turtles, they'll have little spot inclusions in the erythrocyte cytoplasm. They are iron containing and they're normal. Evidence of oxidative damage, where we've overwhelmed those defense mechanisms to help maintain oxyhemoglobin. These are some of the changes you can see on the red cells on the blood smear. The first would be eccentrocytes. Notice that half the red cell is a clear membrane. The other half has hemoglobin in it. Gives it a basket-like appearance. And they surmise that what has happened here is that with the oxidative damage, you get cross-linking of the cell membrane, which excludes the hemoglobin to one side of the cell. Another change that you can get with oxidative damage of red cells is production of Heinz bodies. Heinz bodies are denatured hemoglobin, and frequently they will project from the cell to give it a light bulb-like appearance, or it looks like a little nipple projecting from the cell surface. Heinz bodies. As these cells brush vascular walls, the Heinz body can peel off and you'll get membrane lysis and end up with erythrocyte ghosts. Now, Heinz bodies will stain pink-orange on right stain, but you can use new methylene blue to definitively show that they're Heinz bodies. They should stain dark blue. So these are the Heinz bodies stained with new methylene blue, dark blue dots. And for the red cells that have lysed, you may be left with erythrocyte ghosts, which are these faint structures, and the dark dot is the Heinz body still attached to the inside of the plasma membrane. Since I have a little time left and we're ahead of things, let me give you a little interesting piece of trivia. This might be good for you. Back in the early days, you know, when they had the microscopes that had no tungsten light source, much less tungsten halogen, you'd haul your microscope over to the window, use the mirror to reflect the light up through the specimen. They didn't even have blood smears back then, but they could divide the blood cells into red corpuscles and white corpuscles. And further study in some cases of the red corpuscles showed that these little bodies would form, these things, on the inside of the red cells, and they called them endoglobular bodies. And there was one individual, I think from Germany or definitely from Europe, that did a lot of work with these, and he did such a good job describing their formation that they honored him by placing his name on them. And he was Dr. Schmock, and they were called Schmock bodies. Then after the turn of the century, another eminent experimental hematologist in Europe came along and showed that these Schmock bodies form from oxidative denaturation of hemoglobin. And his compound of choice for causing this was phenylhydrazine. So he injected everything from fish to chickens to dogs to cats, and they all form these endoglobular Schmock bodies because of oxidative damage to the hemoglobin. He did such a great job that they then put his name on them, and that was Heinz, so they were known as Heinz bodies. Then in the 1960s in California, an eminent veterinary hematologist wrote a great book. Dr. Oscar Schaum was working with cats, and he noticed that a lot of times in normal cats, they have round refractal areas in the cytoplasm of the red cells on right stain. And when you put new methylene blue on them, guess what happens? They turn dark blue. And he wrote a paper on ER bodies, or erythrocyte refractal bodies. Published the paper. He wanted, I guess, widespread acclaim, but the medical community really jumped on his case because all he had done is add more names for these structures to the hematology literature and didn't give poor Dr. Heinz his due. So anyway, if you're a student of hematology and you're doing your retrospective research know that these things were endoglobular bodies, Schmock bodies, Heinz bodies, ER bodies, or erythrocyte refractal bodies. Okay, a little bit of fun for you. Okay, basophilic stippling. You will see basophilic stippling as a regenerative response in gerbils and ruminants. You will also see it in response to heavy metal toxicosis, particularly lead poisoning. I have seen it with zinc toxicosis too. Another reminder, a major source of zinc, particularly in dogs, are pennies that have been minted since 1982. Up until 1981 and into 1982, the pennies were real copper. They didn't corrode very well in gastric acid or cause a problem. But beginning in 1982, the pennies up through the current day are copper-plated zinc wafers, and they readily digest in stomach acid and will cause zinc toxicosis. And zinc toxicosis is associated with red cell hemolysis, oxidative damage with Heinz body formation. The Heinz bodies can be pitted, and the patient may present with spherocytosis or infrequently with basophilic stippling. But usually a radiograph shows the metal densities. The thing that you want to do if you're ever faced with this is be sure that you take lateral and ventrodorsal views so you can determine how many pennies are there. I've worked with some cases where they only took the dorsoventral view. The pennies were stacked up. The surgeon went in, did a gastrotomy, removed the penny. The patient continued to deteriorate and died. And then there were other pennies that were not removed. Two views. Viral inclusions, canine distemper. And if you're using Diff-Quick or Right stain, these inclusions will usually stain magenta, and they can be irregular, dot or ring shaped, and they may occur in red cells as we see here, including metarubicytes. They may appear in white cells or both. Reticulocytes and regeneration. What we want to do is determine whether or not the anemia is regenerating red cells to correct the problem more than just what it is currently losing, but enough to get the values back into the reference interval. All right, maximum reticulocytosis, it takes 7 days to achieve that. We talked about doing corrected reticulocyte percentage. This is where you correct the reticulocyte percentage based on the PCV, and what we do is for the dog, it's patient PCV divided by 45 times the observed reticulocyte percentage. If the number is 1% or greater, it's regenerative. If the patient is a cat, it would be the patient's PCV divided by 35 times observed retic percentage. If that number is greater than 0.4, it's regenerative. A cat doesn't have the intense regenerative response that a dog does. I like the absolute reticulocyte count. This is the observed reticulocyte percentage times the red blood cell count, and you get a number. And if that number is greater than 80,000 in a dog, it's regenerative. Greater than 60,000 in a cat, it's regenerative. Greater than 60,000 per microliter. And again, new methylene blue stained blood smears. If the animal is a cat, count the aggregate reticulocytes, ignore the punctates. Okay, case number 4. Labrador Retriever, male, 6 years old, severe laceration of the foot, unknown duration of bleeding. And we have some laboratory data for 2 days. First question, do we have anemia? Yes. Hematocrit, hemoglobin, red cell count, decreased both days. What do we know about classification according to cell size and hemoglobin content? Notice that on the 14th, it is a normocytic anemia. On the 19th, it is a macrocytic anemia, larger red cells. What about the hemoglobin concentration? On day 14, it is normochromic, so we have a normocytic, normochromic anemia on the 14th. On the 19th, notice that now it is hypochromic, so we have a macrocytic hypochromic anemia. And Plasma color is normal for the species, so there is no evidence of hemoglobinemia such as intravascular hemolysis. The reticulocyte percentage, 2% on the 14th, 5 days later, 9.6%. And what we've done is taken the percentage times the red cell count to get the absolute reticulocyte count. On day 1, 62,000, which is not regenerative. So day 1, normocytic, normochromic, non-regenerative anemia. On the 19th, notice we have 278,000 reticulocytes. That's greater than 80,000, so it's a regenerative anemia. We have a macrocytic, hypochromic, regenerative anemia. Whenever we have hypochromia on the hemoglobin index, what we want to do is determine, is this iron lack or iron deficiency, or is it due to reticulocytosis? Well, first off, the cells are not microcytic like iron deficiency. They're macrocytic, big cells like reticulocytes. And we also have polychromasia, which goes along with regeneration. And again, anisocytosis is a nonspecific term. It could mean small red cells or big mixed with normally sized cells, big red cells mixed with normally sized cells, or small, big, and normally sized cells mixed in the same pot. It just means variation in size. Notice that this animal is hypoproteinemic on the plasma protein, and the albumin is mildly hypoalbuminemic. And to get the globulin, if they ask you, well, what's the globulin? Globulin for day 1 would be 5.2 minus 2.1, just simple subtraction. So the globulin concentration is 3.1 grams per DL on day 1 and 3.1 grams per DL on the 19th. And albumin-globulin ratio actually helps you determine whether or not things are being lost together, or you have a preponderance of one being produced or lost over the other. So the way to get the AG ratio, or albumin to globulin ratio, is take the total protein, subtract the albumin to get the globulin, which is 3.1, and then the AG ratio is the albumin, 2.1 divided by 3.1, and that gives you a number, which is 0.68, which is within the reference interval. The next day, mathematical computation was 0.71 within the reference interval. So what this tells you is that you're losing albumin and globulin together, which makes sense with hemorrhage, right? You cut a vessel, plasma spills out, albumin and globulin are lost together. All right, so summary and diagnosis. We have evidence of hemorrhage. The first sampling period, we had a normocytic, normochromic, non-regenerative anemia. But 5 days later, things had changed, apparently for the better, provided the hemorrhage was stopped, and now the anemia is macrocytic, hypochromic, regenerative anemia. The panhypoproteinemia is from the blood loss due to trauma, where we're losing not only the red cells, white cells and platelets as well, but plasma, and we're losing albumin and globulin together. This animal also had mild leukocytosis and thrombocytosis. I didn't show you that data, but just to mention, these two things can occur concurrently when you have hemorrhage, particularly the thrombocytosis. Whenever the bone marrow is signaled to produce red cells, it will oftentimes concurrently increase platelet production. Some remarks about hemorrhagic anemia with acute blood loss. We usually have clinical evidence of bleeding. The spleen can contract and provide a red cell reserve. Splenic blood has a PCV of about 80%. Over 48 to 72 hours, provided the bleeding is stopped, there's an interstitial fluid shift to restore plasma volume. So if we have real acute blood loss, say from a severed artery, stop the bleeding and draw the sample, all the parameters may be within normal, everything. But then once we get fluid shift to replace lost plasma volume, then the anemia will begin to appear and the hypoproteinemia. Neutrophilia and thrombocytosis can accompany hemorrhage. Again, maximum polychromasia in 7 days. The plasma protein can normalize as fast as 2 to 3 days, but for the entire hemogram to come back into the reference interval, it may take 1 to 2 weeks. With chronic blood loss, there usually is no hypovolemia because the bleeding is insidious and oftentimes hard to pick up. With chronic blood loss, there are certain adaptive mechanisms in dogs and horses and other species. 2,3-DPG production, that little molecule is inserted into the hemoglobin tetramer, and the blood cells can release oxygen, the red cells can release oxygen to the tissues more easily. Usually with chronic blood loss, there is less intense regeneration, and it may even evolve into iron lack anemia over time. Hypoproteinemia, mild hypoproteinemia may be present. I think of chronic blood loss with things like persistent hematuria, melena, GI neoplasms. Case number 5 is a 5-year-old male beagle. Has had chronic pyoderma for 3 months, and when we look at the data here, the hemoglobin, hematocrit, and red cell values tell us that the animal is anemic. Then we use the indices. What's the size? It's within the reference interval. It's normocytic. What about the hemoglobin concentration? Notice that they're within the reference interval, so it's normochromic. And how about regeneration? 0% retics, so whenever you have 0% retics, 0% times 3.5 million is 0, so absolute retic count is 0. So this is a normocytic, normochromic, non-regenerative anemia. There were no abnormalities noted in red cell morphology on the stained blood smear. Notice that the total protein is increased, so we have hyperproteinemia, albumin within the reference interval. Our globulin would be 8.6 minus 2.6, or 6 grams per deciliter, so we have a hyperglobulinemia. AG ratio, 2.6 divided by 6 is 0.43. So the way that we can get this, decreased AG ratio is we either have increased production of the globulin, loss of the albumin, or both. All right, this animal had a chronic pyoderma that resulted in an anemia of chronic disorders or chronic disease, and these characteristically are normocytic, normochromic, non-regenerative. The iron is sequestered in the macrophages, and the hematocrit hovers around 20 to 30%. Treatment for the anemia per se is ineffective. If you cure the underlying condition, usually the hematocrit will normalize. The hyperproteinemia in this case was due to a hyperglobulinemia, and what we might want to do is a serum electrophoresis to characterize the hyperglobulinemia. And in this case, it was a polyclonal gammopathy, broad-based gamma globulin peak, which is associated with antigenic stimulation. Okay, anemia of chronic disorders, again, these are usually non-progressive. They hover anywhere in the 20 to 30, 25 to 30% range. Think macrophage sequestration of iron. There usually is decreased erythropoietin production and decreased red cell precursors on marrow aspirates. The red cells that are produced have a shortened lifespan. Okay, canine, 6-year-old male Cocker Spaniel, multiple perianal tumors, treated with estrogen injections. All right, what is the hematocrit, hemoglobin, and red cell count? What information do they convey? That the animal is anemic. All right, how about the indices for the size? It's within the reference interval, so we have a normocytic anemia. What about the hemoglobin concentration? Again, within the reference interval. So it is a normocytic, normochromic anemia. 0% retics, absolute retic count is 0. 0% times 2 million is 0. So it's a normocytic, normochromic, non-regenerative anemia without any abnormalities in red cell morphology. The other information on this patient is that the total white count was 2,400, which is below the reference interval. So it is leukopenic, and also the other information I've given you, it has neutropenia. A platelet count was performed, and the platelets are 21,000 per microliter. Reference interval 211 to 621,000. So what are we faced with on top of everything else? Thrombocytopenia. Okay, so this is a non-regenerative anemia, leukopenia, thrombocytopenia, and if you could summarize that in one or two words, what would it be? Pancytopenia or aplastic anemia. All right, this was estrogen toxicosis. You'll see this most frequently in dogs and ferrets. They're very susceptible to estrogen. In dogs, usually it's from injection or ingestion of estrogen compounds. Ferrets are induced ovulators, so the females are in estrus until they're bred. So the old lingo in the ferret field is spayum or layum to prevent estrogen toxicosis and pancytopenia or non-regenerative anemia. All right, estrogen is associated with a normocytic, normochromic, non-regenerative anemia, and in its most advanced forms, leukopenia and thrombocytopenia. This is pretty much a predictable response in dogs and ferrets. You can see it as an idiosyncratic response in some other species. Another time that I have seen this in dogs are with a functional Sertoli cell tumor that is producing estrogen, suppressing the marrow, a paraneoplastic syndrome. All right, with pancytopenia, there is decreased production of red cells, white cells, and platelets. This can occur from drugs such as estrogens. Chemotherapy drugs is a predictable response. Idiosyncratic reactions to any drug. Various chemicals and toxins can damage the marrow. Certain pathogens can do this too. Viruses like feline leukemia virus, parvoviruses. Parvoviruses are notorious for seeking out mitotically active cell populations like lymphocytes, hematopoietic cells, intestinal crypt epithelium. Other agents, rickettsia, Ehrlichia canis is known for this classically. It can come about as a result of cytotoxic reaction involving either antibody or T cells. And of course, when the Chernobyl reactor melted down in Russia, the poor dogs on the street, probably ionizing radiation. People too. Case number 7, 6-year-old female Cocker Spaniel, lethargy, depression, exercise intolerance, pale mucous membranes, suggesting the possibility of anemia. On this one, the hematocrit, hemoglobin, red cell count are decreased, so we verified anemia. The size of the red cells indicates that it's macrocytic, so we would want to see if we had the possibility of polychromatophilic erythrocytes, and we do, and anisocytosis, but notice also that we have 4+ spherocytes. Mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration. Notice that the MCH is above the reference interval. The MCHC is within the reference interval. Which one is the most accurate? MCHC. So which one do you base your interpretation on? MCHC. Okay, so this is a macrocytic normochromic anemia. Next question, is it regenerative? 21% retics, that's pretty, reticulocytes, that's pretty intensely regenerative. The absolute reticulocyte count, 431,000, so it's a macrocytic normochromic regenerative anemia. Coombs testing, Coombs positive at 1 to 128. So this is an immune-mediated hemolytic anemia. Here are your spherocytes on the stained blood smear, polychromatophilic erythrocyte. Notice also that we had a thrombocytopenia, 101,000, and a mild leukocytosis, which was a neutrophilic leukocytosis. Macrocytic normochromic regenerative anemia with spherocytes, macrocytosis from the reticulocytes despite the presence of spherocytes, not enough spherocytes to decrease the MCV. Positive direct antiglobulin test or Coombs test. I still call it the Coombs test. Everybody's getting away from that and going to direct antiglobulin test. This animal also had concurrent thrombocytopenia. This is called Evans syndrome, where you get immune-mediated hemolytic anemia and thrombocytopenia together. A little bit about Coombs testing. It's used to detect immune-mediated hemolytic anemia. The endpoint of the Coombs test is seeing agglutination. If you have autoagglutination, there's no need to waste your time on a Coombs test. The endpoint of the Coombs is agglutination. The Coombs test is used to detect complement or antibody on the red cell surface, and the things to remember about Coombs testing, you need species-specific Coombs serum. If it's a monkey, you need anti-monkey Coombs serum. Bird, anti-avian Coombs serum. Horse, anti-equine Coombs serum. Second thing you need to do is have serial dilutions of your Coombs serum so you can achieve an optimum antigen-to-antibody ratio to promote agglutination. Okay? If you don't do the serial dilutions, you may get a false negative test if your Coombs serum is too concentrated or too strong. And this false negative test is called a prozone effect. All right, what are the things that are associated with a positive Coombs test? We like to think autoimmune hemolytic anemia, but you'll see this a positive Coombs test associated with hapten reactions for antibiotics like penicillin, with certain bacterial, viral, or parasitic infections like Hemabartonella, feline leukemia virus in cats and so forth. Red cell damage with nonspecific protein absorption to the red cell surface, positive Coombs test. Lymphoid neoplasias can be associated with a positive Coombs test. And for the Coombs test, if you're having that run, you want to send an EDTA blood sample in. The EDTA prevents nonspecific C3 adsorption to the cell surface. If you send in a clot tube, you may get C3 attachment to the red cell surface in a positive Coombs test if you're using a multivalent reagent that detects complement. What about a negative Coombs test? It could mean that autoimmune hemolytic anemia is not present, but if I had spherocytes in response to corticosteroids, I would hardly believe that. Another consideration, the Coombs serum could be too strong for an optimum reaction, false negative test, prozone effect. Get away from this with serial dilutions of the Coombs serum. Another consideration, the patient may have been treated with corticosteroids or transfused, and the transfused red cells have diluted the patient's antibody-coated red cells, so you don't get agglutination. And the autoantibody on the red cell surface may now be below detectable limits of the Coombs test. And sometimes in immune-mediated hemolytic anemia, you'll get spontaneous remission of disease. We're running a little long, but if we can get through these, we'll have a nice break point. Case number 8, 4-year-old quarter horse mare, weakness, depression, increased respiratory and heart rates. The sclera is sort of icteric, but the mucous membranes look muddy red-brown. And this individual is passing red-brown urine. And there was a recent thunderstorm that toppled trees in the area across the fence. It's one of those Georgia late afternoon thunderstorms. Nice history. That's what you want to see on boards, right? Get you thinking early. A look at the urine, red-brown. Red-brown urine could be free hemoglobin, hemoglobinuria, could be intact red cells, hematuria, or it could be myoglobin, myoglobinuria. So you need to figure that out. This is plasma. All right, let's see what we've got. Decreased hematocrit, hemoglobin, red cell count was not done, but even the PCV alone can document anemia. What about the retics? 0% retics. Would we have even bothered? No, why not? Horse. Horse doesn't release reticulocytes. We don't have enough data for mean corpuscular volume or mean corpuscular hemoglobin calculation, so that was not determined. Mean corpuscular hemoglobin concentration of 50.5%. Hyperchromic, what do you think? Hemolysis. Red plasma, we saw it. All right, red cell morphology on the stain smear. 4+ Heinz bodies, eccentrocytes, which indicate what? Oxidative damage. Spherocytes, what's the most likely mechanism of the spherocytes? Pitting of Heinz bodies. We also have rouleau and anisocytosis. So eccentrocytes, Heinz bodies on right stain, Heinz bodies dark blue with new methylene blue. The other thing, remember the brown mucous membranes. We did a methemoglobin concentration on this, and usually methemoglobin is less than 1.8%. The patient was 40.3%. So we have methemoglobinemia. And what's the valence state of iron with methemoglobin? Ferric, 3+, doesn't do a good job in transporting oxygen. Usually if you get your methemoglobin up around 60%, you're dead. Okay, so we're getting in dire straits. Notice also that we have hyperbilirubinemia in this horse. We'll talk about that more when we get to liver. But whenever I see an increased bilirubin, I wonder, do I have liver disease or do I have hemolysis? And in this individual, the smoking gun here indicates that the hyperbilirubinemia is due to hemolysis. Urine occult blood, strongly positive, and it was determined to be free hemoglobin. This is red maple toxicosis with oxidative damage to erythrocytes, and the things that may occur with oxidative damage, think eccentrocytes, think spherocytes, think methemoglobin production, oxidation of iron to change its valence state from 2 to 3+. Also in this individual we've had intravascular lysis with the red plasma and hemoglobinuria. Now one thing I might remind you of, if you're trying to distinguish myoglobinuria from hemoglobinuria, one thing I like to do is look at the plasma. If the plasma is red, then probably you're dealing with hemoglobinuria. Hemoglobin is a large molecule. It's a tetramer, four units put together. With myoglobin release from muscle damage, myoglobin is equivalent to the size of one of those 4 units in the tetramer, and it's rapidly filtered via the glomerulus into the urine. So usually a lot of myoglobin in plasma is readily filtered, so the plasma color will be unaltered. All right, we've talked about oxidation of red cell membrane proteins, cross-linking, forming eccentrocytes. We've talked about denaturation of hemoglobin to produce Heinz bodies. These will stain for identification with blue. They'll stain blue with new methylene blue for specific identification. Removal of Heinz bodies can result infrequently in spherocytes. Now you might wonder, since things like onions cause oxidative damage of erythrocytes, why can I go to McDonald's, at least before I knew my cholesterol, and have my cheeseburger with onions on it, whereas if I give my cat my cheeseburger with onions on it, he gets Heinz body anemia and gets really sick. Well, it depends on the number of free sulfhydryl groups, because in oxidative damage, the sulfhydryl groups are cross-linked to disulfide bridges, tweaks the molecule, and it doesn't perform properly in oxygen transport. So if we look at free sulfhydryl groups on the hemoglobin molecule, people have, I think, 2, dogs have 4, cats have about 8. Okay? Oxidation, again, of oxyhemoglobin to methemoglobin, chocolate brown blood, looks like chocolate milk. You'll see brown mucous membranes with 10% methemoglobin. Once we get about 60%, you're almost invariably dead. Things that will cause Heinz bodies: red maple, onions, ryegrass, brassica species in large animals. Certain drugs, particularly in cats, Tylenol, aspirin derivatives, phenothiazine dewormers, largely discontinued in horses. Onions, they've gotten, I think, the Gerber improved baby food off the market that used to have onion powder as a flavor enhancer. So that's gone. It doesn't matter if the onions are raw or cooked or freeze-dried. You know, fresh onions, onion soup, onion souffle, freeze-dried onions. People that work on this and work on Heinz bodies, the way to cause them in dogs is go to your local supermarket, which is Kroger in my area. Go Kroger and go to the meat counter, get hamburger, go to the spice rack, get freeze-dried onions, mix it together, toss the dog a meatball or two, and you'll get nice Heinz bodies. Copper toxicosis, big problem in sheep especially, using red range blocks that have the trace minerals added instead of the white blocks that are plain salt. Zinc toxicosis, again, newly minted pennies. Semi-moist cat food with propylene glycol, vitamin K products, methionine in cats, and then the oddballs, methylene blue, cats, topical benzocaine, Obtundia surgical dressing, just weird things. All right, then we have a 4-month-old beagle puppy, female, depression, weakness, anorexia, pale mucous membranes, melena. What do you think? Right, I would be thinking parasitism. If we had vomiting and frank blood in the stool, maybe parvovirus. Hematocrit, hemoglobin, red cell count equals what? Anemia. Verifies the anemia. Classified on cell size. Microcytic, 43 is the MCV. The lower end of the reference interval is 60. How about the hemoglobin? The MCH is 21, which is barely within the reference interval. The MCHC is 26. So which of the two do you believe? The MCHC. So this would be a microcytic hypochromic anemia. The next thing is to determine whether or not it's effectively regenerative. And notice in health, dogs have about 1% reticulocytes. So the reticulocyte percentage is not elevated over what you would expect in a healthy dog. So 1% of 4.6 million is wrong, right? 46,000 it should be. Which is less than 80, so it is non-regenerative. Hypochromic, microcytic, non-regenerative anemia. Notice that the technicians saw increased central pallor, small cells, misshapen cells. Poikilocytes, hypochromia, microcytosis. Serum iron is decreased, so it's hypopuremic. And notice that the total protein is decreased. The AG ratio was within the reference interval, so we had a pan-hypoproteinemia, loss of albumin and globulin together. So what are you thinking? Iron lack or iron deficiency from hookworms. Okay? Microcytic, hypochromic, non-regenerative anemia, hypopuremia, pan-hypoproteinemia. Most of the time when you have a hypochromic microcytic anemia, people are thinking iron lack, iron deficiency, and it's easier to treat them than to spend the money to do the serum iron levels. But since you're taking boards, the best measure of iron stores, if you can evaluate it, is ferritin, serum ferritin concentration. The only drawback to that is that you need species-specific reagents to do it. So it's not widely available. Body iron absorption is regulated by the amount of iron that's present in macrophages or stored in the body, and also it depends upon the rate of red cell production. Decreased serum iron concentration is associated with iron deficiency, with acute phase inflammation and chronic inflammation. And the thing to remember is the ferritin assay, if it can be done, is better. Okay, so the powers of observation are very important when you're dealing with problems related to red cells. You need to look closely at the data, look at the numbers carefully in evaluating the case, look for any changes in morphology that may be significant that will help you come to a diagnostic conclusion of the case. I love birds. These are the flamingos that are housed in the men's bathroom at the zoo in Miami when, what was it, Hurricane Andrew came through. So they bedded them down in straw, and they just derived great. Okay, for the second segment of information, I thought we would continue on in the realm of hematology, and we'll talk a little bit about leukogram interpretation, because if they give you any hematology data at all in the ClinPath section to interpret, it's usually either leukograms or CBC data. All right, the leukogram has several components to it, and they include the total white blood cell count. Usually these are automated counts on mammalian species and hand counts on things like reptiles, amphibians, and fish. The second thing that's done is a leukocyte differential count, where the percentages of the various leukocytes are determined from the stained blood smear. And then the percentage of a given leukocyte subtype times the total white count will give you the absolute value of a given cell type per microliter of blood. The last thing that's done is a morphologic examination of leukocytes on the stained blood smear. All right, so total white count, leukocyte differential count, calculation of absolute values, and morphologic changes. And the thing to do is to put a star by the absolute values, because that's what you need to base your interpretation on, not percentages, not relative percentages, absolute values per microliter. When you're doing a leukocyte differential count, there are several problems that immediately arise when you're viewing your stained smear through the compound clinical microscope. The first is differentiating segmented from band neutrophils or heterophils. And usually a band heterophil or band neutrophil will have an S or U-shaped nucleus with parallel nuclear margins. If you could mentally extract the nucleus and unroll it, the nuclear sides are parallel. If you have any constrictions, they don't exceed 50% the width of the nucleus. Another problem in doing an accurate differential count is distinguishing toxic bands and metamyelocytes, which are one stage younger of neutrophils than the band stage, versus monocytes. And you can do this on tintorial differences in the cytoplasm. The monocytes usually have more of an intensely gray cytoplasm. Toxic bands and metamyelocytes sort of a light blue cytoplasm. And the bands and metamyelocytes may have Dolly bodies, which are angular blue-gray particles. Now, some days of the week when you get up and go into work and look through the microscope, you just cannot distinguish a toxic band or metamyelocyte from a monocyte. And if that's the case for one or two cells, you know that's not the end of the world. Just look at the big picture. If you've got a marked left shift with toxic change, that means a heck of a lot more to you than whether one or two cells were or were not monocytes. Another problem in doing differential counts is distinguishing small lymphocytes from metarubicytes or nucleated red cells. These two cell types may be of similar size overall, but the small lymphocyte, the nucleus will more completely fill the cytoplasm. There may be a slight indentation in the nucleus and a thin rim of light blue cytoplasm. In rubricites and metarubricites, the chromatin is very aggregated. There appears to be more cytoplasmic area. The nucleus may be eccentrically located. Another problem in doing a differential count is just recognizing unique morphology of cells in some species. Examples include the presence of heterophils in guinea pigs and rabbits, birds, reptiles, fish. Some fish will have heterophils, some have neutrophils. You need to know the beast and what you're working with. Another unique morphology may involve basophils. Dog basophils have purple granules, but they're very sparsely scattered. Cat basophils have numerous granules, but they stain anywhere from a a mauve color, sort of a grayish beige to lavender. They're not dark purple. And as I mentioned, doing correct differential counts can be a real headache sometimes in birds, reptiles, amphibians, and fish, the unusual species. All right, what do neutrophils do for a living? Well, we all know that they kill bacteria. I guess the honorable thing to do in life if you're a neutrophil is to phagocytose and digest a bacterium. That's an honorable death. That's what they're made for. That's what they live for. But in addition to that, neutrophils can also kill or damage a variety of pathogens, including yeast, fungi, algae, and parasites. They can also inactivate viruses. They're involved in antibody-dependent cellular cytotoxicity, and some of their components can also have a regulatory effect on hematopoiesis. Morphologic changes of neutrophils, there are numerous species variation in the appearance of these cells. You need to know what animal you're working with. Other morphologic changes of importance are identifying left shifts, identifying toxic changes. The most common toxic changes of neutrophils include cytoplasmic basophilia, where the neutrophils have a light blue cytoplasm, cytoplasmic vacuolation, and here the vacuolation of the neutrophil cytoplasm is very fine. It looks like soap suds in the sink strainer for those of you that still wash dishes in the sink. If you've got a dishwasher, you're out of luck. Can't see the suds. The third common manifestation of toxic change, the presence of Dolly bodies. These are angular blue-gray particles in the cytoplasm. If you could look at these ultrastructurally, they are compressed aggregates of or compressed lamellae of rough endoplasmic reticulum studded with ribosomes. Ribosomes contain RNA. RNA stains blue with right stain. The most infrequent form of toxic change, other than in human beings and primates, is toxic granulation. And in toxic granulation, the neutrophils have a fine pinkish purple granulation to the cytoplasm. Other things that we look at for or look for on morphologic examination of leukocytes include infectious agents, certain hereditary anomalies, and blast cells or other indicators of neoplasia. Let's look at some species variations first. Heterophils are present in birds, some fish. You need to know what type of fish you're working with. Some will have neutrophils, some will have heterophils, some will have both. Guinea pigs, hamsters, and rabbits have heterophils, and reptiles. Now, a heterophil has red granules in it. And if you look at the derivation of the term, although this cell performs the same equivalent as a neutrophil we know ultrastructurally has a lot of granules in it, right? Has scattered primary granules and a lot of secondary or specific granules. But in right stain, those granules don't stain red or eosinophilic, they don't stain blue, purple, or basophilic. They are neutral in their staining characteristics, hence the name neutrophil. The heterophil, although it has the same general cellular function, has these small red granules in it. So it's given a different name. The granules aren't neutral in their staining. You can't call it a neutrophil. So it's called a heterophil from the Greek, heteros, meaning different. This is a monocyte. Another unusual morphology that you'll see in leukocytes that is specific to guinea pigs are Kurloff bodies. These things are now called Foa Kurloff cells or bodies. I guess as time passes, they get a little more soft-hearted and give more credit where credit is due. So you see more names tacked on to some of these findings. Kurloff bodies are unique to guinea pigs, and they constitute about 3 to 4% of the leukocyte differential count. And what these Kurloff bodies are intracytoplasmic inclusions. They stain magenta, these things. And they're composed of mucopolysaccharide. And these inclusions are in mononuclear cells, and some people think they may have natural killer cell activity. And you will see curl-off bodies, especially in female guinea pigs during pregnancy or any sort of estrogen stimulation or administration of estrogen-type drugs. So curl-off bodies in guinea pigs, that'd be a great board question. All right, how do we know when a left shift is present? Again, band neutrophils usually have an S or U-shaped nucleus. If we could mentally extract the nucleus and unroll it, the margins are parallel. Any indentation does not exceed 50% the width of the nucleus. Okay, so band, seg, segmenter. Segmenters usually have more coarsely clumped chromatin and visible constrictions in mammals. In domestic animals, some horses don't have good lobulation of neutrophil nuclei. They just have these projections on the surface, sharp or pointed projections. And these things tend to flatten out a little bit in bands. If you move into birds, the heterophils don't have as much lobulation as mammalian neutrophils. Step back into reptiles, even less nuclear lobulation. So calling left shifts associated with infection or marked inflammation is more problematic in those species. Toxic changes. The most common forms of toxic changes in mammalian neutrophils include cytoplasmic basophilia, blue cast, cytoplasmic vaculation, sort of frothy or soap sudsy, angular blue-gray particles called Dolly bodies, and an infrequent form of toxic granulation in domestic animals, but very common in primates and human beings, toxic granulation, where the cytoplasm seems to have these pinkish purple granules. On the lower right is an avian blood smear to show you a toxic avian heterophil. And toxic change in avian heterophils, they will have the basophilia, they will have some degree of cytoplasmic vaculation and degranulation as well. Notice also avian blood, the red cells are nucleated. We mentioned those earlier. This is a small lymphocyte. What about some of the infectious agents that are hanging around? This is a blood smear from a horse with 2 neutrophils, and you can see 3 of these little inclusions in the neutrophil cytoplasm. And for those of you up front, these inclusions look gray and they're spotty. They have a mulberry appearance. This is Ehrlichia equi. So Ehrlichia canis will look like this. Ehrlichia ewingi will look like this. Ehrlichia chifensis, the ones that I've seen, will look like this. Since this is a horse and these inclusions are in circulating neutrophils, this would be Ehrlichia equi, because with Ehrlichia ristici, I have not seen inclusions in circulating leukocytes. You can find them on histosection in macrophages in the colon and tissues, but I haven't been able to see them in circulating leukocytes. On the right-hand side, this is a buffy coat smear from a dog with pancytopenia, and these are Ehrlichia canis morula. More infectious agents. How about the one on the left if I told you it's a dog? Round to irregular to ring-shaped magenta inclusions in red cells and in leukocytes. Canine distemper, correct. The center panel is another blood smear from a dog that also had mild leukopenia, and these little round grape-like inclusions are histoplasma capsulatum. You can see that in circulating neutrophils. The one from the right-hand side is another dog that has had leukocytosis, generalized periosteal reaction, and apparent muscle pain and soreness. Any ideas? Hepatozoan, yes, hepatozoonosis. And in hepatozoan, the Gametocytes can be present in monocytes and neutrophils. With right stain, they stain an ice blue, and they can be easily missed because they're not there in large numbers. Infectious agents in ye old birds, we've done some of these. How about the Monday night crowd? Leukocytozoan, looks like football. How about this one in the cytoplasm of these lymphocytes? Atoxoplasma carinii, looks like little spheres with fine metachromatic granulation. The lower left panel is another avian smear. It's not showing up well, but there's a cluster of cocci in this heterophyll. So that's generalized septicemia. Another bird blood smear, this inclusion right here. Any ideas? Elementary bodies, chlamydia psittaci. You can see that sometimes in circulating leukocytes. Hereditary conditions. Most of my work on hereditary conditions has been in dogs and cats. There are a lot of these things in mice and laboratory animals, and we could just spend a lot of time. We could probably spend a month talking about them, but I just picked a few things out to show you. This is blood smear from a cat. Notice the stringy, spotty, pink-purple inclusions in the cytoplasm. If I had to give you a differential diagnosis for that, knowing it was a cat, I would think toxic granulation, which would be unusual in that species, mucopolysaccharidosis type 6 or 7, which will have purple inclusions like this, pinkish purple. And the third question I'd ask would be what breed of cat it was. Why would I be interested in that? There's a hereditary granulation anomaly of Burman cats. Burman cat looks like a long-haired Siamese with little white feet. All right, but this one was mucopolysaccharidosis type 6, Moreau-Lemay syndrome due to an absence of what enzyme? Aryl sulfatase B. It could be a mucopolysaccharidosis type 7, which is alpha-iduronidase deficiency. We'd need more information to make that call, but that would be your three-part differential if you saw that. This one over here that looks almost identical to this is the Burman cat hereditary granulation anomaly. The lower right panel, if you could see these neutrophils with these inclusions in them, these are not Dolly bodies, they're not gray under the microscope, they're light pink. They're light pink and they measure up to 2 micrometers in diameter. And if you saw that, can you think of an hereditary condition? It's not canine distemper. It's not infectious. Chidiac-Higashi syndrome. Okay, so you see these enlarged lysosomal granules in leukocytes in beige mice, Arctic foxes with some of the dilute hair coat mutations, Lucian mink, Hereford cattle that have this instead of being mahogany and white or fawn colored and white, cats, smoke blue Persian cats, diluted coat color, real unusual color. And it had been described in at least one killer whale as a neat little novelty. But in animals, Chidiac-Higashi syndrome has pleiotropic effects, so it has effects other than these enlarged lysosomes that you see. You have unusual coat color dilutions, you have lack of pigmentation of the retina, so they'll be photophobic and have a red ocular fundic reflex. The one on the left is another hereditary condition. This is cholesterol ester storage disease or acid lipase deficiency. And to show you how subtle these things are, cytoplasmic vacuoles with lipid in lymphocytes and neutrophils. And usually in neutrophils you don't expect to see cytoplasmic vacuolation. More hereditary conditions. These are 2 cat blood smears, and the one on the left, notice the band neutrophils, but they have a real coarse aggregated chromatin pattern. No evidence of infection. No evidence of bacterial infection, viral infection, no administration of sulfa drugs or other drugs to this individual. Got a thought on it? Huh? Pelger-Hewitt anomaly. Homozygous or heterozygous state? Probably heterozygous. They'll have a left shift for life. They're in the left shift for life club. If you encounter the homozygous form, instead of having the band to bilobate nuclei, all the nuclei would be round to oval. This is kitten that's homozygous. And notice that the chromatin pattern is even more coarse. Neoplasias or leukemias, I'll talk about these a little bit more in a little more depth after lunch. Just show you some pretty pictures to look at now. First off, in the upper left panel, mitotic figures in the blood of mammals, bad news, right? However, if you're dealing with reptiles, it's not unusual to see occasional mitotic figures in the blood, particularly in younger individuals. Okay, but this is a blood smear from a cat with mitotic figures and blasts in the blood. Again, blasts in the blood equal bad news. Notice the nucleolar ring here. If this were a bluer spot, it would be a nucleolus. So a nucleolus is the structure. It's got RNA. RNA stains blue with right stain. If you're in the vicinity of the nucleolus and the chromatin is sort of pushed out of the way, but you can't see the blue, that's called a nucleolar ring. So this is an acute lymphocytic leukemia in a cat. Notice that these cells are blasts, mitotic figures. They are larger than the normal small lymphocytes. The magnification differs somewhat. The next panel to the right is a chronic lymphocytic leukemia in a horse. Notice the rouleau formation in the red cells. These are basically small, well-differentiated lymphocytes, and they don't have apparent nucleoli or nucleolar rings. Lower left panel, another leukemia in a horse. And if you could see the entire slide, there was co-production of neutrophils and monocytes. And you can see some of these are just barely beginning to indent. Co-production of neutrophils and monocytes. What type of leukemia? Name it. Myelomonocytic. And what can you tell me about the progenitor cell for monocytes and neutrophils? Bipotential. So you have three possibilities when that cell becomes neoplastic. If it goes all the neutrophil route, you have granulocytic leukemia. If it goes to the monocyte side, it's monocytic leukemia. If it produces both cells together, it's myelomonocytic. Blood smear from a dog, lower right panel. What's your best ID on the cells? Monocytes, right. They've got lobulated to indented to irregular to cleaved nuclei. The chromatin pattern is not as condensed as a segmented neutrophil. Abundant gray cytoplasm with vacuoles, and some of the cells have pseudopodia. And that's a monocytic leukemia. Monocytic leukemia in a dog. How about the top left panel? This one is another dog, I believe. No, cat. This is a cat. What shape is the nucleus? Round. What can you tell me about the cytoplasm? Numerous metachromatic granules. Okay, let's stop and think for a minute. What can you tell me about the morphology of cat basophils? They have a segmented nucleus, so that doesn't fit here. And they have numerous granules in the cytoplasm, but they don't stain purple or metachromatic. They're grayish beige or mauve color. So these are mast cells. This is a mast cell leukemia. Panel on the right-hand side is from a dog. And what I want you to notice here is that these cells also have metachromatic or purple granules, but see the nuclear lobulation? Basophilic leukemia. This is rare. I've only seen one of these in my career. The bottom two panels are conditions in horses. The first one, notice that the eosinophils have round to oval to bilobe nuclei, which is sort of like a pseudo-Pelger-Hewitt appearance. But these cells have big round pink-red granules, and this was an eosinophilic myeloproliferative disease in a horse. The one on the right is an eosinophilic leukemia in a horse, And it doesn't show up well on this PowerPoint slide, but there were specific eosinophilic granules forming in many of these cells, even the young ones that have nucleoli. Other types of neoplasia, blood smear from a cat on the left. Notice that we have a large number of blast cells. These were erythroid series. This is erythremic myelosis in its acute form, where you have primarily circulating blasts. Another feline leukemia virus infected cat, blood smear on the right. And notice this cell with an oval nucleus, and the cytoplasm looks sort of strange. It's a bluish gray, but then it's got sort of a pinkish purple spottiness to it. And this is a micromegakaryocyte in circulation. This cat had megakaryocytic leukemia, also known as megakaryocytic myelosis. What would you call the leukemia if the only thing you're seeing are numerous abnormal platelets in the blood? Platelet count sometimes is 9 to 10 million, and the red count will be 2 million or less. Thrombocythemia, or essential thrombocythemia. I don't know what makes it essential. All right, oftentimes on neoplasia, you may need cytochemical staining and ultrastructure to identify the cell lineage. And this shows you a nonspecific esterase stain with brown cytoplasm. This is a neutrophil. It lacks activity. Ultrastructurally, notice the pseudopodia and the microfilaments, monocytic characteristics. All right, so that was a little bit about morphology to show you some pretty pictures and captivate your interest before we go into the dull, boring stuff. All right, a little bit about neutrophil production and release. Neutrophils are produced in the bone marrow, and they're theoretically divided into two cell pools. The mitotic pool, which is capable of division, and this would be myeloblasts, promyelocytes, and myelocytes, and that should be 20% of the total. And then the maturation and storage pool. These cells cannot divide. All they can do is grow up. And that includes metamyelocytes, bands, and segmenters, and they constitute about 80% of the population. As far as neutrophil production, for every myeloblast that starts out, if it does 5 doubling divisions, we get 32 metamyelocytes produced that will then mature to segmenters. The total time for myeloblast to segmenter formation is about 3.5 to 6 days. And there is an age-ordered release of these cells from the bone marrow into the blood. So the segmenters are the oldest. They'll go first, followed by the bands, then the metamyelocytes. If things really get tough, then myelocytes and promyelocytes. So age-ordered release from the marrow. Once the neutrophils are in the blood, they are generally unevenly distributed. And some of them are in the mainstream of circulation, called the circulating neutrophil pool. And these are the cells that you quantitate by the white cell count. The other cells are in the marginal neutrophil pool, usually where blood flow is slower, or in the microvasculature. They sort of roll along the endothelium. And the ratio is about, for every 1 circulating neutrophil in dogs, there are 2 in the marginal pool. For every 1 in the mainstream of circulation for a cat, there are 3 in the marginal pool. And where this becomes important is, if you say scare a cat and demarginate these cells, the neutrophil count will jump up 4-fold. Notice that the neutrophil is the major circulating leukocyte in health in most of the domestic animals except ruminants. And in ruminants, it is the major circulating leukocyte type in young prior to weaning age, and then lymphocytes predominate. Some species will have heterophils, rabbits, guinea pigs, birds. And rabbits, their heterophil granules can be so intense and so vivid that a lot of people that are inexperienced will confuse them with eosinophils. Okay, but back to neutrophils in the circulation. They circulate about 10 hours in the blood, and then they randomly emigrate from the blood vessels. So, release from the marrow into the blood is age-ordered. Movement from the blood into the tissues is random. It's not age-ordered. And movement into the tissues is unidirectional. They leave the blood vasculature and don't return. Once the neutrophils are in the tissues, they can live or function for about 48 hours max, after which they're either phagocytosed by macrophages or they transmigrate epithelial surfaces, usually mucosal surfaces, and are lost from the body. Okay, we've talked a little bit about morphologic examination of neutrophils, segmentar versus band, toxic changes, infectious and congenital diseases. So we'll just jump past that. All right, what things cause changes in neutrophil counts? One will be the bone marrow production and release of the neutrophils. Second consideration is how they're distributed between the circulating neutrophil pool that we can count the cells or quantitate them, and the marginal neutrophil pool where they cannot be counted. And the third thing to consider is the rate of emigration from the blood into the tissues. All right, whenever we're looking at blood count data, what are your three possibilities? Either the neutrophil or heterophil count is within the reference interval, its increase, which would be neutrophilia or heterophilia, or its decrease, which would be neutropenia or heteropenia. First off, what are the major mechanisms or major causes of neutrophilia? These can be due to physiological causes, exposure to endogenous or exogenous corticosteroid release, inflammation or infection, and neoplasia. They are the four things to consider. And this is a dog neutrophil, nice and segmented. This is an avian blood smear. Notice the heterophil here. The granules look dark. They don't photographically record with their nice red-brown coloration. The cell to the right is a toxic heterophil that is degranulated. It's got cytoplasmic basophilia, and if you could see it under light microscopy, a mixture of red and purple granules. And to the right here is a guinea pig blood smear to show you the heterophils with the red granules. All right, what about physiologic neutrophilia? It usually is seen in very young animals, particularly cats. It's associated with fear, excitement, strenuous, generally short-term exercise, particularly in birds. If you catch a bird up to bleed it and it's squawking and flapping its wings, it'll have heterophilia. It's a transient response that's epinephrine or catecholamine associated, I should say. Transient response. So if the patient calms down, things should go back to the reference interval, resample, everything's on an even keel, back within the reference interval. Physiologic neutrophilia is often accompanied by lymphocytosis, elevated lymphocyte count. Corticosteroid-induced neutrophilia. This is due to either endogenous or exogenous corticosteroids. You can either medicate or it can be adrenal-derived cortisol. The major mechanism for the neutrophilia or heterophilia associated with corticosteroids is an increased bone marrow release rate. This is the major mechanism causing the increase. The bone marrow release rate can increase 2 to 7-fold in small animals, in dogs. The second mechanism for the neutrophilia is decreased emigration of the cells from the blood vascular system because they're less adherent. Now, a key feature for differentiating corticosteroid-induced neutrophilia from that induced by physiologic changes or excitement is corticosteroids are accompanied by lymphopenia and eosinopenia. So look for those two things. And the magnitude of the neutrophilia in corticosteroid-associated change may decrease with prolonged drug treatment and drop back toward the reference interval. However, the lymphopenia is usually a consistent feature. Severe inflammation or infection causing a neutrophilia. This is related to increased tissue demand for neutrophils. Look for a left shift as the hallmark of inflammation or infection. If they give you CBC data to interpret, it's usually in a domestic animal. So if you have an elevated neutrophil count or neutrophilia, you have to have 1,000 bands per microliter of blood or more in small animals to have a clinically important left shift. Greater than 300 bands in large animals to have a clinically important left shift. Large animals like horses and cattle don't have the magnitude of increase of dogs and cats. For other species, use the appropriate reference intervals, and if the people giving the board exam are nice, upstanding citizens, they will provide you with reference intervals. Okay? In severe inflammation or infection, toxic change may be present, and generally, higher neutrophil counts are associated with localized infection. I sort of think about that in reference to the subway system. You know, think of all the riders on the subway trains as being neutrophils. So if you get on the metro and you're playing neutrophil and you have infection all over Washington, you can get off at any metro stop, so there are fewer riders on the train at any one time. But you know, if we have a big abscess here at the Twin Brooks station, all the riders get on the train, the only place they can get off is at Twin Brooks. So what happens to the count? Goes up. Higher counts with localized infection. Neoplasia, again, we've seen some of these. Considerations would be granulocytic leukemia, which is mainly the neutrophil or is entirely neutrophils. And it can either be acute with lots of blasts or chronic where they look more segmented. And myelomonocytic leukemia would be your other consideration, which would be a mixture of monocytes and neutrophils together. All right, neutropenia. What are the considerations in neutropenia? We could have decreased production of neutrophils in the bone marrow, major concern and reason for doing a bone marrow aspirate. Secondly, we could have a shift of neutrophils from the circulating neutrophil pool where we can count them with the leukocyte count to the marginal pool where we can't count them. And third could be an overwhelming tissue demand for neutrophils. In neutropenia, a left shift is present if 10% of the neutrophil population are bands or younger, no matter what species. 10% or more of the neutrophils are bands or younger. A degenerative left shift is present whenever bands and younger forms like metamyelocytes and myelocytes outnumber the segmenters, no matter what the total count is. Okay, why don't we stop there for lunch? That's a nice break point, and then we'll pick up after lunch. We'll finish out on leukocytes, then we're going to do some clinical chemistry of liver, and end up the day on hemostasis. So I'm waiting for my diligent MP to get ready to go. Are we ready, sir? Okay. So we're off and running. I wanted to make a few final concluding comments on hematopoiesis and heterophils and things before we move on. As you probably are already aware, mammalian hematopoiesis is in the bone marrow parenchyma, and what this means is it's a bone marrow tissue outside of the sinusoids. We already have mentioned that some of the species do have heterophils, especially rabbits if you're into those animals, or birds and reptiles. One thing to remember about avian hematopoiesis is the granulocytes are produced in the bone marrow parenchyma, which is extra-sinusoidal. The erythrocytes and thrombocytes are produced in the sinusoids. Another interesting feature about birds, particularly for you anatomic pathologists, is they will have pneumatized bones. So you have large air spaces in the bones that are lined by simple cuboidal to columnar ciliated epithelium. That's sort of neat. As far as fish goes, I mentioned that already, that the main blood cell production is in the anterior kidney and the spleen because they lack bone marrow. All right, lymphocytes. Again, most of the remarks will pertain to mammals, that the lymphocytes are produced primarily in the peripheral lymphoid tissues. They may recirculate. If we had to characterize the lymphocyte population in the blood, I would say that they're small-sized T lymphocyte memory cells that recirculate. Lymphocytes are sort of unique in that they retain the ability to divide, so when we talk about a lymphocyte and its lifespan, you need to be precise. Do you mean from one mitosis to the next, the intermitotic interval, or do you mean from the last mitosis until the cell dies? What is the lifespan? B lymphocytes are involved in humoral immunity, T lymphocytes cell-mediated immunity, so we don't really need to get into that in depth. But one thing that you should know is that there is lymphocyte predominance in some species, including adult ruminants, certain species of birds, certain laboratory animals, rabbits, mice, and some rats. And it can vary according to strain, so you need to know what you're working with. Okay, so again, adult ruminants have mainly lymphocytes in the circulation. Pre-weaning calves, they're going to be neutrophils. And some of the species with lymphocyte predominance that I mentioned: gerbils, guinea pigs, hamsters, ferrets, some species of birds, pigs, mice, rabbits, and rats. Influences of stress and excitement always need to be considered whenever you're looking at data on many of these animals. I'll give you an example in birds. There was conflicting reports on reference intervals in white-naped cranes. The ones that were kept in cages and couldn't move around very much had a predominance of heterophils. Once they naturalized the exhibits so the birds could get out and stroll around, the predominance was lymphocytes. So what they were seeing in the caged animals was a stress response. So you need to consider stress or fight or flight responses when you're evaluating data. So I guess my concluding remark here is, if you're working with some unusual species, you need proper control groups so you can tell what's really happening in your study. All right, the primary lymphoid organs are the thymus and bone marrow in mammals, thymus and bursa fabricius in birds. Thymus, of course, T cells, bone marrow, bursa fabricius, B cells. Once the lymphocytes develop in the primary lymphoid tissues, they'll seed the secondary lymphoid tissues, which include tonsils, spleen, lymph nodes, bronchial-associated and gut-associated lymphoid tissue as examples. There are other things, head-associated lymphoid tissue in birds and so on and so forth. But usually in the adults, it's secondary lymphoid tissues that produce the majority of the lymphocytes. Also, lymphocytes in mammals have non-random circulation. What this means is if the lymph node came into being, say, in the spleen, it would go through the afferent lymphatics to the thoracic duct, catch the bus, travel around the blood vascular system, get off on the stop at the spleen, then travel back through in the same pattern. So they recirculate to their home tissue in health. But the recirculation pattern may change during disease states, okay? And if the recirculation pattern changes, the lymphocyte count can change, or if the rate of recirculation changes, the lymphocyte count can change. What are the major causes of lymphocytosis? In general, they are physiologic, usually catecholamine or epinephrine related. Number 2, antigenic stimulation / infection. Number 3, lymphoid neoplasia. I thought what I would do on the panels here, the first panel on the left shows a small, well-differentiated lymphocyte that is intermediate between the size of a red cell, usually, and a neutrophil. In the middle panel, a blood smear from a dog, and there is a small lymphocyte, and then to the right of that, there is a larger cell that has a convoluted to cloverleaf-shaped nucleus, moderately granular chromatin, dark blue cytoplasm with a Golgi zone around it. And this cell on a blood smear would be called an antigenically stimulated lymphocyte or an immunocyte, reactive lymphocyte, any of those terms. On the far right is a blood smear from a cat, and notice that this lymphoid cell has 5 nucleolar rings in it. That's a lymphoblast. That's from a case with lymphoma. Physiologic lymphocytosis. This is most frequent in young animals, particularly those that experience fear, excitement, or strenuous short-term exercise. Strenuous short-term exercise, it could be struggling during venipuncture, birds flapping their wings when you try to capture them, or the horse running across the pasture to get away from you before sampling. And with physiologic lymphocytosis, this lymphocytosis is transient. Once the animal calms down, the lymphocyte count goes back into the reference interval. The degree of lymphocytosis can be quite dramatic and can overshadow either neutrophilia or heterophilia, which accompanies the response. As a matter of fact, if you really want to see how high the neutrophil counts and lymphocyte counts can go in physiologic leukocytosis, get a young cat, preferably a year of age or less, be real calm and quiet with it, and carry it up to the exam table, and then slam it down about 3 times real quick. Let it squall and bleed it. And I've seen physiologic lymphocytosis in cats where the lymphocytes alone will reach 36,000. Okay, so it can really be dramatic. What about antigenic stimulation or infection? There are a number of times that we can see lymphocytosis accompanied by morphologic changes in the lymphocytes. One is post-vaccinal, which is a desired response, and we see lots of immunocytes on the blood smear. Certain viral infections and bacterial infections will cause lymphocytosis as well. Probably one of the best examples of a viral infection with lymphocytosis is bovine leukemia virus and persistent lymphocytosis. Another thing, for those of you that use dogs in your research, with chronic rickettsial infections, chronic Ehrlichia canis, you can have a pretty brisk lymphocytosis. I've seen this up around 22 to 30,000 lymphocytes per microliter. This is just lymphocytes, not any of the other leukocytes. And these cases may mimic chronic lymphoid leukemia. You may be thinking that before you even think about doing rickettsial titers. Lymphoid neoplasia. The main considerations here are lymphosarcoma or lymphoma with a leukemic blood picture versus some leukemic condition. Usually if you have lymphoma with a leukemic blood picture, in most of the animals you'll have scattered lymphoblasts on the blood smear. We do occasionally see small cell variants of lymphoma, but they're unusual in small animals. They're a little bit more common in horses and also in birds. Acute lymphoblastic leukemia, a more homogeneous population of lymphoblasts in the blood, and they should have nice nucleolar rings. Here's an edge of a mitotic figure. With the chronic lymphoid leukemia, the cells are small and well differentiated. And I also thought I would show you an unusual manifestation. It's very rare to see plasma cell leukemia where you have neoplasia of plasma cell series and these cells are in the circulation. And it does occur. And here's an example here. And this plasma cell looks very unusual. If you could see it under the microscope, there is this pink-purple flush to the outer periphery of the cytoplasm and sort of blue toward the inside. I usually put this up in February when I'm teaching sophomore clinical pathology. It's sort of a romantic thing. They call it a flaming plasma cell. Flaming plasma cell associated with antibody production. All right, what are the rule-outs or possibilities for lymphopenia? Common one, corticosteroid associated. Number 2, acute infection. Number 3, loss, sequestration, or blockage of lymphocyte-rich lymph. And number 4 would be some congenital diseases. The corticosteroid effect, besides seeing the lymphopenia, you may have an eosinopenia and a neutrophilia or heterophilia. In dogs, you'll also have a monocytosis in that corticosteroid pattern. Usually, if it's endogenous corticosteroids, the product that's involved or the molecule that's involved is cortisol in mammals. If you're dealing with birds, corticosterone is the major corticoid in birds. Okay, the corticosteroid effect usually causes temporary lymphocyte redistribution. It does not kill the lymphocytes, it just compartmentalizes them or causes them to get off at the wrong bus stop. If you're working with rats and mice, usually with the corticosteroid-associated lymphopenia, they're redistributed to the bone marrow. So if you did a bone marrow on a rat or a mouse following corticosteroids, it'd be full of lymphocytes. Again, this effect is accompanied by concurrent neutrophilia, and actually the effect of corticosteroids depends on the dosage, the method of administration, and length of administration. So if it's a potent drug given at high dosage, long period of time, there will be a marked steroid effect, and in this case you may get destruction of lymphocytes and damage of lymphoid tissue, but only with high doses of corticosteroids, long-term administration. All right, the lymphopenia of acute infection has a very complex etiology. There are a couple of things that are involved. One is that acute infection may be a stressful event, so we may have some participation of corticosteroid response with redistribution or compartmentalization of these cells where we're unable to account for them on a CBC. Second thing that can happen with acute infection is that as these lymphocytes are recirculating, when they go to the lymph nodes, they may be trapped and held there for a period of time to promote antigen exposure, part of the logarithmic amplification of the immune response. So if they're trapped for a period of time, this can be reflected as lymphopenia on the blood count. Another consideration is that lymphoid tissue may be destroyed by infectious agents. And if I could give you 2 good examples here, there would be feline leukemia virus in cats and parvovirus. Either parvoviral enteritis in dogs, feline distemper, which is parvovirus, or B19 parvovirus infection of people. Any of those would suffice. Loss, sequestration, or blockage of lymphocyte-rich lymph occurs in a number of conditions. One is protein-losing enteropathy, because a lot of times the lymphocytes are concentrated in the intestinal tract, and they'll transmigrate the mucosal surface and be lost there. Chylothorax, for the recirculating lymphocyte population, a rent in the thoracic duct will cause pooling or trapping in the chest cavity, resulting in lymphopenia. Another association of lymphopenia from loss, sequestration, or blockage of lymph flow is in feline cardiac disease. And cats with cardiomyopathy, you'll sometimes see lymphocyte-rich effusions. Now, the thing that mystifies me is they've never shown dye leakage on thoracic duct cannulas in these cats. So the question is, how do they get there in the first place? Sounds like a good graduate student project to me, 6 to 8 year project. Okay, blockage of lymphocytes in lymph flow can occur a number of ways. One is neoplastic emboli or inflammation may obstruct lymphatic flow. Another condition that you may have could be lymphangiectasia, and the lymphangiectasia could be secondary if you have an inflammatory process or something blocking lymph flow, or it may be a primary condition where the lymphatic channels fail to fully develop. What about congenital lymphopenia? When I think about this, I think about people, I think about Arabian horses, and I think about skid mice, things of that sort. So people, Arabian horses, and mice with severe combined immunodeficiency. They lack humoral antibody because they don't have the B cell component. They lack circulating lymphocytes because they don't have the T cell component. Those are the main recirculating lymphocytes. And lymph node biopsies, when you see them from these individuals, are very, very striking. That would be a great histosection to put on the glass slide of the board exam for you anatomic folks. Section of lymph node that basically is stromal tissue, period. Okay? There are also selective T cell deficiencies too that have been described, and they can result in lymphopenia. All right, monocytes. The panel on the right shows a couple of canine monocytes with their convoluted nuclei, vacuoles that are fairly good size. Vacuoles and monocytes look like you stabbed them with a pencil point. Gray cytoplasm and pseudopodia, and a neutrophil for comparison. Before I start out, I might say that for those of you that like to see vacuoles in your monocytes to help you identify them, it's usually better if you let the blood sit around on the bench top for an hour or two before you make the smear, and the monocytes show progressive vacuolation. If you get the blood and immediately make smears, the monocytes are less vacuolated. Okay, I look at monocytes as being a replacement pool for tissue macrophages. And monocytes have various functions, and as they grow into macrophages, their full potential is realized. But if you get down to the grassroots of this, to the blue-collar working status, there are two types of cells. There are the eaters and the secretors. And the eaters are the garbage trucks of the body. They phagocytose material, clean up tissues and sites of inflammation. And the secretors are the very academic type with a prolonged lifespan that sit around and think wonderful thoughts and secrete biologically active molecules like lymphokines. Okay? Monocytes have a bipotential stem cell that they share with neutrophils. And unlike neutrophils, there is no bone marrow storage pool of monocytes in the marrow. Have you ever stopped to think that whenever you look at a bone marrow from a reasonably healthy animal, you have a tough time finding monocytes in it? The reason is there's no maturation and storage pool of monocytes in the marrow. So the only time you're really going to focus in and see monocytes is if you have marked neutropenia, probably. Once they enter the bloodstream, they circulate for a short period of time and then emigrate into the tissues. They are distributed amongst circulating and marginal monocyte pools, just like we talked about for neutrophils. The cells that become macrophages in the tissues may have a prolonged lifespan, living approximately 11 to 12 months. There's a cell type that you'll see in reptiles that looks just like a monocyte, except it's got a little bit of purple coloration, purple flush or coloration to the cytoplasm, and those cells are called azurophils. My experience with them is that they're more monocyte-like than heterophil. But there is one paper out there, a cytochemical study that was done, and the authors there contended that they were more closely related to heterophils than monocytes. I don't believe that. I think azurophils are more monocyte-related. All right, when may we see monocytosis? You can see it in acute disease and chronic disease. Acute and chronic disease. Monocytosis may be the only change in the leukogram with bacterial endocarditis or in some individuals with bacteremia. Also, if you have a neutropenic state and you see a monocytosis developing in the blood, that's a good prognostic sign. Remember, monocytes and neutrophils share the same bipotential stem cell, so if you're seeing monocytes, they're kicked out in the blood early because they don't have a storage pool. So the neutrophils shouldn't be far behind. You can have extreme monocytosis in reptiles and some birds, And usually when I see this, this is associated with bacterial granulomas, fungal granulomas, or chronic chlamydiosis in birds. And by extreme monocytosis, I'm talking monocyte counts approaching 100,000 per microliter. Also, extreme monocytosis is often an indicator of monocytic or myelomonocytic leukemia. Monocytic or myelomonocytic leukemia. Another interesting aside is that in animals with monocytic leukemia, if we had say a dog with monocytic leukemia, one with myelomonocytic leukemia, and one with granulocytic leukemia, they both develop leukemia at the same time. The one that's going to have the mildest anemia is going to be the dog with the monocytic leukemia because there's no storage pool in the bone marrow. Myelomonocytic intermediate grade anemia will develop fairly quickly because the neutrophil population's retained for a while in the marrow. And with granulocytic, you have full-blown myelophysic disease. What about monocytopenia? This is one of those pieces of trivia that you really don't need to harp on for the boards. It has very little clinical significance. The only time I worry about monocytopenia is if I have a marked neutropenia without compensatory monocytosis. That tells me that it's probably gotten the stem cell. Eosinophils. Eosinophils have three major job descriptions. They're involved in killing and rejection of parasites. They modulate immune reactions, primarily hypersensitivity reactions, and they're a double-edged sword. Number three, they have a pro-inflammatory function. Ask any asthmatic who's lost his or her respiratory lining from eosinophil degranulation. They'll tell you it's a bad thing. Okay? Corticosteroids tend to inhibit the bone marrow release of eosinophils, and they promote redistribution of eosinophils in circulation. Now, one thing that you may notice is an animal that has been on corticosteroid, eosinophils are more apparent in bone marrow aspirates many times. The reason is inhibited bone marrow release. After eosinophils leave the circulation, they have a tendency to localize in subepithelial sites, particularly where things are exposed to external antigens. So you'll see them in skin, respiratory tract, urogenital tract, and gastrointestinal tract. And one thing that sometimes seems like a paradox, occasionally you'll run into the samples where you have massive tissue infiltration of eosinophils, but when you look at the blood work, no eosinophilia is present. We see that all the time. It's sort of a paradox. On the right-hand panel, I threw up some pictures to remind me to tell you that you can identify the species sometimes based on eosinophil granule morphology. Dogs have eosinophils with round, variably sized red-brown granules. Cats have eosinophils that have brick or rod-shaped granules. Domestic cats, if it's a lion, they'll be round, but domestic cats. Horses, large, round eosinophil granules, they look like a raspberry. Ruminants and pigs, small, round, uniformly round granules. And in birds and reptiles, the eosinophils usually have rounded granules. They stain a brighter red-orange as opposed to heterophils that have pointed to needle-shaped granules and stain a muddy red-brown. Okay, so separating eosinophils from heterophils is not a tremendous challenge in birds. Eosinophils, rounded granules; heterophils, big pointed granules. The eos have bright red granules, the heterophils dull red-orange granules in birds. Where it gets to be a bit of a problem will be in species like rabbits. Because rabbit heterophils have very distinct chunky granules that stain red. The eosinophils have red granules about the same tintorial property, but they're round, so you need to look carefully. Final comment, eosinophils generally are the rarest leukocyte in blood smears from birds, with the exception of raptors. Raptors are birds of prey. They include things like hawks and eagles and ospreys and owls. They're the best bet in the avian world if you want to see eosinophils, but usually basophils are more numerous in avian blood smears than eosinophils. Okay, some causes of eosinophilia. Parasitism, especially with tissue migration phases of parasites. Production and maintenance of an eosinophilia is like a primary and secondary antibody response. First response to the parasite, mild eosinophilia that develops slowly. Second response to the same parasite, a marked, rapidly developing eosinophilia. Okay, interleukin-5 is important in maintenance and production of eosinophilia. Another major cause of eosinophilia, inflammatory and hypersensitivity reactions. Eosinophils can modulate some of the effects of mast cells. Tumor-associated eosinophilia is seen occasionally, and in my experience, it's primarily mucinous-secreting carcinomas, occasional fibrosarcomas, and lymphomas. And usually the lymphomas that are associated with eosinophilia, in my experience, have been T-cell lymphomas. Eosinophilic leukemia and hypereosinophilic syndromes also are characterized by moderate to marked eosinophilia. With the eosinophilic leukemia, usually to diagnose it, you like to see a marrow blast count higher than about 30%. In cats in particular, the tough task comes in distinguishing idiopathic hypereosinophilic syndrome from eosinophilic leukemia. Both of these conditions can kill the patient. Okay? It's just that one is overtly neoplastic and the other one, they've eliminated all the possible causes, and what they're left with is eosinophilia of unknown origins. They'll call that one idiopathic. Eosinopenia, redistribution of the cells with corticosteroids, so it can be a corticosteroid-associated change. Eosinopenia is also a component or result of acute infection, but the mechanism is really unknown. Corticosteroid release may play a role in stressed individuals, but the precise mechanism for the eosinopenia has not been discerned to my knowledge. All right, basophils. When I think of a basophil, my mental picture is a lobulated to segmented nucleus and numerous purple granules that may obscure nuclear morphology. This is a horse blood smear with a typical basophil. And I can think immediately of two exceptions to that statement. One is dog basophils. They have a lobulated nucleus like this cell. This is a canine basophil, but the granules are sparse. This has quite a few for a dog. Sometimes dog basophils will only have 3 or 4 or 5 granules. The other exception that comes to mind is a cat. Cats have numerous granules that stain a grayish beige or mauve color, but generally lack metachromasia when they're in the circulation. In the marrow, cat basophils may have some metachromatic granules. Okay, despite being one of the rarest cells in the blood, and there is a trade-off, animals that have rich tissue mast cell supplies usually have lesser numbers of the cells in circulation. Other animals that have lots of basophils in circulation don't have much of a tissue mast cell supply. The functions of basophils include participation in immune-mediated inflammation, usually hypersensitivity reactions they're involved in. They can promote hemostasis with kallikrein-like activity. They can inhibit hemostasis with heparin release. They're involved in plasma lipid clearing. They also have a role in rejection of parasites and have been shown to kill certain tumor cells, carcinoma cells. So basophils, despite being rare in the blood of most mammals, do have far-reaching effects. But I might hasten to add that the leukocyte count that we do in the routine complete blood count and the leukocyte differential count are relatively crude for quantitating basophils. You can only detect overt basophilia if the animal typically has 3 to 5% basophils in the leukocyte differential count consistently. The best way to quantitate basophils if you're doing it in a research setting is with a toluidine blue-based diluent, alcohol-based diluent. You need the alcohol to prevent the degranulation of the basophils. Also, if you're looking at basophils in tissue section, you really need an alcohol fixative from the get-go, because with 10% formalin, the granule mucopolysaccharide washes out and you can't see them. Okay, as I mentioned, there is an inverse relationship between numbers of basophils in the blood versus tissue mast cells. Talked about the unique morphology of cat basophils and the fact that basophils are generally more frequent in the blood smears from birds than eosinophils, maybe with the exception of raptors. In some reptiles, particularly turtles and snapping turtles, basophils may be the most numerous leukocyte on the differential count. Some differential counts on blood smears from snapping turtles will have about 80% basophils. And these cells may degranulate in stained blood films, particularly if you're using diff-quick or a quick stain instead of the classic Wright technique. And this has been most of the time a problem for me in birds and occasionally in ferrets. If you want to demonstrate the presence of basophils in tissues, there are two ways you can go at it. One is to use an alcohol-based fixative on tissue specimens collected for H&E, ultimately for H&E staining or paraffin embedding. The other thing is you could do imprints and stain them by the classical Wright stain technique. The two panels on the right, this is a basophil in basophilic leukemia from a dog, the one that I showed you previously. The top smear with the rouleau, this is a cat that had a disseminated mast cell tumor. This is with a leukemic blood picture, and this was stained with diff-quick, and this shows you a degranulated mast cell, round to oval nucleus, no metachromatic granules, just a moth-eaten appearance to the cytoplasm. And if they degranulate on your diff-quick, you'll probably miss the first one or two until you get attuned to thinking about that. All right, basophilia on the routine white blood cell count can only be discerned when you have 3 to 6% of the differential count are basophils. Oftentimes the basophilia is accompanied by an eosinophilia. That's seen more often than not. If I had to give you the main cause of basophilia in small animals, I would say heartworms in both dogs and cats. As a paradox, basophilia may also accompany mast cell neoplasia. Okay? And again, some species will have a predominance of basophils in health. Example is a snapping turtle. These are dog basophils with the widely scattered granules. You can appreciate the lobulated or twisted ribbon appearance of the nucleus in each of these cells, but the granules are widely scattered. And for a dog, this is quite a few granules. Very rarely do you see that many. Okay, as we sort of end up the leukogram thing before we get to the casework, a little comment about some common leukogram patterns to look for if you have a case to interpret on the boards. The first pattern is physiologic leukocytosis. And what you'll see is a leukocytosis or elevation in the white count with a mature neutrophilia. That means you have lots of neutrophils but no left shift. You don't have the bands. And lymphocytosis should be apparent as well. In addition, the eosinophil count is generally unchanged. the monocyte count is generally unchanged, but may be slightly elevated in some individuals. All right, stress or corticosteroids. Here we have a leukocytosis, again with a mature neutrophilia. We don't have a left shift. We have a lymphopenia and eosinopenia, very characteristic. And the monocyte count is either unchanged, or in dogs specifically, you can get a pretty brisk monocytosis with corticosteroids. So the way to separate the physiologic response from stress is physiologic, lymphocytes increase. Stress equals corticosteroids, lymphocytes decrease. Another common leukogram pattern is involved with severe inflammation or infection. Look for a neutrophilic leukocytosis. So the elevation in the leukocyte count is primarily from neutrophils. The hallmark of infection or severe inflammation is a left shift. Look for bands. They may have toxic changes within them. And in animals that exhibit toxic change, the type of toxic change that lingers the longest, the last one to resolve, is the cytoplasmic basophilia. Another common leukogram pattern is extreme leukocytosis. It may involve any cell line and can be a diagnostic challenge. As far as leukograms, what conditions would lead you to give a guarded prognosis? First, neutropenia of any cause, guarded prognosis. Secondly, a degenerative left shift with or without toxic change. And for me, my definition of a degenerative left shift is where bands, metamyelocytes, and younger cells of the neutrophil series outnumber the segmenters, no matter what the count is, whether it's increased within the reference interval or decreased. If the immature neutrophils outnumber the segmenters, it's a degenerative shift. Third reason for a guarded prognosis is extreme leukocytosis of any form, at least until you can exclude leukemia. How about a few cases? Case number 1, 5-year-old male dachshund with pruritus. And this is the CBC data. And again, always base your interpretation on absolute counts. And if all they give you is a relative percentage, like say lymphocytes 10%, bands 5%, 10% of 19,700 would be what? 1,970. Is that right? My math is usually terrible most days. Okay, so to figure the absolute number, it's percentage of the given type times the white count equals the absolute number. So taking it from the top, we have a leukocytosis that is characterized by what? A neutrophilia. Question number 2, in this animal, do you have a significant left shift? No. How many bands would you have to have for a significant left shift in a dog or cat? 1,000 or more if the neutrophil count is within the reference interval or we have neutrophilia. Okay, next question. What about the lymphocytes? Okay, lymphopenia. It's below the reference interval. Monocytes. Monocytosis, 1,700 is above the upper reference interval of 1,300. And question, do you have monocytosis more frequently in acute or chronic disease? Both. Both. You can have it in acute and chronic disease. How about eosinophils and basophils? They didn't see any on the leukocyte differential count. Okay, we may have or it looks like we have an eosinopenia because it's below the reference interval that's given by the laboratory for dogs. Basophils, we can't make much of a statement one way or another. Okay, so to recap, we have a leukocytosis characterized by a neutrophilia, no significant left shift, a lymphopenia, a monocytosis, and an eosinopenia in this dog. Diagnosis. Corticosteroid pattern. Right. Okay, corticosteroid treatment, and what will happen is with the neutrophilia, increased marrow release rate is the major mechanism to elevate the leukocyte count. Secondarily, there's decreased immigration from blood because the cells are less sticky. The lymphopenia and the eosinopenia are probably due to temporary redistribution of those cell types where they can't be counted. Case number 2, 7-month-old domestic short-hair cat, disappeared from home, returned weak, dehydrated, and with diarrhea. I give you a reasonable history. They may not do that on the boards. All right, what's your assessment of the total white count? Leukopenia, it's below the reference interval. All right, let's look at the neutrophil series. We have segmenters and bands that exhibit toxic change. Okay, what do you think about the neutrophils? Neutropenia. What you do if they give you one of these cases, even if it shifts back younger than bands to metamyelocytes, add up the numbers. So 175 and 125 is 300, which is below 2,500, which is the lower limit. So we have a neutropenia. And do you have a clinically important left shift? Yes. How many bands would you have to have a clinically important left shift in this individual? Minimum. 10%. So if we had a total of 300 neutrophils, we need what? 30, right? For 10%, and we have 125. So we have a clinically important left shift in this neutropenic animal. Is this left shift degenerative? Is it a degenerative left shift? No. Why not? Because the bands and younger do not outnumber the segmenters. We'd have to have more than 175 bands for it to be degenerative. Okay? So that's why you need to be careful when you do those on your cases. All right, lymphocyte count. What do you think? Lymphopenia, very mild lymphopenia. How about monocytes and eosinophils and basophils? Not much to interpret there, right? They're within the reference interval. So in recap, we have a leukopenia characterized by neutropenia, a clinically important left shift with toxic changes. Lymphopenia could be due to stress or acute infection. And the monocyte count is within the reference interval. So we know that we're probably dealing with increased tissue demand for neutrophils, or maybe a pool shift. Further information on this cat: it was FeLuc and FIV negative, and the final diagnosis was parvovirus infection, feline panleukopenia. Okay, again, parvoviruses tend to target mitotically active populations, lymphoid cells, hematopoietic cells, and intestinal crypt epithelium. All right, let's shift. Let's do a horse here. 3-year-old thoroughbred mare presented to the clinic with colic. On pre-op workup, it had a mild neutrophilic leukocytosis. The torsion was corrected surgically, and profuse diarrhea began 2 days after surgery. Here's your data. What do you think about the leukocyte count? It's within the reference interval. 5.9 is within the range of 5.6 to 12.1. All right, let's look at the neutrophil series. I may need some help here with some math majors. We've got what? 29. just above, I think, 2,900. Is that right? 1180 plus 1475 plus 295. Okay, so it's probably just right in the lower end of the reference interval, borderline neutropenia with toxic change. Does this animal have a left shift? If the neutrophil count is within the reference interval or elevated, how many bands do you need for a clinically important left shift in a horse or cow? 300. What if it's below the reference interval? 10%. 10%. Okay, so we have a left shift here, a pretty brisk one. Question, is this left shift degenerative? Yeah, because 1475 plus 295 is greater than 1180. So we have a degenerative left shift. What prognosis would you put on this at best? Guarded. I heard some poor, knowing it's a horse, but guarded. Yeah, you know, the only good horse is in kennel ration dog food. All right, lymphocytes are within the reference interval. And what about monocytes, eosinophils, and basophils? Not much to say there. That's the low end of the reference interval. Now with the degenerative left shift and toxic change, what are you thinking? Infection or very severe inflammation. All right, let's turn our attention to one more thing before we move on. Fibrinogen is an acute phase reactant produced by hepatocytes. And notice that the fibrinogen concentration is 1,300 milligrams per DL. The upper end of the reference interval is 400. So why do we do fibrinogens in large animals? We don't routinely in dogs and cats. Why large animals? Because the fibrinogen may be the earliest indicator of impending infection or inflammation, developing infection or inflammation. And you may see hyperfibrinogenemia before you see any significant changes in the leukogram. Okay? So if they give you a leukogram and fibrinogen on the boards and everything in the leukogram is within the reference interval and the fibrinogen is elevated, that could very well be early infection or inflammation. Okay, so the leukocyte count, neutrophil counts within the reference interval, left shift, actually a degenerative left shift with toxic change. We suspect infection, hyperfibrinogenemia, severe inflammation or infection. And this is one of those unfortunate surgical patients that weathered the surgery okay and then developed salmonellosis during the post-op recovery period. Not a pretty sight, but the patient did survive and returned home. Okay, Holstein cow, 5 years old, swollen rear mammary quarters, recumbent, temperature of 107 degrees Fahrenheit. What would you be thinking right off the bat? Mastitis, yeah. So I imagine on your visuals for your boards, they'll have mammary gland quarters and things that you can talk about and describe and give differential. I'll show you the ClinPath part of the questions. Okay. How about the white count? Total white count. It's leukopenic at 3,000 per microliter, which is less than 4,000. How are things looking in the neutrophil series? The total neutrophil count is within the reference interval, which should be 600 to 4,000, so 1320 plus 690 plus 60 is within the reference interval. Next question, do you have a clinically important left shift? Yes, because we have 1,320 bands plus 690 juveniles. Juvenile here is not a delinquent, it's another name for a metamyelocyte, one step younger than a band. Okay, so we have these juveniles running around. They've all got toxic change, probably punk hairdos or something. And what about the shift? Is it degenerative or not? Yes, it is degenerative because when we add these two together, that would be 0, 1, 0. 2010, bands and younger cells That's greater than the segmenters. Okay, so again, a guarded prognosis. How about the lymphocytes? Lymphopenia could be due to acute infection. Stress may be involved too. How about monocytes, eosinophils, basophils? Within the reference interval. What about the fibrinogen? Hyperfibrinogenemia. What does that make you think of? Inflammation or infection, and it can elevate early. That's the reason we perform that in large animals. So if you had to summarize everything, what do you think is going on? Probably mastitis, coliform mastitis. Okay, leukopenia, even though the neutrophil count was within the reference interval, there was a degenerative left shift, toxic change, makes us suspect infection. Hyperfibrinogenemia, severe inflammation or infection. Also, the lymphopenia can occur with acute infection. So this was acute coliform mastitis. 1-year-old female Siamese cat pre-op physical exam. Here's your laboratory data. And what do you think about white count? Leukocytosis, that's the magic word. How about the neutrophil series? A neutrophilia. Do we have a shift? No, so it's a mature neutrophilia. Do we have any morphologic abnormalities noted in the neutrophil series? No, no toxic change or any of that. How about the lymphocytes? Patient is 7,455. The upper end of the reference interval is 7,000. So what have we got? Lymphocytosis. How about monocytes, eosinophils, basophils? Within the reference interval. How about an hematocrit of 47% when your reference interval goes 30 to 45%? Polycythemia from this morning, right? So we have a leukocytosis characterized by neutrophilia, no discernible shift, a lymphocytosis, mono, eo, and baso counts presumed within reference interval, and mild polycythemia. Got a cause? Stress? No. Stress should be lymphopenic, eosinopenic. Physiologic leukocytosis due to catecholamine response. Okay. Characteristic pattern in physiologic leukocytosis. Increased white count, neutrophilia without a shift, lymphocytosis. In this individual, I also gave you the hematocrit, mild polycythemia from splenic contraction. This is due to fear, excitement, strenuous exercise, such as struggling during bleeding or pounding that cat on the exam table. Transient leukocytosis, neutrophilia, and lymphocytosis. Let the patient calm down. Things should go back to the reference interval. This photograph won top prize for its Not My Job award. Okay? End of the road or a new beginning. Sort of the spiritual nature of things. Okay, I think now would be about an appropriate time for a break, don't you think?
I-15 freeway. The road remains open and is acting as a natural fire break. Dense brush and afternoon heat are adding fuel to the fire, but winds are light and firefighters expect their aggressive assault to quickly contain it. All right, let's look at the numbers. Again, still not finding the heat of the afternoon, but pretty warm here. 97 in Vegas, 103 for you in Phoenix, 106 in Palm Springs, and up into San Francisco, only in the upper 60s. Once we make our way into the Pacific Northwest, yesterday we had record temperatures around Seattle with temperatures in the middle 80s. 76 right now, Boise at 80 degrees, and also finding those 80s through the northern Rockies. Again, the temperatures will be up into the middle 80s again today in Seattle, low 90s for you in Portland. Those numbers anywhere from 5 to almost 15 degrees above average. But as we head into Wednesday, we see somewhat of cooler air coming, and temperatures trying to get back to average in the northwest as we head into Thursday. But the colder air, the below average readings will stay in through the northern plains and up across the Dakotas here. Not much rain to speak of, maybe a stray shower popping up into New Mexico around Albuquerque. Otherwise, we expect mostly dry conditions, and 88 for you in Salt Lake and in Denver for tomorrow. Carl?
Cool air is now coming into the upper Midwest, and before long that's going to be cold air, and we'll be talking about going out to Hawaii. And let's take a look at some conditions there in Hawaii, and it's looking pretty good here. We've got a couple of clouds sliding up through the Big Island, but otherwise looking not bad at all. Temperatures, as they always are pretty moderate here in the lower 80s. Kailua Kona, and a lot of sunshine, a south-southwest wind with a few clouds around. As we jump on over and towards Kahului, 84 degrees, partly cloudy skies, a little bit breezier here. And then over to Oahu and Honolulu, 85 degrees and winds out of the northeast at about 15 miles an hour. By the way, the airfare now from Chicago over to Honolulu is about $440, so it's not all that terribly high right now. Temperatures in the middle 80s tomorrow, we think, along the Big Island. And as we take you a little farther northward, we are looking for 88 degrees in Honolulu, so fairly warm weather there, and about 84 degrees in Lihue, a little bit farther along towards the west. Jen?
All right, well, with the ever-changing weather all across the country, it's important to stay safe when it comes to driving. In our Weather Ready series, we take a look at being safe and prepared on the road in all weather conditions, including severe weather. Let's head to the radar right now and see where those thunderstorms are popping up. And as we move into Florida, we're finding some rain into central Florida. No severe weather here, but take it easy in central Florida along 95. And as we move elsewhere across the southeast, we're finding a few showers. And this is actually some welcome rain up into northern Georgia, not much over into the Carolinas. Let's try to go into upstate New York. First go into Atlanta and see those thunderstorms rolling right through the city. And again, strong thunderstorms popping up in upstate New York. There you can see perhaps some gusty winds around Syracuse and over into Utica and Rome, so watch out here. We'll talk more about this coming up in Storm Watch.
It's a challenge for even the most experienced driver. Severe weather like heavy rain and fog can make it difficult to see other vehicles, road signs, and the road itself. So take precautions when driving this season. Slow down, especially through puddles. Hitting water at high speeds reduces your traction and may cause you to skid. Allow extra distance. It takes about 3 times longer to brake on wet roads than it does on dry. Always brake and slow down before entering a curve to prevent a skid. Safety features like anti-lock brakes and electronic stability control will also help you avoid and recover from a skid. ESC detects when the vehicle is starting to skid, then applies brake pressure to select wheels, reducing engine power to bring your car back under control. For more driving safety tips, go to weather.com/ready.
Brought to you by Hyundai, exclusive sponsor of Weather Ready Driving Safety.
The big one's coming. I can feel it.
The big one?
A blackout! And without me, there'd be no fridge, no toaster, no lights, no computer. Relax. I got the family covered. I could be out for hours. Welcome back. Thanks. You're welcome.
Be in control of the energy you need with a propane generator. Learn how at usepropane.com.
Brought to you by Propane. Propane, exceptional energy.
Oh, what a wonderful morning. It's time to rise and shine. All I need is a steaming cup of coffee. Today is gonna be.
Life comes at you fast. But with nationwide Blue Ribbon Claim Services, you don't have to worry. We can guarantee all your repairs in writing for as long as you own the car.
Nationwide is on your side.
Experience the phenomena.
The Maritime Snowpack is God's gift to snowboarding.
Experience the journey.
Are you ready to wrestle alligators?
This was not in the deal.
Experience the thrill.
Every time you jump out of this aircraft, you're dead until you do something.
Get the total weather experience 5 nights a week on the Weather Channel. Epic Conditions, Weather Ventures. Weeknights beginning October 1st at 7 and 11. Only on the Weather Channel. In high definition where available.
Why are people switching to Scottrade?
Easy. There's an office around the corner from my house and one by where I work.
We aim to please.
My first month I saw mostly in black and white.
At 18, my heart pumps 100,000 times each day. By age 45, my skeleton has replaced itself 4 times. And by now, I've taken over 700 million breaths on this 80-year journey we all share.
Inside the Living Body premieres Sunday at 8, 9 Pacific on Channel 276, the National Geographic Channel.
What do you get at Scottrade besides $7 trades?
I get Dow Jones News for investors, free streaming quotes, and research I can really use.
That's why we're here.
Epic Conditions, beginning October 1st on the Weather Channel. Now, you're local on the 8s.
Closed captioning hours on the Weather Channel brought to you by Flexitol Heel Balm for rough, dry, and cracked feet.
Embarrassed by rough, dry, cracked heels? Flexitol Heel Balm has a unique formulation that intensively hydrates and moisturizes feet, leaving them wonderfully soft and healthy. Flexitol, it works.
All right, it's 50 past the hour, and that always means it's time to head out into the tropics. Let's go over to Carl to get a complete look at what's going on out there in the Atlantic and maybe even the Pacific. Carl?
All right, Jen, we'll start you off here with a look at Africa and the full disk view. This is where a lot of our tropical systems begin as clusters of thunderstorms that roll across the central part of Africa and then come off the coast and move into the Atlantic. And in fact, we are watching an area of low pressure that's been out here for a while, still about 4 days from its closest approach to land, and not all that particularly impressive right now, but we will watch it. It does have potential. It's got a ways to go, and we'll see if it does in fact turn into anything. Otherwise, things are pretty quiet as you go across the Caribbean here and extending up into the Gulf of Mexico. There is an area of low pressure. There's a broad trough here through the northwestern part of the Gulf, an elongated trough and some convection that we think will slide into South Texas and New Mexico, Mexico, and bring a fair amount of rain, but it doesn't probably have much chance to develop here. Also, another area that we're watching in the eastern part of the Gulf, but that is not looking very good at all, so good news for us. Also, another feature that is way out here in the eastern part of the Pacific, but across most of the areas that are close to land, nothing imminent, just some scattered showers and storms. So all in all, things are pretty quiet across the tropics tonight. Let's talk about the stormy weather in the lower 48. Here's Jen with that.
All right, and yeah, we have a lot of thunderstorms we're looking at. In fact, we're going to start right up in upstate New York. And let me grab off the printer the latest severe thunderstorm warning. It's out for Oneida County in central New York. And again, these thunderstorms have the capability of bringing some strong gusty winds up to around 60 miles an hour. It's this area right here, northern Oneida County. Some locations, Rome, Delta Lake, and again going over into Floyd, so that's going to continue to push to the east rather quickly, so watch out for some strong gusty winds. And you can see back over into Syracuse, we're also seeing the tail end of that thunderstorm. Again, scattered showers and thunderstorms up into upstate to New York tonight, but we're also finding rain and gusty winds elsewhere here. Let's go into the Boston area, getting some heavy rain, and especially south of Boston. This one thunderstorm again around Hyannis Point or Hyannisport, as well as over into Woods Hole. That has a special marine warning on it. So they're advising folks not to go in boats right now offshore of the Cape Cod area or just offshore of Rhode Island, because we're seeing strong gusty winds with these thunderstorms popping up. Eastern Long Island also seeing the heavy rain, a little bit of lighter stuff back over into upstate New York, or rather New York City, and also into New Jersey. These are all going to be pushing to the east. Here's another cluster of storms to watch down here around Ocean City, Maryland. Those are going to be a little bit rough here, but we're seeing improving weather behind it back along 95. But again, still looking at the threat rotating around the Great Lakes for scattered showers and thunderstorms in upstate New York, maybe, and see some more into northern New England as we go through the next few hours. All right, again, this is one area we're looking at for rain. In fact, all this is going to be pretty much offshore by tomorrow, so you'll see improving weather in the northeast for your Wednesday. However, down into the southeast, there's that tail end of the system, and this one's slowly going to be moving through. It's not going to be bringing any more rain into Dallas, and we get a break across Oklahoma City as well. But into northern Louisiana, the southern half of the state, we're seeing showers and thunderstorms. Some good rain coming into northern Alabama, and also over into Atlanta. We're finding that rain moving through. A few thunderstorms here as well. And then down into northern Florida and southern Georgia, up around Valdosta, up around Brunswick, the Golden Isles, and right down to the first coast, showers and thunderstorms. The threat for severe weather tonight again in the northeast and also popping up around the southeast with those scattered thunderstorms. Carl?
Let's talk about your forecast, and this is how the computer model sees it for the next couple of days. We'll hold on to an old boundary across the southeast, and along with that, we will find more rain chances in parts of Georgia and Alabama and along the Gulf Coast as well. You see how the front really clears things out into the northern plains, and another one's going to be coming down here on Thursday. Another boundary dropping through the northern plains, and with that, it is going to get very chilly in the upper Midwest. Here's how it looks for the next few days. Here's our front coming through the middle of the week here, and there's the next one, the stronger one that drops down on Thursday and into Friday. So by the weekend, that will clear through just about the entire country, and most of the eastern two-thirds of the country will be below average. We'll talk more about that coming up.
Heavy rain in the southern plains leaves drivers with a flood of problems. Find out if things will soon dry up.
And the conditions aren't much better in the 5 boroughs. We'll show you how long the gloomy skies will last next on PM Edition.
You know what's the best part of a Lunesta night? The way you feel the next morning. Non-narcotic Lunesta can give you 7 to 8 beautiful, restful hours of sleep to help you feel refreshed, recharged, and ready to start your day. Lunesta helps you fall asleep quickly, so take it right before bed. Be sure you have at least 8 hours to devote to sleep before becoming active. Until you know how you'll react to Lunesta, you should not drive or operate machinery. Do not take Lunesta with alcohol. Call your doctor right away if after taking Lunesta you walk, drive, eat, or engage in other activities while asleep. In rare cases, severe allergic reactions can occur. Most sleep medicines carry some risk of dependency. Side effects may include unpleasant taste, headache, drowsiness, and dizziness. Ask your doctor whether a Lunesta night can help you have mornings like this. Lunesta, a great tomorrow starts tonight.
I miss you already.
I know, baby, but this isn't goodbye, okay?
I wish you didn't have to go.
I'll be back.
What's that?
It's Orbit's telling me my flight's delayed. Guess we have more time.
I gotta get
I'm gonna hit the duty-free shop. I'll call you.
Orbitz TLC gives you free updates to keep you a step ahead. Only at Orbitz.com.
The extreme power of Energizer E-Squared Lithium, the world's longest-lasting AA battery and high-tech devices. Energizer, keep going.
Stains don't care if your shirt is white or blue. That's why we keep your colors as bright as your whites are white. Clorox Bleach for pure white. Clorox 2 for pure color.
Tonight on the Weather Channel. At 8, an ancient belief that staring into the sun improves your health. At 9, why flowers around Chicago will last longer this year. Abrams and Bettis at 8, Evening Edition at 9. Tonight on the Weather Channel.
The Weather Channel is brought to you by this cable or satellite provider. You can also get reliable forecasts from the Weather Channel through this radio station or newspaper.
Epic conditions beginning October 1st on the Weather Channel. Now, your local on the 8s.
Okay, hepatic clinical chemistry. As you probably know, any hepatologist will confirm the fact that the liver makes everything happen in the body, okay? It's got a metabolic mission, a fairly large one. It's involved in carbohydrate metabolism, say regulation, homeostasis of glucose. It's involved in lipid metabolism, protein metabolism, Vitamin metabolism and activation, a nice thought there would be vitamin K, and hormone metabolism. The liver also has a tremendous storage function. It stores glucose as glycogen. It can be a depot for fat that is used to meet energy needs, storage of vitamins and minerals. There also are some vascular functions that the liver performs, such as producing lymph. Albumin is of hepatocyte origin and provides a lot of the oncotic pressure. Also, antigen removal by Kupffer cells in the liver is a very important function. Closer to home in the hematologic realm includes iron recycling for blood cell production, production of most of the coagulation factors. Once red cells are destroyed, helping to recycle the amino acids from the globin chains as well as the iron. And I mentioned albumin production, and albumin production not only helps maintain oncotic pressure, plasma pressure, but albumin is like the teamster outfit of the body. It transports a lot of substances. The liver is also very much involved in digestion with the production and recycling of bile acids. And lastly, for those of you probably like me that will go out and have a cold beer when the day is done, the liver is very important in detoxification and excretion. Okay, so it'll take care of toxic products like ammonia, various drugs and toxins. It helps excrete bilirubin, which is the remnant of the cracked open tetrapyrrole ring for hemoglobin. Excretion of toxins, cholesterol, and the liver, the bile is one of the major excretory routes from the body to get rid of excessive copper. A little bit about the hepatic blood supply. There are a couple of sources of blood coming into the liver. One is going to be via the portal vein, and this will start from your veins in the intestine and will enter the liver at the portal triad. In conjunction with that, a branch of the hepatic artery will come to the liver, and you'll have a little arteriole also in the triad area. So you have, say, relatively oxygen-poor blood and oxygen-rich blood mixing in the portal triad. It will percolate down through the sinusoids to the hepatic vein and back into the vena cava. When I think about liver, I think about the functional unit, the hepatic acinus, and the acinus is basically around the portal triad. So these are the central veins with the portal triads at the periphery. And many people will talk about liver in zones 1, 2, and 3, away from the triad. And notice that the further away from the triad you get, the more oxygen depleted the blood is, right? So a practical example of this is if you have a very severe, rapidly occurring anemia, you may not get enough oxygen transport to these hepatocytes surrounding the central vein. It'll result in necrosis and elevation in hepatic enzymes. Okay, so the hepatic acinus centered around the portal triad. And again, I've mentioned that the blood enters portal vein and hepatic artery together out in the triad area, flow through the sinusoids, collected in the central vein, and then out. What about bile flow? Bile flow goes in the opposite direction to the blood flow. So what will happen here is that the bile flow will start near the central vein in the canaliculi, progress to the bile ductules in the portal triad, and then to the bile ducts, and then gallbladder and so forth. So the bile flows in opposite direction. Just another schematic of hepatic blood supply from hepatic artery, portal vein, through the sinusoid, central vein, and out. All right, clinical signs of liver disease can be diverse, confusing, and not pathognomonic of what's occurring within this organ. Common signs of liver disease are lethargy, anorexia, weight loss, vomiting. Jaundice may be present, also altered mental state. Patient can fluctuate from depression to seizures or have head pressing. I like the yellow main titles. It reminds me of jaundice. This is a PCV tube here. Notice that the plasma is distinctly yellow. Now, let me ask you a question. If this is a dog or a cat, what significance would this yellow plasma have? I'd be thinking icterus. What if it's an adult cow or horse? Could be normal due to carotene pigments. What if it's a newborn foal? Newborn foal. It would be abnormal. It would be abnormal, and I'd be wondering about hemolytic disease of newborns, something like that. Okay, so you need to know the species to make judgments on plasma color. All right, some of the reasons for laboratory testing specifically related to liver disease. One is that we may want to use the laboratory test to specifically localize the abnormalities to disease of the liver or biliary system, or to alter function of the liver or biliary system. Second use of laboratory tests would be to classify the disease process as either involving hepatocytes primarily or bile ducts primarily, like cholestasis. Another reason for performing laboratory tests would be to monitor the response to treatment. If you have liver disease and you're trying to treat it, you might want to monitor any response to treatment or determine if the disease is static or progressing. Okay, so we can use laboratory tests to monitor effects of treatment and whether or not we're arresting the disease. Laboratory tests also allow us to make some clinical prognosis concerning long-term outlook for the disease in question. But I might hasten to add for you anatomic folks, there's nothing like a liver biopsy to help get a definitive diagnosis. Clinical pathology may be able to help us determine whether hepatocytes are more involved or bile duct epithelium is more involved, but to put a specific disease name on what's happening, we may need a biopsy. All right, there are several common enzymatic assays that are done as far as assessing hepatobiliary function. And the ones that you're probably most familiar with are alanine aminotransferase. For any of you older people, it used to be called SGPT. Spartate aminotransferase used to be known as SGOT. Sorbitol dehydrogenase, and these are all leakage enzymes that are commonly assayed. I'll talk about each one in detail. The last two, alkaline phosphatase and gamma-glutamyl transferase, are more indicators of cholestasis, and these are induction enzymes. Something stimulates their production. Alkaline phosphatase, if you read the literature, they often abbreviate this in a number of ways. They call it ALKPHOS, ALP, SAP for serum alkaline phosphatase. Less common enzymatic assays that are done include arginase. Arginase is a liver-specific assay, but it's not very sensitive, and that sort of limits its use. Glutamate dehydrogenase is assayed more frequently in laboratories in Europe than in USA, so it's more into their mainstream of testing than ours. Lactate dehydrogenase, at least in animals, is present in many cell types, and there are isoenzymes of LDH. Because of its presence in a variety of cell types, it limits its usefulness for hepatic disease. One enzyme that has had some degree of success in the clinical testing area is 5' nucleotidase. And this is more of a cholestasis marker. It's a membrane-associated ectoenzyme. It's not in the cell, it's on the outside membrane associated. And this, again, is used as a marker of cholestasis, especially in rats. Very good in rats. And another interesting finding, particularly from the toxicology sector, is that 5' nucleotidase activity is not increased in dogs with corticosteroid treatment, which has great significance for the clinician. OCT, or ornithine carbamyltransferase, is not done very frequently. This enzyme is primarily located in the mitochondria, so you have to have a lot of hepatocellular damage to get this enzyme to leak, and it's a more technically difficult procedure. All right, some concepts about basic enzymology. And when we are dealing with enzymes, usually we're measuring and expressing enzyme activity. So we measure the enzyme activity and not the concentration of the enzyme itself, which is a protein. For many enzymes, isoenzymes will exist. This is especially true for alkaline phosphatase, lactate dehydrogenase, creatine kinase, which is primarily of concern in muscle, but is peripheral to our discussion. So isoenzymes exist. These usually catalyze the same substrate, but they work better at different ion strengths. They have different resistance to heat before they're denatured, and so on and so forth, or different electrophoretic mobility. The other thing that we have to consider whenever we're thinking about enzymes is what are the reasons for increased enzymatic activity in serum, and there are a few to consider, and I'll cover that momentarily. And we also lastly need to consider the importance of enzyme half-life. For example, if an enzyme has a very short half-life, it's not going to do you any good to take a sample and send it through the mail to a laboratory somewhere. Likewise, if you want to know whether the animal is recovering from a disease or not, it doesn't do much good to assay an enzyme with a real long half-life, because it's not going to tell you what has occurred in the last 24 to 48 hours. The little box on the right is for you biochemistry fans. That's a representation of alkaline phosphatase enzyme. Okay, the enzymatic activity is usually reported either in units per mil, units per mil or international units per liter. And basically what it all comes down to is they're measuring 1 millimole of substrate that's catalyzed, or product that is produced per minute is a unit of activity. All enzymatic assays are done under specified conditions of buffer strength, substrate, temperature. And it's very important that you know these things if you're trying to compare one laboratory's results to another. An example, many of the enzymatic assays will be run at room temperature, which is considered 25 Celsius, at 35 Celsius, or 37 Celsius. And if you run the same enzymatic assay with the same substrate and buffer ionic strength at 25 Celsius and at 37 Celsius, the higher temperature will probably have twice the value, twice the activity. Okay? That's why you just can't pull any old book off the shelf and look up reference values for enzymatic assays. The assay systems need to be identical. So because of that, work with a laboratory that provides reference intervals for the species in question. As I mentioned, isoenzymes exist for alkaline phosphatase, creatine kinase, lactate dehydrogenase, and they have the same catalytic specificity, but what they're going to differ in is their resistance to heat inactivation, what temperature it takes to inactivate them, what their electrophoretic mobility is, how they respond to the ionic strength of buffers. And in addition to that, chemical inhibition is important in some enzyme systems, specifically alkaline phosphatase in dogs and levamisole inhibition. I'll talk to you about that in more detail momentarily. All right, what are some of the reasons for increased enzymatic activity in serum? First, we may have an enzyme that's in high concentration in the cell, but once cell membrane permeability occurs, the enzyme leaks. It leaks along a concentration gradient from a high intracellular concentration to a lower extracellular concentration. So, increased membrane permeability with leakage, number one. Number two is there may be induced cellular enzyme production. This is especially important with markers of cholestasis like alkaline phosphatase, gamma-glutamyl transferase. Certain drugs can induce enzyme production. Third would be the influence of enzyme half-life, and we've already mentioned this. If it has a short enzyme half-life and you're using it to assess liver damage and you have to mail the specimen to the lab, any increase in enzyme activity may not be apparent by the time that the sample reaches the lab and is assayed if the enzyme has a very short half-life. An example there would be sorbitol dehydrogenase, or SDH. Another reason for increased enzymatic activity in serum is related to decreased enzyme inhibition, catabolism, or removal. Examples might be in pancreatic disease, renal inactivation of lipase and amylase. So they aren't catabolized as they normally would be. What would be another good example for enzyme inhibition? Lipase in hemolyzed samples, the blood will, the free hemoglobin will inhibit enzymatic reactivity. That's another example there. Another example of decreased enzyme inhibition, we're going to be talking a little bit about creatine kinase and using it to distinguish enzyme increases from of muscular origin from those of hepatic origin. And CK is one of those unusual beasts that when you get a high value and you go to dilute the sample and rerun it, you dilute the inhibitor of the enzyme so the activity continues to climb. All right, importance of half-life. For our discussion today, the enzymes with the shortest half-life that we need to be concerned with would be alkaline phosphatase in cats, half-life about 6 hours. Sorbitol dehydrogenase in any species, SDH, the half-life is less than 12 hours. So these specimens really can't be mailed off to the laboratory or transported over long periods of time without losing considerable enzyme activity. Those that have a moderate half-life that are going to go about a day and a half to 2.5 days would be aspartate aminotransferase and alanine aminotransferase. Long half-life enzymes would be alkaline phosphatase in dogs, 72 hours, and gamma-glutamyl transferase, 96 hours. Okay, let's see, we've basically been through that. Yes?
The leakage enzymes, or ALT, in terms of a rapid release, the question may not be able to be answered, but how quickly can you pick that up? There have been studies that show that ALT, with a known hepatic insult, ALT is released in X amount of time.
Yeah, I would say usually to detect it about 24 hours to 48 hours. Okay, and usually when I'm thinking about enzymes of hepatic origin, I like to split them into the leakage enzymes that sort of leak out of cells versus the induction enzymes that are stimulated by drugs or some other perturbation. Leakage enzymes include alanine aminotransferase, aspartate aminotransferase, sorbitol dehydrogenase. These enzymes are usually present in the cytosol, such as ALT, or in the cytosol and mitochondria. Examples would be AST and SDH. So if we get increased membrane permeability, if it's a plasma membrane, you're going to get rapid leakage of ALT, but it's going to take more severe injury that also involves mitochondrial membranes before you get marked elevations in AST and SDH. There also is a concentration gradient effect. It's higher in the cell than outside. So once the cell membranes are increased in their permeability is increased, it's going to take a while for the effect to appear, say, in serum from leakage. Another basic premise is that the greater the number of enzyme-producing cells that are injured, the greater your serum activity is going to be. And let the buyer beware. We'll take that basically at face value, and I'll talk a little bit about that later. Examples of induction enzymes are alkaline phosphatase and gamma-GT. And these enzymes are membrane-bound, usually associated with brush border. They are often induced by drug treatment, particularly anticonvulsants like phenobarbital, barbiturates, corticosteroids. Induction of enzymatic activity occurs within a few days. It peaks over 3 to 4 weeks, declines slowly to baseline. So the decline to baseline may take ultimately weeks to months. All right, let's go back with our leakage enzymes. A little bit about ALT. I mentioned it's located in the cytosol and it leaks readily. This particular enzyme is very liver specific in cats, dogs, ferrets, hamster, mouse, rabbit, and rat. Decreased concentration of this enzyme in the hepatocytes of other species limits its use. So it's not a good marker for leakage of hepatocytes in certain species. This is the case in large animals, guinea pigs, and birds. There isn't a lot of ALT in the liver, not enough to make it worthwhile to assay. So what we're going to do in those animals is we're going to be looking usually at aspartate aminotransferase, AST. And activity of AST is present in not only liver, but also in muscle. So then the problem comes in trying to determine where the origin of the increased enzymatic activity is. All right, mild ALT activity can be seen in hemolyzed samples via red blood cell lysis, and also from muscle damage. So here's a neat little thing that you can remember if you like trivia. Although ALT is not measured in large animals, if you're getting a multi-test panel that has it and you find your SGOT is within the reference interval and your ALT is markedly increased, it's probably coming from muscle. We'll see that a lot in capture myopathy in deer. All right, ALT activity usually correlates with the number of cells damaged, but it doesn't differentiate a focal from a diffuse hepatic lesion. We might need histopath to do that biopsy. And it really doesn't differentiate a reversible from irreversible insult. Okay, so we may need some other additional information to be able to make that call. ALT activity does not always correlate with hepatic insufficiency. And the reason for that is if you have marked hepatic fibrosis, ALT activity may decrease when hepatic function tests are abnormal. Alternatively, increased ALT activity may occur in acute injury when function tests may still be normal at that time. Serum half-life of ALT is about 3 to 5 days, so following hepatic injury, ALT activity will peak in 1 to 2 days and then slowly return to baseline over 2 to 3 weeks. And elevations in serum enzyme activity will vary with the disease state or the insult. And this is just to give you some examples. Most of these have been cases I've seen in dogs. Severe blunt trauma, toxic insults to the liver, 100-fold increase in activity. Bile duct obstruction, bile will have a detergent action on cell membranes and cause leakage. So ALT can be elevated 40-fold with bile duct obstruction. Mild to moderate elevations with corticosteroids or anticonvulsants about 4 times the upper end of the reference interval. Surprisingly, increased ALT activity may be very mildly increased or not increased at all in fatty liver. And the degree of increase in enzymatic activity is highly variable with minor trauma or hypoxia. What we usually look for is a 50% decrease in ALT activity over 1 to 2 days after acute injury. That is a favorable prognostic sign to us. If we get a 50% decrease in activity in 1 to 2 days. However, let the buyer beware. Decreased ALT activity may actually have an unfavorable prognosis if we've had massive hepatic necrosis and now we've exhausted the supply of cells that have the enzymes, so there are no cells to release anything else to measure on the clinical chemistry testing. Also with chronic hepatic fibrosis, there may be a loss of functional hepatocytes. They're replaced with fibrous connective tissue, which isn't a source of ALT. Aspartate aminotransferase is another leakage enzyme, also known as SGOT. As I've mentioned, it's located in the cytosol and mitochondria. But the big problem with AST is it's not liver specific. You'll get some AST activity in a hemolyzed sample where the origin is lysed red cells. Also, you get pretty good SGOT or AST activity from damaged skeletal muscle and to a lesser extent cardiac muscle. It depends on the mass of muscle that's injured or damaged, and usually you have less heart muscle as composed to skeletal muscle. So what we'll do is use the AST assay in conjunction with CK, which is creatine kinase. Creatine kinase comes from muscle, and we'll do both enzymatic assays at the same time to try to determine whether the increased AST activity is of muscular or hepatic origin. So this is what we'll be using, these two things in concert in guinea pigs, birds, and large animals. Overall, AST is more sensitive than ALT in detecting a change or injury, but it's less specific to denote liver injury. But for your interpretation, you can think of it as a leakage enzyme just as you would ALT. The only thing is you have to make sure that the increased AST activity is from liver if you're interested in liver disease and not from muscle or hemolysis. Sorbitol dehydrogenase, another leakage enzyme that's located in the mitochondria and cytosol, and this is a liver-specific enzyme, and it's very good to use in large animals, especially in rats. It's preferred, and mice. There's really no advantage in assaying this over ALT in small animals because the half-life is short. You can't send samples by mail. So we still primarily use ALT for small animals, and we'll do SDHs on large animals from the clinic and some of the laboratory animals. Okay, because of the short half-life, less than 12 hours, you can't mail the samples to the laboratory for analysis of SDH activity. Another consideration is that SDH activity, because of its very short half-life, rapidly returns to the reference interval post-injury, within 4 to 5 days of injury. So the thing here is that the SDH activity may normalize before AST will normalize following hepatic injury. So if there's been a delay in presenting the patient to to the clinic for laboratory testing, SDH may have returned to baseline, whereas if you were doing AST, you could still detect evidence of organ or tissue damage. All right, and again, an asterisk by the fact that this is the best leakage marker in the rat. Alkaline phosphatase, an induction enzyme. It's membrane bound and has very high sensitivity but low specificity. The biliary tract is usually responsible for normal serum activity, especially in dogs. However, alkaline phosphatase activity measurement of that is pretty useless in animals as a marker of cholestasis because the reference interval is so broad. You really have trouble distinguishing health and disease because of the broad reference interval. Other things to know about alkaline phosphatase is that activity of this enzyme will markedly decrease in pregnant rabbits. Really decreases. May go below reference intervals. Alkaline phosphatase activity also is decreased in guinea pigs that have been fasted, that are in stages of starvation, or that have scurvy. And they think that a lot of the alkaline phosphatase activity in guinea pigs is from the bone isoenzyme. Various isoenzymes of alkaline phosphatase are produced. The bone isoenzyme may be prominent during growth in young animals and bone disease. Otherwise, in the adults, the biliary tract is responsible for most of the serum alkaline phosphatase activity. In the rat, however, the main isoenzyme responsible for serum alkaline phosphatase activity is the intestinal isoenzyme in rats. And that doesn't tell you anything about cholestasis, right? Measuring an intestinal isoenzyme. So in rats, you might want to use 5' nucleotidase as your cholestasis marker. All right, a little bit more about alkaline phosphatase isoenzymes. There is one of hepatic origin. There is a bone isoenzyme. It's most prominent in young, growing animals with a lot of osteoblastic activity. And it also is the main source of alkaline phosphatase activity in the serum of hamsters. How many of you in here have bled hamsters routinely for clinical chemistry? Not the easiest thing in the world to do. They are tough to get blood from. Okay, steroidal alkaline phosphatase isoenzyme is of concern only in dogs. It's associated with corticosteroid production, endogenous or exogenous drug administration, and because of its importance, I'll speak to it specifically in a moment. The intestinal isoenzymes usually are very short-lived, particularly in domestic animals like dogs and cats, but the intestinal isoenzyme is the main form of alkaline phosphatase in the serum of rats, and that's why it's not a good marker of cholestasis in rats. So consider 5' nucleotidase. Other sources of alkaline phosphatase isoenzymes include the renal cortex in the brush border of the renal tubules. Sometimes in the placenta of some species during third trimester. Rabbits are an exception, again, because during pregnancy, alkaline phosphatase activity decreases. And another thing to remember is that alkaline phosphatase is present in colostrum, and it's been shown that nursing puppies and calves will have high alkaline phosphatase activity associated with colostrum ingestion. The hepatic isoenzyme of alkaline phosphatase produces most of the serum activity in animals, exceptions being the hamster, where the bone isoenzyme produces most of the activity, and rats, where intestinal isoenzyme produces most of the activity. The hepatic isoenzyme can be inhibited by levamisole, and it will cut its activity by 90% or more. Alkaline phosphatase also can be induced with various drugs or in certain disease conditions. In cholestasis, enzyme activity may increase 50 to 100-fold. Very mild increases 4 to 6-fold with anticonvulsant administration. And corticosteroids can also elevate enzymatic activity markedly. And this may be one of the reasons to consider 5' nucleotidase as a marker of cholestasis. The steroidal isoenzyme occurs only in the dog. It's induced with endogenous and exogenous corticosteroids, and it will appear within 30 days with chronic corticosteroid exposure. Within 30 days. I've seen it come up faster than that. And this isoenzyme is not inhibited by levamisole. So activity decreases less than 10% on exposure to levamisole. So it can be said that the steroidal isoenzyme has high resistance to levamisole. Alkaline phosphatase bone isoenzyme increase osteoblastic activity, especially in those hamsters. Young growing animals, about a 3 to 6-fold increase in ALP bone isoenzyme activity. You'll sometimes see alkaline phosphatase activity increasing in various metabolic bone diseases or bone neoplasms, either primary or metastatic neoplasms that are involved in bone. And this isoenzyme, like the hepatic one, is inhibited by levamisole. All right, other isoenzymes of alkaline phosphatase include intestinal, renal cortex, placenta that we mentioned already, and their half-lives, at least of the renal cortex and intestinal isoenzymes, very short, 3 to 6 minutes. But despite a short half-life, the intestinal form is the major form in rats. Gamma-GT, or gamma-glutamyl transferase, is another induction enzyme used as a marker of cholestasis. Normal serum activity is from biliary origin, although with renal tubular lesions you can get an increase in gamma-GT activity in urine. We don't do a lot of measurement of GGT in urine to detect renal tubular damage, but it can be done. Okay, considerations in changes in gamma-GT activity are similar to those that we've already talked about for alkaline phosphatase. This enzyme can be induced by corticosteroid exposure, and it is a good marker of cholestasis in large animals because of its narrower reference interval. And marked serum activity of this enzyme is associated with colostrum ingestion. So the enzymatic activity can increase 1,000-fold just from colostrum ingestion. Bilirubin is falling out of favor, okay, because it's a non-specific test for liver disease. If you've got jaundice and you've got hyperbilirubinemia, what are your two things that you're thinking? One is you may have liver disease, right? That may be the source. The other thing is you might have hemolysis of red cells, and the jaundice is secondary to processing all the red cell breakdown products, including bilirubin. When would you have suspicion of hyperbilirubinemia? First, if you have clinical jaundice or icterus. And usually the bilirubin concentration in serum needs to be 2 to 3 milligrams per DL before you start turning yellow. Another consideration is that yellow plasma may be due to beta-carotene pigments. This is especially true in adult horses and ruminants, but not in newborn large animals. Beta-carotene pigments. Usually to see yellow discoloration of plasma, if it's due to bilirubin, the concentration needs to be in the area of 1.5 milligrams per DL. So it doesn't have to be elevated as severely as it does to see it in the sclera. All right, bilirubin metabolism. This is just to give you sort of an overview where the red cells are destroyed. The heme, the iron is recycled, the biliverdin is converted to bilirubin, which is bound by albumin, and is carried to the hepatocyte, which is going to take the free bilirubin, conjugate it, and excrete it in the bile. This bilirubin metabolism chart, before you get busy writing and just scribbling all this stuff down, this is straight out of Duncan and Prossie Veterinary Laboratory Medicine, borrowed from my major professor. Okay, same sort of thing. The macrophage or hepatocyte will process the red cells. We get hemoglobin, which is broken down to heme. The iron is recycled. The bilirubin comes from the cracked open tetrapyrrole ring. It would be bound to albumin and transported as unconjugated bilirubin. It's taken up by the hepatocyte. It's conjugated. Now it's water soluble, and it's excreted in the bile. If for some reason you have blockage of bile flow, conjugated bilirubin can re-enter the circulation, and conjugated bilirubin is water soluble, so it'll pass out in the kidney, in the urine. Also, some of the bilirubin that goes into the intestinal tract will be modified by bacteria to urobilinogen, which will be absorbed in the portal vein and then excreted in the urine. So if you get a positive dipstick test for urobilinogen, all that basically tells you is that you're getting some absorption from the intestinal tract. All right, what are some of the mechanisms of hyperbilirubinemia? One could be retention of bilirubin, where production is increased, decreased uptake by the hepatocytes of the albumin-bound form of bilirubin, or decreased hepatocellular conjugation for excretion. Another major mechanism of hyperbilirubinemia can be cholestasis, obstruction of bile flow. And this can either occur outside of the liver or within the liver. All right, what about unconjugated hyperbilirubinemia? This is before the liver can work on it and conjugate it for excretion. If we have unconjugated hyperbilirubinemia, it can indicate very early hemolysis or massive internal bleeding. And the alkaline phosphatase and GGT at this time may be within the reference interval. Unconjugated bilirubin is insoluble at physiologic pH, and that's why it's bound to albumin for transport. And as you would expect, if it's insoluble, it's not going to pass out in the urine, so there'll be a lack of bilirubinuria or detected bilirubin in the urine. Unconjugated bilirubin is the predominant form in horses and ruminants, no matter what the cause of disease. It's an important point. Unconjugated bilirubin predominates no matter what the cause of disease in horses and ruminants. And secondly, all you need to do is take horses off feed and they'll become hyperbilirubinemic. Horses don't have a gallbladder. Another piece of trivia. Conjugated hyperbilirubinemia. This is most common in liver disease and obstruction of bile flow, except in large animals where the unconjugated predominates. There usually is an increased activity of alkaline phosphatase and gamma-glutamyl transferase with it, gamma-GT. Conjugated bilirubin is water soluble, so it can be excreted in the urine. It's important to know that bilirubinuria precedes hyperbilirubinemia. That's one of the reasons for doing a dipstick test on urine. You'll detect increased bilirubin excretion in urine before you can detect increased concentration in serum or plasma. Another thing to remember is that dog kidney, the renal tubules, can excrete small amounts of bilirubin, so it's not unusual in urine samples from dogs to have a trace bilirubin reaction. But finding bilirubinuria is abnormal in other species of animals and has clinical significance. All right, what about our unconjugated or albumin-bound form of bilirubin versus the conjugated or water-soluble bilirubin? Determination of conjugated and unconjugated bilirubin can't reliably distinguish hemolytic disease, where you get destruction of red cells, from intra and extrahepatic diseases. And that's what limits the usefulness of bilirubin assessment, and it's really beginning to fall out of favor. So what you can do is you can use hematocrit, alkaline phosphatase, GGT activity, and other liver function tests to get a handle on what's going on. Bilirubin is not in vogue at the moment. But boards are, right? So what you need to know is if they give you a yellow rat, abnormal bilirubin metabolism in rats, just a little bit for you here. Gun rats lack bilirubin, uridine, diphosphoglucuronate, glucuronyl transferase. That's a mouthful. It's like a sobriety test. And what happens here in these rats is that they have a high total bilirubin, but they don't have any conjugated bilirubin because they don't have the enzyme that's involved in conjugation. So the hyperbilirubinemia can be associated with nephrotoxicity, neurotoxicity. And these gun rats that are type of Worcester rat or derived from Worcester rats are nice models for Crigler-Najjar syndrome in people. Other causes of yellow rats include one that's called a TR rat. TR stands for transport minus. It's a Worcester rat. There also is another one that's called a GY rat, which is a Groningen yellow, which is another type of Worcester rat. And then the EHBR, Sprague-Dawley rats, and these are Assai hyperbilirubinuria rats. This last one, this EHBR Sprague-Dawley rat, will have some mesangial proliferation in the glomerulus. But these latter three usually have a defect in the same gene that interferes with bilirubin excretion, transport and excretion. And these are models for things like Dubin-Johnson syndrome and Rotor syndrome of human beings. Okay, so a little stuff about rats that they may ask you on the lab animal part or even on the ClinPath thing if they get mean and ugly.
Can you go back for a second? Tell us another story.
So I have a question about freezing serum or using frozen serum samples. How does that affect the enzyme activity?
It depends on the enzyme in question. Some things like alkaline phosphatase activity may actually increase with freezing and storage. Some may have no effect, some may decrease. And for some enzymes, if you go to the literature, some say nothing happens, some will tell you it decreases, and some it increases. So I haven't got an easy answer. Are we ready to move on from the yellow rats? What's that? Does fasting induce hyperbilirubinemia in rats? Not to my knowledge, but I don't do tremendous numbers of rats. Okay, bile acids. Bile acids are very popular at the moment. They're very stable compounds that are derived from cholesterol, and cholesterol serves as the source of this for formation of primary bile acids, which are called cholic acid and chenic acid. These are in any biochemistry book. They are modified to the secondary bile acids, which are deoxycholic and lithocholic acids. Furthermore, these bile acids are usually conjugated to either glycine or taurine, so they can be called taurocholic acid or glycolithocholic acid, things like that. Okay, these usually are good tests to run because bile acids are stable. The results of the tests are much easier to interpret than dealing with bilirubin. This is a spectrophotometric test, but the only thing you need to realize is you need 2 samples for proper assessment of bile acids. You need a fasting and a 2-hour postprandial sample. So bile acids are synthesized by cholesterol, they're conjugated, they're stored in the gallbladder if the species in question has a gallbladder. Following stimulation from eating, the gallbladder contracts, the bile acids are released into the small intestine, then they're involved in emulsification of fats, a digestive function, they're reabsorbed in the portal vein, and 95% of the bile acids are removed on the first pass by hepatocytes. So serum bile acid concentrations in health are low. They're removed, they're recycled, they go around the merry-go-round again. If you have a portosystemic shunt that bypasses the liver, this is one of the reasons you'll have high bile acid concentration. So what are some reasons for increased bile acid concentration? First would be hepatocellular disease, particularly those where we've lost hepatocytes. We no longer have enough to take these things up and recycle them. You could have increased bile acid concentration from failures in conjugation, but that's sort of rare. Cholestasis, or blockage of bile flow, will cause decreased bile acid secretion and regurgitation with increased bile acid concentration. Portosystemic shunts, the highway bypasses the liver and goes directly from the portal blood into the systemic circulation. If it bypasses the hepatocytes, the bile acid is not going to be taken out and recycled. So pretty simple. Other considerations for bile acids, you really can't detect a decrease in bile acid concentration because these things are recycled. It's hard to detect a decrease. The other thing is clinical problems like dehydration, hypovolemia, chronic passive congestion have little effects on serum bile acid, but they have great effects on dye excretion tests and things like that. But because they have little effect, that's one of the beauty of bile acids. All right, we're approaching break time. I wanted to show you some cases, so let me go quickly through this part. Very few people do cholephilic dye excretion tests. These are the old BSP and ICG. They're not performed because BSP is irritating and only one company makes it, and infrequently. ICG isn't done very often because it's expensive. Cost of ICG to do a dye excretion test on a small beagle is about $300 for the dye. And usually with these dye excretion tests, you would either measure dye retention at 30 minutes after injection or its T1/2 of disappearance. So it's too cumbersome for routine clinical use, and it's not used that much. Also, there are a number of things that will affect test interpretation. Increased retention of dye, you'll have that if you have decreased hepatic blood flow, decreased hepatic functional mass, hyperbilirubinemia. The bilirubin competes for the albumin for dye binding. Albumin binding drugs will displace the dye. Decreased retention if it's spread out through the tissues with anasarca, ascites, obesity. Hypoalbuminemia where you don't have enough albumin to bind the drug and it's binding to other proteins. But I put this on to show you that you take a pre-dye injection sample and then you look for disappearance over time or retention at 30 minutes. Not used much. Tests of portal blood clearance include ammonia measurement, not done very frequently because you have to take the sample, put it on ice. You can't keep the tourniquet on the limb very long or the ammonia concentration goes up. Another test of portal blood clearance would be antigen clearance by Kupffer cells. If antigens reach the systemic circulation, they will invoke a mild immune response with globulin production, and a polyclonal gammopathy will result. Blood ammonia, again, is a cerebral toxin that can be quantitated. Bile acids have largely replaced determination of blood ammonia concentration. Clinical suspicion of hepatic encephalopathy from ammonia toxicity, excitability, tremors, head pressing, blindness, convulsions. Thing to know is that the ammonia is toxic. The ammonium ion is not toxic. It's not absorbed. For ammonia, what you need to do is have an 8 to 12 hour fast. You get a baseline sample. It's got to be quickly collected in ammonium-free heparin. It's got to be stored on ice. It's got to be tested within an hour. If you freeze the sample at -20, it's still got to be tested within 48 hours. So you can see this is a pain in the fanny, right, compared to doing bile acids. Venous occlusion will increase ammonia. So this is sort of difficult to provide. Ammonia tolerance tests, if you've been reading about that, it's not indicated if you have a high baseline ammonia because you could push the dog into toxicity. Basically what you're doing is getting a baseline, then give ammonium chloride, collect a sample in 30 minutes, 3 to 10 infold increase infold, 3 to 10-fold increase over baseline following the ammonia tolerance test indicates an abnormality. This is urine sediment with ammonium biurate crystals. They look like little thorn apples. They have little thorns coming off of them, associated with portosystemic shunts. All right, and basically this is a scheme of ammonia metabolism, urea cycle, forms urea, and that's usually the excretory product. In some species, uric acid is important too. Humans, primates, and birds. So, increased plasma ammonia, the most common cause, hepatic insufficiency, but you have to have a tremendous decrease in functional mass. Portosystemic shunts are relatively common. They can either be congenital or acquired. The liver atrophies because of a lack of stimulus by hepatotrophic factors. Look for ammonium biurate crystals in the urine. Other causes of increased plasma ammonia include urea toxicosis as a feed additive in ruminants. That's infrequent. And the urea cycle enzyme deficiencies, congenital condition, they're rare. Hyperglobulinemia, a portal clearance of antigens. This is when we get the hyperglobulinemia in liver disease, it's usually due to decreased Kupffer cell mass where the antigens are now getting into the systemic circulation, provoking an antibody response that shows up as a polyclonal gammopathy. And if they give you an electrophoretogram, for some reason my symbol didn't transfer, beta-gamma bridging. The beta globulins and gamma globulins flow together. Beta-gamma bridging on electrophoresis. All right, there are certain tests of hepatic synthesis that can be done. These include glucose, which is stored as glycogen, albumin production, hemostasis tests we'll talk about in the last hour, bile acid production and recycling, and cholesterol synthesis. And glucose. With severe liver disease, you can get a fasting hypoglycemia, but usually this means about 80% of the liver mass is non-functional. Also, following eating, you get a prolonged postprandial hyperglycemia because there are no or too few hepatocytes to serve as a storage unit. I've talked about albumin and globulin. To get hypoalbuminemia from decreased production by the liver, 80% loss in functional hepatic mass, usually seen in chronic disease. Hemostasis tests, we'll talk about these in detail later, so let's skip this for now. Okay, other tests of synthesis, I mentioned the bile acids and cholesterol. And I love this little cartoon here with the fortune teller and the young lady telling her fortune in the crystal ball. She says, I see a man in your future. He's very rich, he's very old, and he has very high cholesterol. Okay, so cholesterol concentration is more of interest in human medicine and certain research related to atherosclerosis and things of that nature. Just to show you a few examples of some changes. This first one, increase in ALT activity, mild increase in alkaline phosphatase, was a dog that was treated with caparsolate for heartworm disease. And notice that it has a mild hyperbilirubinemia and is primarily a direct or conjugated. Let's see what we have on number 2 is a Doberman Pinscher with anorexia, depression, vomiting, ascites, and icterus. And on the second dog, there is an increase in ALT activity, increase in alkaline phosphatase, and notice that the alkaline phosphatase value following levamisole goes from 831 to 110. So this is 86.8% suppression, indicates it's the hepatic, probably the hepatic isoenzyme, although the bone isoenzyme will suppress too. There's a hypoproteinemia, hypoalbuminemia with a decreased AG ratio. So this means that either the albumin is not being produced or perhaps it is being lost. We need a urinalysis to see what we had there. Let's see, BSP and ammonia not done very frequently anymore. Case number 3, just to mention this, we have increased ALT activity. This is a miniature poodle, PUPD, hepatomegaly. This one had been given corticosteroids for a skin condition. And what I wanted to show you here was the alkaline phosphatase activity is increased following levamisole exposure, very little decrease in activity. So it resists the effects of levamisole inhibition, indicating it's the steroid isoenzyme. Case number 4 is an obese cat with anorexia and vomiting. And the major thing to see here is that we have evidence of liver involvement, elevation in ALT and alkaline phosphatase, mild hyperbilirubinemia. This one was a cat with hepatic lipidosis on biopsy. It required a biopsy to get through it. The last one is a horse, somnolescent horse. And what I wanted to show you on this one was the AST, if it's elevated alone, we would need to use creatine kinase to determine if the increase in activity was due to liver or muscle. CK is within the reference interval, which indicates it's liver. But better still, we have sorbitol dehydrogenase, which is liver specific, and tells us that we have hepatocyte leakage. Also notice that we have cholestasis here with a high GGT. Hypoalbuminemia is also present. We need to know if we have any renal loss or if it's just lack of production. And this horse also had hyperammonemia. And this was liver disease due to crotalaria or some other poisonous plant ingestion. Okay? So just some quick examples. And I know we're a little bit behind the break, I think, but this would be a nice. The last topic of the day I call simplified hemostasis, and some of my previous students are here, so they've been real sports staying awake through some of this. And I've modified the hemostasis even from the professional course, because this is the 1-hour crash course for practitioners and other interested individuals to learn how to evaluate hemostasis problems. All right, there are 3 basic things to think of associated with hemorrhage. First, we need to know about vessels, because injury or abnormalities of the vessels will result in hemorrhage. The second important item is platelets. We need the correct number of platelets to plug leaks. We need correct function of platelets, or we're going to get bleeding. The third thing to consider are the clotting factors. The clotting factors can either be totally absent, they can be abnormal in their conformation and not work properly, or there may be something that is inhibiting their activity, and it will result in bleeding. So the 3 major things to think about whenever you have bleeding are integrity of vessels, number and function of platelets, and clotting factors. All right, vascular injury or abnormality. Sometimes, this is readily apparent. Following trauma, accidental trauma, or elective surgery, you may be able to see bleeding. Bleeding involving vessels may be localized. An example would be an ulcer, or widespread, as would be the case in some animals with septicemia. In addition, diseased vessels may also be of concern, and this could be inflammation involving the vessel wall, which is vasculitis, or actual necrosis of the vessel or vessel wall. Sometimes the vascular lesions are inapparent. They're not visually riveting, and these things are referred to as purpura. Some examples of vascular purpura: if you have guinea pigs, be sure to give them plenty of leafy green vegetables because they're very susceptible to scurvy. Equine purpura hemorrhagica, another cause of vascular purpura. Platelet problems can also cause bleeding, and I'll mention this again. You need an adequate number of platelets in circulation to plug the small leaks. They've got to function properly, or you end up with petechial hemorrhages. And coagulation factor deficiencies can be acquired or hereditary. I'll talk to you about that as well. We can also have bleeding post-thrombosis, such as with thromboembolism, heartworm disease, amyloidosis, sepsis, and neoplasia, and it can involve vessels. All right, for platelets, the things that you need to be thinking about when you're considering these small pieces of shed cytoplasm from megakaryocytes is, do I have an adequate number of megakaryocytes in the bone marrow to produce platelets? The only way we can find that out for sure is a bone marrow aspiration biopsy or core biopsy and quantitate megakaryocytes. The second thing to consider with platelets is, are they able to function properly in the blood vascular system? For instance, if the animal has been treated with aspirin, you may have platelets that have been acetylated. They're not going to work properly in aggregation and release of their granules. Von Willebrand's disease. They may not have the von Willebrand's factor that allows the platelets to stick to subendothelial collagen and plug leaks. So, question number 2 on platelets: will they function properly in the vascular system? The third consideration with platelets is whether we have excessive use or destruction of platelets. Excessive consumption might be severely damaged endothelium throughout the body. We're using up the platelets faster to plug leaks than we can produce them. The other thing is we may have antibody directed against platelets that are destroying them, such as immune-mediated thrombocytopenia. And the third consideration, and the one that gives most people headaches, particularly on boards, because this is where they love to toss out some data to you: clotting factor considerations. Most of the clotting factors are going to be produced by the liver, and also the liver is important in activation of some clotting factors, particularly with its vitamin connection, vitamin K, and carboxylation of certain factors such as 2, 7, 9, and 10. You'll know them intimately in a moment. Secondly, the clotting factors need to have their proper structure to function correctly. If I had to sum up the clotting factors for you, and there are 13 that are pretty well described and written about in the literature, numbered almost 13. We'll get to that in a second too. I would have to characterize clotting factors as proteins, and they actually are enzymes. They're serine proteases. The only ones that are not serine proteases are factor 1, which is fibrinogen, factor 5 and factor 8, which are non-enzymatic factors, and factor 4, which is calcium. Okay? The rest of them can be thought of as serine protease enzymes. So some of the factors, the non-enzymatic ones, can be consumed in certain disease states. And usually it's not a problem consuming factor 4, which is calcium, but the ones that are most subject to excessive consumption are the non-enzymatic factors, fibrinogen, which is also known as factor 1, factor 5, and factor 8. The other consideration for clotting is clot formation and degradation. And another test that is frequently done is to quantitate FDPs, which are fibrin or fibrinogen degradation products. And when I think about hemostasis abnormalities involving clotting factors, I also wondered whether the condition is acquired or hereditary. If it's an hereditary condition, usually only one factor is missing. If it's acquired, multiple factors are involved. And the two most common acquired coagulopathies are disseminated intravascular coagulation, DIC, and rodenticide toxicosis. Now, at this point in the program, I thought I would just mention to you the nomenclature of the clotting factors so we'll be on common ground. These clotting factors are designated by a Roman numeral. Once the factor is activated, they'll have a little A after it, indicating activated. And the name may or may not change accordingly, too. Factor 1 is probably known more as fibrinogen. It's known by its name, fibrinogen. And once you split fibrinogen, you're ending up with fibrin initially. Factor 2 is prothrombin. And if you activate factor 2, if it was 2A, that would be called thrombin. Okay? Factor 3 is tissue thromboplastin or tissue factor, and that's the one that you never run out of as long as you're alive. It's derived from fresh tissue. Factor 4 is calcium, an ion that's important in clot formation. Factor 5 is usually referred to by a number, but the name is proaccelerin. The easiest one of all is factor 6. It doesn't exist. Somehow it got overlooked. Okay, so it's not around. Factor 7 is referred to by its number. It's proconvertin. Factor 8 is the name of it is anti-hemophiliac factor, but frequently it's known as hemophilia A. So you're either talking about the condition hemophilia A or the factor, factor 8. Likewise, for factor 9, it's either referred to as hemophilia B or factor 9 deficiency. But the family it was first described in was the Christmas family. That was their real last name, Christmas, in Great Britain. And the article describing the absence of this factor 9 was published in the Christmas holiday issue of Lancet. So tell me that hematologists don't have a sense of humor. Okay, factor 10 is Stewart-Power factor. Factor 11 is referred to in the literature often as PTA. You'll see that. Plasma thromboplastin antecedent, or PTA. Factor 12 is Hageman factor. 13 is fibrin stabilizing factor. And then there are two other molecules that are involved in the contact phase of clotting. One is called prekallikrein, known as Fletcher factor, if you want to put a name on it. The other one is high molecular weight kininogen, called HMWK or Fitzgerald factor. And before we move along, I thought I would mention John Hageman. John Hageman was a brakeman on the New York Central Railroad, and he had a problem with peptic ulcers, and back during his day, the treatment for peptic ulcer was not Tagamet, it was surgery. And before you went in for surgical excision of your gastric ulcer, they did a hemostasis profile, routine workup prior to surgery. Guess what? His blood wouldn't clot. Never had any bleeding problems in his life, but his blood wouldn't clot. And from that, they they identified the missing factor as factor 12 and named it in his honor, Hageman factor. Now I heard that he died, I think, when he was in his 50s, and I heard that he fell from a train, broke his hip, and died of a blood clot. So if that's true, there's no justice in this world, right? But he was on the cover of Journal of Laboratory and Clinical Medicine in 1987, the year he died. All right, some tests associated with laboratory evaluation of hemostasis. And we'll go through these first, and then we're going to get into the nuts and bolts. One test is platelet counts, because we need adequate number of platelets to get good hemostasis. The second test of hemostasis is bleeding time, where we make an incision in a mucous membrane, see how long it takes for the bleeding to stop. Then the rest of the tests are usually done in little mixing containers. These would be the activated clotting time, called the ACT, activated partial thromboplastin time, called APTT, one-stage prothrombin time, or OSPT, and thrombin clotting time, TCT. Fibrinogen can be quantitated with the thrombin clotting time. That's the most sensitive measure of fibrinogen, or by heat precipitation methods if it's increased. As clots and fibrinogen are degraded, they form fibrin or fibrinogen degradation products, and these are usually measured by an agglutination test on a card. I'm going to go through each of these tests. They'll make more sense as we talk about them and build a coagulation cascade. Platelet counts can be done by manual or automated methods, and what we're doing is enumerating platelets. And if an automated platelet count doesn't seem to fit the patient, you can always go back to the blood smear and look at it and make sure the platelets are not aggregated, because if they're aggregated, the machine is going to count them as if they were one big platelet. So pseudothrombocytopenia can be a problem with platelet aggregation. I'm aggravated. Platelets are aggregated. Okay, the other thing that can be done is we can evaluate platelet size by visual inspection, or the machine can measure the platelets and give us a mean platelet volume, or MPV. Usually if we have a turnover of platelets, the younger platelets are bigger. They have a higher MPV. So what about thrombocytopenia then? Again, we would be concerned of lack of production of platelets in the marrow. We need to think about increased consumption in the vascular system, or increased destruction, which is immune-mediated cause. The bleeding time test. In the bleeding time test, what we do is take a mucous membrane and make a standardized incision. It's usually 1 millimeter deep and 10 millimeters long. Start a stopwatch, blot it with filter paper until the bleeding stops. And what this primarily does is evaluate platelet function. So the bleeding time test is dependent on an adequate number of platelets, an adequate function of platelets, and vessel integrity. And the formation of the platelet plug is independent of clotting factors. Everybody understand that? That's important. So when do you have a prolonged bleeding time? First of all, with thrombocytopenia, less than 75,000 platelets per microliter, you may have petechial hemorrhages. Secondly, prolonged bleeding time will occur if we have altered platelet function. And this can be due to congenital disease or acquired conditions, such as administration of aspirin or non-steroidal anti-inflammatory drugs. That will alter platelet function. They don't undergo aggregation and release properly. Von Willebrand's disease, hereditary condition. Platelets lack von Willebrand's factor that helps them stick to subendothelial collagen. Also, certain substances in uremia or fibrin degradation products in excess can interfere with platelet function. Okay, so prolonged bleeding time can be due to thrombocytopenia or altered platelet function. The third reason for prolonged bleeding time is vessel abnormality. The best example here is scurvy in guinea pigs. Scurvy in guinea pigs. lack vitamin C, they don't get cross-linking of collagen, the vessels are weak, they blow out. It's like a blowout in an old tire inner tube. The activated clotting time measures the time in seconds for whole blood to clot in a glass tube that's been warmed to 37 C, body temperature, and the blood in the tube is exposed to a granular contact activator, something like a kaolin clay or diatomaceous earth. And what the activated clotting time test does is it evaluates the intrinsic and common systems of the coagulation pathway. I'll put all this together in a minute, I promise you. It evaluates the intrinsic and common systems of the clotting cascade, but it requires platelets for the phospholipid in this test. So if you have thrombocytopenia less than 10,000 platelets, the activated clotting time is going to be prolonged. And the activated clotting time test is not as sensitive as the activated partial thromboplastin time test. With the ACT, you need a severe factor deficiency, less than 5% of factor activity remains, to get an abnormal ACT. Whereas with APTT, 30% or less activity remaining will give you an abnormal test. So, what things will give us a prolonged activated clotting time? Severe thrombocytopenia. Some thrombocytopathies, this is where platelets don't function well, but those things are rare. Severe factor deficiency in the intrinsic or common systems with less than 5% activity remaining. So if I needed to tell you the intrinsic factors would be 12, 11, 9, 8, common factors 10, 5, 2, and 1. Don't worry about it, we'll get to it and make perfect sense here in a moment. Also, inhibitors that prevent clot formation, such as heparin, fibrin degradation products, certain products in uremia, may give you a prolonged activated clotting time test. The activated partial thromboplastin time measures the time in seconds for clot formation in citrated plasma after we come back and add a contact activator, we add phospholipid, and we add calcium. So to the citrated plasma, we add contact activator, phospholipid, and calcium. Just like the ACT, this test evaluates the intrinsic and common systems, not extrinsic, intrinsic and common systems. The factors that it evaluates are 12, 11, 9, 8 of the intrinsic, 10, 5, 2, and 1 of the common. And it detects moderate decreases in factor activity. So if we have less than 30% factor activity remaining, the APTT is going to be prolonged. You follow me? This test is independent of platelets because we've added the phospholipid to the test vessel. And we can use modifications of the activated partial thromboplastin time to document specific factor deficiencies. And I may have time to talk about that a little bit more later. When do we get a prolonged APTT? One thing would be contact activator deficiencies, like prekallikrein deficiency would be an example. We could get a prolonged APTT if we have deficiencies of intrinsic or common factors, clotting factors, with 30% or less activity remaining. So some examples might be factor 12 deficiency, hemophilia A or B, which would be factor 8 or 9 deficiency. Von Willebrand's disease, the animals lack von Willebrand's factor on the platelets, and they're also factor 8 deficient. DIC, consumption of fibrinogen 5 and 8, 1, 5, and 8. Vitamin K deficiency, 9 is in the intrinsic, 10 is in the common, 2 is in the common, 7 is in the extrinsic. Don't worry about it, I'll make it crystal clear for you. The one-stage prothrombin test also uses citrated plasma and measures the time in seconds for clot formation in this citrated plasma after we add thromboplastin and calcium. Thromboplastin and calcium. And this evaluates the extrinsic and common pathways. The extrinsic factors are 3 and 7, and the common pathway factors are 10, 5, 2, and 1. Okay, thrombocytopenia has no effect. The thing that you need to remember, or things you need to remember, factor 7 has the shortest half-life of all the coagulation factors. That's important. You just need to memorize it. Factor 7, shortest half-life. The other thing is factor 3, or tissue factor, you're never going to run out of as long as you're alive. Okay, so in the extrinsic pathway, the two factors there, 3 you're never going to run out of as long as you're alive, and 7 has the shortest half-life. All right, what gives you a prolonged one-stage prothrombin time? The first thing to consider might be hereditary factor 7 deficiency, because we're never going to run out of factor 3, but factor 7 deficiency could cause a problem. A factor deficiency in the common system, usually 10, 5, rarely 2, very, very rare 1. We could have DIC, disseminated intravascular coagulation, that would consume fibrinogen and factor 5, which are both in the common pathway. We could have vitamin K inhibition or deficiency, such as in coumarin poisoning, bile insufficiency, liver failure. And usually vitamin K dependent factors are 2, 7, 9, and 10. And with the one-stage prothrombin time measuring the extrinsic and common, factor 9 is in the intrinsic, so it's not of concern. The thrombin clotting time also uses citrated plasma, and it measures the time in seconds for clot formation after we add thrombin and calcium. And thrombin is the active form of what enzyme? Precursor. Prothrombin. And what's another name for prothrombin? Factor 2. So the only variable there is whether or not we have enough fibrinogen to make a fibrin clot, and whether we have any inhibitors in there of that clot formation. Okay, so the thrombin clotting time is independent of factor 2 which is prothrombin, because we add 2A, which is thrombin. Got that? What will give us a prolonged thrombin clotting time? First off would be hypofibrinogenemia, when the fibrinogen concentration is under 100 milligrams per deciliter. And this is because it is consumed usually in DIC, and that's why we're not getting the clot. Hereditary deficiency of fibrinogen is rare. The other thing is we could have interference of clot formation by excessive fibrin degradation products, by dysproteinemias, usually marked elevations of protein like in plasma cell myeloma, with heparin treatment, or with abnormal fibrinogen. In other words, fibrinogen is produced, but the molecule is abnormal. There's something wrong with it. That's rare too. So if I had to tell you prolonged thrombin clotting time, think decreased fibrinogen with DIC, think excessive FDPs, think excessive paraprotein, think heparin treatment. That'll get 99.9% of them. Fibrinogen or fibrin degradation products are split products of either the fibrin clot or the precursor, the fibrinogen molecule. And usually the FDPs are the result of cleavage of fibrin or fibrinogen by plasmin. Increased concentrations of FDPs indicate excessive enzymatic activity associated with clot lysis. All right, let's build a hemostasis cascade, and we're going to cover the whole thing, and we're going to do this nice and easy, and I should have a rendition of this somewhere in your book. The three things that you need to consider with bleeding: vessels, integrity of vessels, number and function of platelets, and clotting factors. So those three things. The next thing you need to realize is that the coagulation cascade involving the factors is like the letter Y. What was it, Men at Work or something that did YMCA? Just think of the Y in YMCA. And the factors, the end point of the coagulation cascade, whether it starts from the intrinsic or extrinsic side, is to convert fibrinogen into an insoluble fibrin clot. Convert soluble fibrinogen into an insoluble fibrin clot. Everybody has trouble putting the numbers, the Roman numerals, on the cascade, right? So let me tell you how to do it. We're going to the outskirts of Washington, and we're going to Tyson's Corner. You know where that is? You've been out there on a shopping binge, one of the greatest shopping malls in the world. So we're going down to Tyson's Corner, and we're going shopping for T-shirts. And there are 3 T-shirt companies. They're called the Intrinsic T-shirt Company. They're the in crowd. They make the Izod, Ralph Lauren type T-shirts. The other one is the Extrinsic T-shirt Company. They're sort of the outsiders trying to gain the market. So the Extrinsic T-shirt Company. And the last one is the Everyday Working Man and Woman's T-shirt Company, and that's the Common T-shirt Company. Okay, so intrinsic, extrinsic, and common T-shirts. Let me put the numbers in and tell you how these run. I told you that the Intrinsic T-shirt Company, they're like the Ralph Lauren or Izod, right? They have the highest price on every T-shirt you look at. They're $12 a piece. Do they ever have sales? Not really. If they have a sale, do they ever mark anything down? Not really. So the best you can do is a $12 T-shirt on sale by the Intrinsic T-shirt Company. They mark it down to $11.98. Okay? So the Intrinsic T-shirt Company, the Izod of the T-shirt world, start with $12 T-shirts, put them on sale for $11.98. That's the intrinsic system. All right, how about the outsiders over here on the extrinsic side? Well, they're trying to get their niche in the market too. And what they try to do is lure people with a $7 price for a T-shirt that's a lot less than the $12. $7 price. And if it doesn't sell, they do about a 50% markdown on it to $3. So roughly a little less than half of 7 is 3. Got it? But the one that I like to look for are products from the Common T-shirt Company, the Every Man and Woman's T-shirt Company. They try to make an honest buck, so they'll start their T-shirts at $10, but they're not above doing a 50% off and marking it down to $5. If that doesn't sell, they'll mark it down about another 50% to $2. And if that doesn't sell, they'll cut the price by half again to $1. So $10 to 5 to 2 to 1. That's the Common T-shirt Company. Everybody got it? Okay. One thing before we move on that you need to know is there's some corporate communication. I don't know if it's corporate espionage or what. But these guys over in the extrinsic, whenever they're running the $7 sale, they're over here looking to see what's the lowest price they're going to get here. So the 7 people talk to the 9 people as the sales go on. This is a way of cross-activating. Activated factor 7 of the extrinsic can come over here, activate factor 9, and then clotting can proceed. That's what that arrow is for. Okay, now we need to start putting in the tests, where they are and what they do. So since we've already talked about soluble fibrinogen being converted to insoluble fibrin, this can be chewed up by plasmin and produce FDP. So we can do an FDP assay and look for fibrin or fibrinogen degradation products. The other test that we talked about doing was the bleeding time test. And this is where we make a standardized incision in a mucosal membrane, blot it with filter paper, and time it with a stopwatch until the bleeding stops. Bleeding time is dependent upon vessel integrity and platelet number and function. Next test we talked about was the activated clotting time, and it depends on the platelets for the phospholipid to make the thing run, and it measures the intrinsic and common systems, 12, 1198, 10, 5, 2, and 1. Oh, is it? If extrinsic and intrinsic is backwards, they said on the handout, so get that right. Pin that in right now. The intrinsic has more numbers than the extrinsic. Sorry about that. I was in a hurry to get it done. Yes?
One other typo on section 2D, one-stage performance test. You have it as intrinsic and extrinsic.
Yeah, okay. OSPT, extrinsic, and common. Sorry about that, but having to do my own typing and cover 4 full-time positions is that's been tough for me, so forgive me those few little glitches. This is the correct stuff basically you're seeing up here. All right, let's do another test. APTT, activated partial thromboplastin time, independent of vessels, independent of platelets. All it's interested in is intrinsic, 12, 11, 9, 8, and common, 10, 5, 2, 1. Got it? One-stage prothrombin test. It evaluates the extrinsic and common, so 7, 3, 10, 5, 2, and 1. And thrombin clotting time basically evaluates fibrinogen concentration, because we add prothrombin in the thrombin clotting test. And what is we add thrombin. And what is thrombin? It's the activated form of 2, or prothrombin. All right, some numbers, if you're a number cruncher. For thrombocytopenia, to affect bleeding time test, less than 75,000 platelets. To affect the activated clotting time test, we need less than 10,000 platelets per microliter, because these provide the phospholipid. Severe deficiency in factor activity, less than 5% factor activity remaining for 12, 11, 9, 8, 10, 5, 2, and 1. APTT measures intrinsic and common systems. It's a little more sensitive than the ACT, less than 30% activity, prolonged APTT. Follow me? One-stage prothrombin time, less than 30% activity in factors in the extrinsic and common system. OSPT is prolonged. Factor 7 has the shortest half-life. Factor 3 we never run out of if we're alive. Thrombin clotting test, we mentioned the variable here is fibrinogen or inhibitors, and with FDPs, FDPs have to be greater than 32 micrograms per mil for us to say that they're elevated. The thrombin clotting time, I'll mention again, if the fibrinogen is less than 100 milligrams per DL, the test is prolonged. Let's try some cases. Case number 1, a mixed breed male dog, 10-year-old, stays indoors. This animal has pale mucous membranes with petechial hemorrhages, and on palpation, splenomegaly with an irregular contour. Now, first off, petechial hemorrhages suggest what? Thrombocytopenia, little pinpoint hemorrhages, lack of platelets or lack of platelet function. Let's do some data. First item, platelet count on the patient, 80,000. What's your interpretation? Thrombocytopenia, so we lack platelets, and the problem is, are they being consumed, are they being destroyed, are they not being produced? Not enough info yet. Second thing, bleeding time is 7 minutes. The reference interval is 1 to 5 minutes. So the bleeding time test is prolonged. What's your interpretation? Well, we know that we have to have at least 75,000 platelets to even stay within the reference interval, but that's cutting it pretty close, fine, thin line. So Thrombocytopenia may be prolonging this, or we could have some clotting factor problem too. But bleeding time is mainly platelet number and function, So I would be wondering, we have decreased platelets, how's our von Willebrand's factor and things like that. Let's look at the activated clotting time, ACT, prolonged at 120 seconds. Will thrombocytopenia prolong it? Yes, because platelets provide the phospholipid, although we've got 80,000 platelets, we should have enough phospholipid. Will clotting factor deficiencies prolong it? Yes, and what part of the coagulation cascade does this ACT evaluate? Intrinsic and common, 12, 11, 9, 8, 10, 5, 2, and 1. And does the factor deficiency have to be mild or severe to have an abnormal test? Severe, 5% or less of factor activity remaining. Okay, so let's move on then. The APTT, it measures the intrinsic and common pathways, 12, 11, 9, 8 of the intrinsic, 10, 5, 2, and 1 of the common, and it is prolonged. Does thrombocytopenia prolong this test? No. Why? Because we add phospholipid. Is the factor deficiency severe or moderate? Moderate to prolong it. 30% or less of activity, so it's more sensitive than the ACT, and it is prolonged. Let's look at the one-stage. Well, let's back up. So right here, what this is telling us is besides the thrombocytopenia, we've got a problem with a clotting factor in the intrinsic or common system. You follow that? So something, 12, 11, 9, 8, 10, 5, 2, and 1, something screwed up. All right, let's look at the one-stage prothrombin test. What does it evaluate? Extrinsic and common. Are platelets needed for a test to be performed? No, they have no bearing on it. And what can you tell me about the OSPT value of 18.5 seconds? It's prolonged, and we have 30% or less factor activity remaining for 3, 7, 10, 5, 2, or 1. What about fibrinogen concentration? It's decreased with a prolonged thrombin clotting time test. And what things prolong the thrombin clotting time? Fibrinogen deficiency, if it's less than 100 milligrams, which we have here, or some inhibitor thrown in the mix. What are these FDP things? Fibrinogen or fibrin degradation products. And the reference interval goes up to 32 micrograms per mil. What do you think of 256? It's high. So let's stop and look at what we've got here. We have thrombocytopenia with increased fibrin degradation products and decreased fibrinogen. And what might you think is a cause? DIC. What factors are non-enzymatic consumed in DIC? 1, 5, and 8. All right, we already know about 1. It's the fibrinogen. Factor 8 is located where? Intrinsic system. How about 5? Common system. So the APTT is prolonged because we lack 5 and 8 and 1. And the OSPT is prolonged because we lack 5 in the common system, 1 in the common system, and thrombin clotting time is prolonged probably because we're deficient in 1. So DIC, disseminated intravascular coagulation, consumption of platelets, factors 5 and 8 and fibrinogen, and generation of FDPs. Okay, this just reviews the tests and the... Okay, we have clinical evidence of bleeding with petechia. We verified that we had thrombocytopenia by the count and we would be thinking maybe increased use or destruction of platelets in this individual. You'd need a bone marrow to rule out decreased production of platelets. The prolonged ACT and APTT, the ACT tends to indicate a severe factor deficiency in the intrinsic or common system. The APTT is prolonged too, it's more sensitive. The OSPT suggests that the problem is with the extrinsic and or common, and the prolonged thrombin clotting time indicates hypofibrinogenemia. The increased FDPs suggest excessive clot lysis. So all these are the smoking gun for disseminated intravascular coagulation, an acquired coagulopathy. Let's see. This case had splenic hemangiosarcoma on biopsy, and it had disseminated intravascular coagulation. Very good. You did a good job on that. Case number 2, Chesapeake Bay Retriever, male 6-month-old, indoor dog, gingival hemorrhage with tooth eruption, excessive bleeding after routine castration. So we have 2 instances of hemorrhage, excessive hemorrhage in this individual. One at a young age with tooth eruption, the second time, unfortunately, after routine castration. The data, what about platelet count? It's within the reference interval. What about the bleeding time? Prolonged. What things will prolong the bleeding time? Platelet number and function. What do you think about platelet number? Fine. What do you think about function? It sucks, right? So, what are some things that would be associated with abnormal platelet function? It could be von Willebrand's disease, lack of von Willebrand's factor. It could be aspirin. It could be non-steroidal anti-inflammatory drugs and so forth. Okay, let's move along then. What do you think about the activated clotting test? Within the reference interval. So that means that we have adequate platelets for phospholipid, correct? And it is not detecting any severe factor deficiency in the intrinsic or common pathways, right? So it's not detecting any problem with 12, 11, 9, 8, 10, 5, 2, or 1. All right, next item of business. How about the activated partial thromboplastin time? It is prolonged at 29.9 seconds. And it evaluates the intrinsic and common system, but it is more sensitive than the ACT. So this tells us that we have a problem with one of the factors in the intrinsic or common pathway, 12, 11, 9, 8, or 10, 5, 2, and 1 in the common pathway. And it's more sensitive than ACT because 30% or less activity, we get an abnormal test result, right? Let's look at the one-stage prothrombin test, 7 seconds interpretation within the reference interval. And what does the OSPT evaluate? Extrinsic and common. So 3, 7, 10, 5, 2, and 1. So if that is working correctly, where's the problem? 12, 11, 9, 8. It's in the intrinsic arm. That's what we think. Let's move on. Thrombin clotting time within the reference interval. That tells you that fibrinogen is present in adequate quantity for clot formation. And notice that the concentration is 400 milligrams per DL, which is within the reference interval. How about FDPs? Within the reference interval, so there isn't any evidence of excessive clot lysis. So let's recoup. Platelet number is adequate, but function is abnormal. And that abnormal platelet function is also combined with a moderate factor deficiency in the intrinsic system. Got a thought? Von Willebrand's disease, right? Abnormal platelet function, lack of factor VIII activity. Review of the cascade again. Follow the bouncing ribbon. All right, platelet count and bleeding time. Normal platelet number but impaired function. Normal ACT but prolonged APTT means that we do have a factor deficiency in the intrinsic or common systems, but it's not severe. It's moderate, probably moderate to mild, in quotes. Normal one-stage prothrombin tells us that the extrinsic and common systems are working, which will lead us to a factor deficiency in the intrinsic system. We have normal fibrinogen concentration and thrombin clotting time, so clot formation, we ought to have enough fibrinogen there for clot formation. FDPs are within the reference interval, so there's no evidence of excessive clot lysis. So we have abnormal platelet function and intrinsic factor deficiency, von Willebrand's disease. And there are additional laboratory tests that you can do to quantitate von Willebrand's factor and factor VIII, or factor VIII related antigen. Case 3, are you all holding up pretty good? 2-year-old female Cocker Spaniel, indoor dog, petechia on mucous membranes and abdominal skin. What do you think of as involved with petechia? Thrombocytopenia, so we want to do a platelet count. Data, how about your platelets? Thrombocytopenia. What about the bleeding time? Prolonged, and what things will prolong the bleeding time? Inadequate number of platelets, which we have here, and abnormal platelet function. The activated clotting time test, what do you think at 130 seconds? It's prolonged. Where does the phospholipid come from to make the test run? Platelets, and what happens if you get severe thrombocytopenia? Prolonged ACT. Also, severe factor deficiency in the intrinsic and common system will prolong the ACT. But I probably would not run this test because it's dependent on phospholipid from platelets. Therefore, we want to do an APTT, which is independent of platelets, because we add the phospholipid. What about the test result? Within the reference interval. So the intrinsic and common system is okay. OSPT, 6.5. Within the reference interval. That tells you that the extrinsic system and common systems are okay. So factor 7 and 3, 10, 5, 2, and 1 are all right. Thrombin clotting time, 5.9 seconds. Within the reference interval. That tells you that you have enough fibrinogen for clot formation and we don't have to worry about any inhibitors. Fibrinogen concentration is within the reference interval. What about these FDP things? Fibrin degradation or fibrinogen degradation products within the reference interval. We don't have excessive clot lysis. Okay, what's your problem? Thrombocytopenia. Now we need to determine, have they been consumed, have they been destroyed, are they not being produced in the bone marrow? And again, the cascade. And what we would want to do is a bone marrow on this individual to see if it had decreased platelet production and megakaryocytes were adequate and they were mature. So that suggested that we were either consuming or destroying platelets. Prolonged bleeding time from too few platelets, prolonged ACT, lack of platelet phospholipid. Let's see. If the platelets, all right, one thing that I might point out in the thrombocytopenia, if the platelets are being consumed and they're turned over, but they're not being replaced in adequate numbers, look for a mean platelet volume. That may be helpful if it's increased when the platelets are turned over. This one, though, ended up being an immune-mediated thrombocytopenia on additional laboratory testing. So it was platelet destruction. Anybody here from the hills of Georgia and seen a blue tick hound? Okay, ticking on them. So we have an adult male blue tick hound, roams freely outdoors, missing for 2 to 3 days, comes home vomiting blood in the stool, lumps under the skin. The littermate, who's also been running, appears clinically normal. There is no history of previous hemorrhagic episodes with tooth eruption or anything else. Lumps under the skin, what might they be? Hematomas, good. Let's look at some data. How about platelets? How about platelet count? Mild thrombocytosis, so we've got enough platelets. How about the bleeding time? Within the reference interval, so we have enough platelets and they're functional. Bleeding time is okay. The ACT is dependent on platelets for phospholipid. We have a gracious plenty of them, but notice that the ACT is prolonged. So what does this suggest to you? A severe factor deficiency in the intrinsic or common system. So it involves 12, 11, 9, 8, 10, 5, 2, or 1. The activated partial thromboplastin time also prolonged. What this does, the APTT removes platelets from the equation, so we now definitely know that we have a factor deficiency or problem in the intrinsic or common, 12, 11, 9, 8, 10, 5, 2, or 1. Let's look at the one-stage prothrombin test. What about 11.2 seconds? Prolonged. What part of the coagulation cascade is evaluated? Extrinsic and common. So it says the problem is going to be with 7, 3, 10, 5, 2, or 1. All right, let's keep looking. What about the thrombin clotting time? 6.6 seconds. It's within the reference interval. It tells us we have adequate quantities of insoluble fibrinogen to make an insoluble fibrin clot. And notice that the fibrinogen concentration is within the reference interval. How about the FDPs at 16? Still within the reference interval. Sometimes if you get massive bleeding into body cavities, massive hematomas, you can have increased FDPs. All right, so let's review. Platelets are okay, bleeding time is okay. It appears that we have a severe factor deficiency that involves the intrinsic, extrinsic, and or common, other than factor 1. So fibrinogen is okay. The increased platelet count, those things tend to exclude DIC. Normal bleeding time, is this dog von Willebrand's? No, normal bleeding time. So I would be thinking of either an hereditary factor in the common system, 10, 5, or 2, or maybe a multiple factor deficiency. And the multiple factor deficiencies are usually acquired, correct? DIC should be consumption of platelets, 5, 8, and fibrinogen, and increased FDPs. FDPs are not increased. Fibrinogen has not been consumed. Platelets have not been consumed. What's the other common acquired multiple factor deficiency? Warfarin toxicosis, vitamin K inhibition. Which factors are the vitamin K factors? 2, from memory, 2, 7, 9, and 10. 2, 7, 9, and 10. 9 is intrinsic, 7 is extrinsic, 2 and 10 are common. What's your vote? All right, let's get the cascade out of the way. The vote is warfarin. Let's see how that works. Okay, again, increased platelets, normal function. We could have intrinsic, common, or extrinsic factor deficiency, but we're voting for warfarin. Normal thrombin clotting time and FDPs tend to put DIC on the back burner. Hereditary factor deficiency is unlikely because there are no previous bleeding episodes at a younger age. So this is advanced warfarin toxicosis. This is classical and fully developed. All right, in warfarin toxicosis, there are some other diagnostic tests that you can do. One of them is called a PIVKA test, P-I-V-K-A. It stands for proteins induced by vitamin K absence or vitamin K antagonism. And these are inactive proteins antigenically similar to factors 2, 7, 9, and 10. Actually, they they aren't carboxylated correctly so they can work. Okay? You can detect these altered inactive proteins increasing in concentration before the blood tests become abnormal. So PIVCA concentration, these proteins increase before you get prolongation of the prothrombin time or activated partial thromboplastin time, one-stage prothrombin time or APTT. What happens is vitamin K epoxide reductase is inhibited. Vitamin K epoxide concentration increases, these proteins increase. We could also do rodenticide toxicology for you tox people, which is expensive. But we have the smoking gun here. Okay, so that one was a classic, fully developed warfarin toxicosis. Let's see, this one's a female adult blue tick, roams freely out of doors, appears healthy, but the litter mate was bleeding. We just saw the litter mate. Question?
Did you explain the thrombocytosis?
Oh, okay. Whenever you get bleeding, massive internal bleeding, it's not unusual to get increased release or production of platelets. So it goes concurrently with stimulus for red cell production too, hand in hand. Let's look at the data on this individual. What about the platelet count? Within the reference interval. Within the reference interval. What about the bleeding time? Within the reference interval. Could this dog have von Willebrand's? No, the bleeding time is not prolonged. Let's look at the ACT, the activated clotting time. And what about 70 seconds? Within the reference interval. It's telling us that, well, we have adequate platelets for phospholipid. The ACT is saying there is no problem, severe problem, in the intrinsic or common systems. All right, how about the APTT? That's more sensitive. It's 16 seconds within the reference interval. So it's telling us that there is no problem in the intrinsic or common pathway. So that's saying 12, 11, 9, 8, 10, 5, 2, and 1 are okay. How about the one-stage prothrombin test? At 14.5 seconds, it is prolonged. So it measures the extrinsic and common systems. So where is the problem? Extrinsic, because we already know the common system works because it's part of the APTT. So it's the extrinsic system, and what two factors are there? 7 and 3, and which one do you not run out of as long as you're living and breathing? 3. So which one is deficient? 7. Very good. Let's look at the thrombin clotting time, 6.2 seconds. It's within the reference interval. Okay, so it tells us that factor 1 or fibrinogen is present in a great enough concentration for clot formation. Also, if you look at the fibrinogen concentration as measured by another method, it's 500 milligrams per DL, so we have a mild hyperfibrinogenemia. FDPs, we have a small quantity being produced, but not above the reference interval. So the problem is with factor 7, And let me ask you this. There is no previous episode of bleeding in this dog during its lifetime. Would you consider hereditary factor 7 deficiency? No. What would you think of then? Got a little bit of it. Yeah, a little bit of rodenticide, and the first test to go abnormal in the hemostasis profile is going to be the one-stage prothrombin test. Why? 7 has the shortest half-life. So what this shows you is early warfarin toxicosis. Yeah, question? The thing is, would I do additional testing or would I do quantitation of factors? Knowing me, taking the cheap way out, I would treat it with vitamin K1, aquamaphytin, and look for clinical improvement. The thing is with difascinone and some of the new generation rodenticides, you need to keep treatment up for sometimes weeks to even months. Okay, they're long acting. I'd take the cheap way out because when you start factor analysis, that's expensive. Rodenticide toxicology is expensive. And let me see, this may be the end of it. Nope, you want to do one more or you want to quit? One more? Okay, here you go. Here's your German Shepherd dog, 5 months old, hemothorax, deep muscle hematomas, previous bleeding during tooth eruption as a puppy, and bruises easily. What do you think? He's got a bleeding problem? Let's look at the data. How about platelet count? Within the reference interval. Bleeding time. Reference interval. So we know that platelet number and function is okay. What about activated clotting time? Prolonged. We have adequate platelets for phospholipids, so this tells us that we have a severe factor deficiency in the intrinsic or common system. 12, 11, 9, 8, 10, 5, 2, or 1. APTT is prolonged, again, intrinsic or common system. One-stage prothrombin time is within the reference interval, telling us that the extrinsic and common pathway work okay, so we have a problem in the intrinsic system. 12, 11, 9, 8. Thrombin clotting time is within the reference interval, so we have adequate fibrinogen for clot formation. Notice that we do have an increase in FDPs. We can see this with either DIC, but we don't have thrombocytopenia. Got it? We don't have prolongation of the OSPT, which doesn't fit DIC. We don't have consumption of fibrinogen. So probably these FDPs are from massive hematomas or internal body cavity bleeding. What would you be thinking? Could this one be a von Willebrand's? That's prevalent in German Shepherds. No, because the bleeding time is normal. So what are you thinking? Hemophilia. With factor 12 deficiency like John Hageman, you don't get clinical bleeding. Factor 11 deficiency may or may not bleed, but factor 9 and factor 8 do bleed. Okay? Normal platelet number and function, severe clotting factor deficiency that we've determined is the intrinsic arm. Adequate fibrinogen for clot formation. Again, consider hemophilia A or B. Factor 12 deficiency doesn't bleed, 11 is variable bleeding. So you need factor analysis to get that. And that one ended up being factor 8 deficiency, hemophilia A. So a lot of times when you're doing clotting profiles, because factor analysis is expensive, rodenticide toxicology testing is expensive, you need to sit down and do a cost versus benefit analysis. So, you know, if you suspect rodenticide toxicosis, easy thing to do clinically is treat with vitamin K1, see if you get a response. I love this sign, gas, regular 172.9 plus arm and 9/10, premium leg and 9/10. Well, thank you. You've been really good sports about tolerating me all day.